It's so great to see everyone. My name is Justin Groden. I'm one of the cardiologists here at UT Southwestern. I'm a heart failure specialist, and I think it goes without say that, I think it's safe to say that I speak for all of my colleagues that we're extremely delighted for those of you that made it here with us in person today and those of you that are listening online to have the opportunity to listen to what it is we do. Today, you're going to hear really an array or a menu of what we do. It's really just the tip of the iceberg. But you're going to hear discussions that span anything from genetic cardiomyopathies, amyloidosis, hypertrophic cardiomyopathy, and then we'll transition onto the management of more complex patients, such as those in the ICU that might be critically ill. And even what happens after that for individuals that need advanced heart failure therapies, such as LVAD, transplant. So, like I said, we're absolutely delighted that you're all here sharing your Saturday morning with us. We know that it takes a lot to get here, especially on a Saturday morning. And then to everybody that's a mother, I want to wish you an early happy Mother's Day. So I want to make a special mention that this course is officially endorsed by the HFSA. So there's a lot of information about the HFSA in your handout, but we're certainly happy that they've endorsed this symposium today. So, and I'd also like to mention that this symposium is eligible for both CNE and CME. There's information about that in your packets. So I'd also like to take a special moment to thank all of our speakers today for all their work and time that they've spent preparing all of their talks. And then I'd also like to take a moment to acknowledge a special thanks to our exhibitors, Abbott and Kiniksa. And then lastly, I'd like to ask you all to silence your cell phones, pagers, laptops, whatever makes noise, please kindly keep it to a minimum. Okay, so with that being said, I am the first speaker. So in addition to being a heart failure specialist, I also take care of a lot of patients with amyloidosis. And then along with my colleagues, Lori Roth and Sarah Talbot, we run the cardiac amyloidosis program here at UT Southwestern. And so the title of my talk is actually a haiku. So stabilizing, silencing, fibril depleting, ATTR is retreating. And if this is a little bit foreign to you, ATTR is a type of amyloidosis. And we will touch very early on what is the pathophysiology of the disease. But really, the goal of my talk this morning is to give you an outline. Now, it won't be comprehensive, but to give you an outline of all of these new and wonderful therapies that we're currently using to treat these patients. And I will also give you a preview of some therapies that are coming down the line. So yes, that was a haiku. These are my disclosures. And I will mention that I will briefly touch on some off-label therapies, diflunisal, doxycycline, tolcapone, and something called turo-ursodeoxycholic acid. Okay, so I hope you guys have all enjoyed your breakfast. This is a heart that was taken out of a human being. Okay, so for those of you that have never had the opportunity to see a heart that has been removed from a human, when you take a healthy heart out of someone and you put it on a table, it collapses under its own weight. It's kind of like you take, sorry for those of you that don't eat meat, and I know raw meat is kind of gross, but if you take a piece of chicken and you put it on a cutting board that hasn't been cooked, that always reminds me of what a healthy heart looks like. So a heart with amyloidosis is so stiff, when you put it on the back table, it stays expanded under its own, its structural stability is so stiff that it stays expanded, much like a racquetball. And that's what the surgeon is showing you here in this, in this image. Now, this is another heart that was taken out of a human with amyloidosis. And you can see here that amyloidosis is really characterized by substantial left ventricular thickening. That's this donut-shaped like part of the muscle. And then the right ventricle looks kind of like a teepee that is sitting on top of that in your screen. And you can see that it's very, very thick. So before we talk about treatments, I first want to talk about some useful principles about ATTR, and we'll review briefly ATTR pathophysiology. So the mechanism of transthyretin amyloidosis or amyloidogenesis is as follows. So about 99% of the transthyretin in the human body is made in the liver. And transthyretin is a portmanteau of the words transports and thyroxine and retinol. So really what it does is it transports thyroid hormone and vitamin A. So TTR circulates as a homotetramer, that means 4 identical pieces of protein. And when it becomes amyloidogenic, it then, we think, it breaks up into folded dimers, which then subsequently break up into folded, then misfolded monomers, which eventually start to aggregate in oligomers and deposit as mature ATTR fibrils, and then infiltrate organs, right? This is a heart failure and a cardiology conference, so the myocardium, and then gives us the classic cardiomyopathy that we see today. So how do we treat this disease? Well, there are really 2 methods currently, and both of these methods halt amyloidogenesis. So I'm going to touch on this multiple times throughout this discussion, but that is to say that they stop further amyloid formation. They don't necessarily reverse it or clear amyloid deposits that have occurred in the body. So one of the methods are the TTR silencers. So these are agents that halt the translation of TTR from DNA to protein. They get in the way of that. We have small interfering RNAs, antisense oligonucleotides, and I'll briefly touch on a future therapy that leverages CRISPR-Cas9 technology to do single base pair editing to edit the TTR gene and silence it permanently. And then another treatment strategy is to stabilize the TTR protein. So this keeps TTR from going through this amyloidogenic cascade. So we really have 2 agents, and I'll discuss them later in this talk, but we have molecules that bind to these thyroxine binding pockets. This is shown by the red dots here on the cartoon that I've shown you. And then we have molecular mimickers that mimic ultra-stabilizing mutations. Well, I did mention that most of our treatments halt the progression of the disease. Well, clearly when I'm seeing a patient, they're very interested in, how do I get this stuff out of me? Is this ever curable? So there are 2 methods to deplete amyloid deposits. Well, this is an advanced heart failure transplant talk, so clearly we could just cut the thing out and put it in the bucket. But we also have the promise of a number of agents that are in development that deplete or have the potential to deplete amyloid fibrils that have been deposited. These are monoclonal antibodies. So this is the outline for our discussion. I'm going to go through the majority of these, but it's not going to be completely comprehensive. But what I've shown you here is that there were a number of off-label therapies, and largely until 2018, this left-hand column was all we really had to treat patients with amyloidosis or ATTR. And the data that supports their efficacy was actually quite marginal. We've got a number of wonderful current therapies and then a number of therapies that are on the horizon. And then what I've done here is on the horizontal bar, on the horizontal rows, you can see that I've divided it into stabilizers, silencers, and depleters. And anytime you see a star, that denotes that these agents can be used for individuals with non-genetic ATTR or a genetic or hereditary form of ATTR called ATTR-V or variant. So really, I want to start this, I think, to illustrate some of the complexities when we decide treatment strategies. I want to start with a case, and then we're going to keep coming back to this case. And really, the case is this patient and her family. So this is a 75-year-old woman who has hereditary or variant ATTR. She's got cardiomyopathy, she has heart failure symptoms, polyneuropathy, and autonomic dysfunction. And what you see here is a demonstration of a positive technetium pyrophosphate scan, and this is the fusion image of the SPECT-CT that demonstrates uptake in the myocardium. And she does have a pathogenic allele and is heterozygous for the P60A mutation. So here's her family. So the pink dot or the pink arrow denotes our proband, and you can see that there are a number of affected family members, and it starts with this individual's mother, who had actually died in her 60s. There's our proband. And then she also had an older sister that died of cardiomyopathy and really life-limiting neuropathy. And this is a true family that Lori, Sarah, and I all follow. She has a younger sister with just cardiomyopathy and no neurological symptoms. Then her older sister who died has a son who is in his early 50s and just has cardiomyopathy. And then they have an older brother who is a carrier, but does not have any evidence of disease. And he has two daughters that are also carriers. So how would we treat this family in the past before a lot of these agents were approved? So as I mentioned, we really had a number of off-label therapies. And then the one I want to highlight, really just more for historical context, is diflunisal. So diflunisal is a typical NSAID, right? Most of us use it for arthritis, musculoskeletal pain. So we've observed through a number of basic science studies that it does bind to the thyroxine binding pockets on TTR, and it does confer tetrameric stability. So we posit that it does have some off-label benefits for ATTR amyloidosis. But of course, with all NSAIDs, when you're treating a patient with heart failure, there are certainly concerns with bleeding risk, kidney dysfunction, and worsening heart failure. So this was studied in a randomized controlled trial in individuals with hereditary ATTR and polyneuropathy. And what I'm showing here are neuropathy scores. So these are scales these are validated scales that assess the severity of neuropathy. And what this demonstrates is that individuals that were on diflunisal at 1 year and 2 years did better. Now, diflunisal never achieved an FDA label for this indication. So how would we treat this patient in the past? This family, a bunch of off-label diflunisal, and we would throw caution to the wind whether or not it was going to influence, their kidney dysfunction or provoke kidney dysfunction or worsen their heart failure symptoms. Now, what about the carriers? No clue. Okay, so how do we treat these individuals or individuals in this family currently? That's right, we are at now, and we just looked at then. Okay, so our current treatments are agents tafamidis, acoramidis, patisiran, inotersen, vutrisiran, and eplontersen. And I'm going to discuss these one by one in the next several minutes. So patisiran was actually a second generation silencing agent. It is a first generation siRNA. It was approved by the FDA in 2018. So this small interfering RNA controls gene expression, so it halts the hepatic production of TTR, and it targets what's called the 3' untranslated region of mRNA. So it kind of keeps the instructions from getting to the ribosome. And it is associated with a dose-dependent reduction in TTR. You can see after one dose, the TTR levels in these individuals drop by over 80%. Well, how does it work for cardiomyopathy? So this was studied in a small RCT. These data were presented in the New England Journal of Medicine. This is their primary endpoint, which was the median change in a 6-minute walk. And what it demonstrates here is that patisiran use over time in patients with ATTR was associated with better 6-minute walk scores. However, notice that none of these 6-minute walk scores get better. They all get worse. Now, these data were not robust enough for the FDA to allow a label for this agent. It is currently approved for ATTR polyneuropathy. So then a quick word about patisiran. So this is given as an infusion. It sits in a phospholipid envelope, and we give it every 3 weeks. Individuals do get infusion reactions, so they have to be pre-medicated with acetaminophen and H1, H2 blockers. And so now I want to pivot to vutrisiran, which is a more modern generation small interfering RNA. And its technology is a little bit different. It uses a GalNAc ligand that binds to a specific receptor in the hepatocytes. This causes the molecule to be very, very stable, has very, very high potency, and it has substantial long-term stability. This, unlike patisiran, can be given subcutaneously every 3 months. And so these are really pivotal data that were presented towards the end of 2024 in Europe at ESC. These are data from the Helios-B clinical trial that was a cardiovascular outcome study that randomly assigned placebo or vutrisiran to individuals with ATTR-CM, whether or not they had hereditary disease or wild-type disease. And you can see that it was associated with a lower risk of death or recurrent CV events over time. So now I want to pivot to the antisense oligonucleotides. And one of the early generation antisense oligonucleotides was inotersen. This, very similarly to the siRNAs, inhibits hepatic production of TTR by targeting mRNA. It too is associated with a dose-dependent reduction in TTR, and it also is given subcutaneously. And in patients with neuropathy, it does slow progression over time. This is demonstrated by these 2 serial neuropathy assessments. So now I want to pivot to the next generation molecule. Again, we don't really use inotersen. It has a black box warning for thrombocytopenia and glomerulonephritis. And then the company has largely abandoned the development in patients with cardiomyopathy. But the second generation of this molecule, which is really, really different, I really shouldn't even say it's the same molecule, is a drug called eplontersen. This, similar to vutrisiran, targets the liver by a special GalNAc ligand. Again, it's more stable, it has increased potency and substantial long-term stability. This is given subcutaneously once a month. And in patients with neuropathy, it too was associated with better symptomatology of neuropathy over time. It is currently being evaluated for patients with cardiomyopathy in the CardioTransform trial. This study has been completely enrolled, and we hope we get the readout sometime over the next year, year and a half. And now I want to pivot to really 2 game-changing medications as well that stabilize the TTR protein, that is tafamidis and acoramidis. So tafamidis is a benzoxole derivative that has no NSAID properties, unlike diflunisal. This was specially designed by Jeff Kelly in his lab to bind to the thyroxine binding pockets. And when this was evaluated in patients with ATTR-CM, whether or not they had hereditary ATTR or variant, you can see that its use was also associated with better outcomes over time, a lower risk of death and a lower risk of CV hospitalizations. But remember, a number of these patients are older, so this actually tends to be the most important slide that they look at. And that is to say that it is associated with a reduced rate of decline in quality of life and functional capacity. So these tend to be very, very meaningful. And this is very comparable to all agents that treat ATTR. I'm just not calling out tafamidis, is that you see these curves separate very, very early at 3 to 6 months. And now I want to pivot to acoramidis. So this is a little bit distinct from tafamidis in that it is also a TTR stabilizer, but it is more so a molecular mimicker that mimics an ultra-stabilizing mutation that has a more potent level of TTR stabilization. It too, when studied in patients with ATTR-CM, was associated with better outcomes by 30 months. So this is just data from their composite hierarchical endpoint assessed by a win ratio, and their primary endpoint was either death from any cause, CV-related hospitalizations, NT-proBNP, and 6-minute walk distance. And when you take out things that you say maybe might not be such hard clinical endpoints like biomarkers and 6-minute walk, you can see that even if we look at death from any cause and CV-related hospitalizations, the agent was still superior to placebo. So how do we treat this family now? Well, I guess it started to go through before I could hit the button. But for the individuals that have both cardiomyopathy and neuropathy, CM or PN, we can use any stabilizer or any silencer. They are all wonderful, great job for those of you that might work for some of these companies. They're all great. All these agents are safe. I have no idea which is better. For the individuals with cardiomyopathy, we currently have FDA-labeled approval for acoramidis, tafamidis, and vutrisiran. Now, what about the carriers? No idea. So how are we going to treat these families in the future? So I want to touch on 2 silencing agents. So as I did mention, the CardioTransform study, so this is a very, very large study. It will be the largest study of ATTR-CM patients to date. Again, hopefully we get the readout very, very soon. We enrolled a number of individuals here at UT Southwestern, and we'll see. So hopefully we'll find out if eplontersen will get an FDA label for cardiomyopathy. And then a very, very new trial that is coming down the road is testing a third generation silencing agent, or siRNA, called nucresiran, which is given once every 6 months. It has very, very potent TTR silencing, and currently site selection is underway. So now I want to pivot for the last portion of my discussion to two very, very novel therapies for ATTR, at least novel therapeutic concepts. The first is an agent called NTLA-2001. And now I will tell you this slide is somewhat outdated because this agent does have a name. It is called nexigeran ziclumeran, or we call it Nex-Z. You don't have to put that to memory, okay? It's very hard to say. Maybe that's on purpose. So this leverages a bacterial-based method of, so a Cas RNA that originated from bacteria that causes single base pair editing that permanently silences the TTR gene. So this is delivered in a phospholipid envelope through an infusion. Patients get it once, and this edits the TTR gene in hepatocytes. So these molecules are opsonized by receptors on the hepatocyte, as I mentioned. The positive part about this is you can give it one time. So these are data from the phase 1 trial that demonstrates that just 1 4-hour infusion of NTLA-2001, or Nex-Z, is associated with a substantial reduction in circulating TTR levels over time. Now, these data track out now to 2 years. So one dose lasts over 2 years. So we are currently enrolling in this study. There's a large CV outcome study that is assessing patients with both wild type and hereditary ATTR-CM. Now, in the interest of time, I'm not going to go through it in more detail, but now I want to touch on a very unique method of treating amyloidosis. And this is one that hopefully might offer a cure, or might offer the possibility of depleting amyloid deposits in the myocardium. So this is a molecule that's a monoclonal antibody called NI006, or also known as ALXN2220. You don't have to remember that. So Alexion, which is a subsidiary of AstraZeneca, is evaluating this molecule in a phase 3 clinical trial. So this figure that I'm showing you is a histological specimen of a mouse or mice engrafted with ATTR tissue that are then administered this monoclonal antibody. And what you see with increasing doses, you can see that this brown stuff, which is all ATTR, these deposits actually get better. So this was identified through high throughput screening of human B cell libraries. And this monoclonal antibody has very, very high affinity to binding to ATTR. This was also studied in a phase 1 study. And you can see here what it demonstrates is pretty remarkable that by 4 months and 12 months, these individuals had imaging evidence of less amyloid in their body. So this is by both tracer uptake and by something we call ECV, which is an MRI-based way of assessing amyloid load in the myocardium. And so these are some scintigraphic images that just demonstrate that demonstrate this concept. You can see this person at the top was given this drug at baseline, and you can see his PYP scan is starting to clear. And then this person on the bottom was given placebo, and as soon as he crossed over, you can see that he started to have drug effect. So this is currently being studied also in a phase 3 RCT. We enrolled 5 people here. Now, as you can imagine, so many patients were enthusiastic about enrolling in this study, and it has actually over-enrolled, which is pretty remarkable, and it enrolled in record time. So there are some studies that are deep on the horizon. There's another monoclonal antibody called coramitug that's currently being developed by Novo Nordisk. And then, I briefly touched on prevention for carriers. There's a study by Bridge Bio called ACT Early that is testing the hypothesis that acoramidis may prevent amyloid heart disease. So how could we treat this family in the future? Well, we could use anything, hopefully, anywhere from any of the silencing agents to the stabilizing agents, and then maybe a depleter. Now, how would we use the two? We really don't know. I suspect that most individuals will have to be on something that stops amyloid production or halts amyloid production, and then they might be on some cycle of a depleting agent. They might not need that indefinitely. And then we'll see, maybe if acoramidis proves to be beneficial in carriers, we might also be using that as well. So that's my last slide. I'd like to thank you for your attention, and then we'll have a discussion session after the next talk, and I'd be happy to answer any questions. So I do want to announce our next speaker. So Dr. Natalie Tapaskar is originally from Chicago, like the new Pope, and and so she's she's in her first year with us at UT Southwestern and does some really terrific work in HCM and has really taken the lead in further developing our already established HCMA Center of Excellence.
Okay, we'll leave it to Dr. Grodin for a great introduction there. So my talk will be about HCM and cutting edge therapies. And I'm going to try to cram as much information as possible into the 20 minutes. Sorry if I speak fast, but we've got a lot to cover. So we'll cover what is HCM, what's the natural history of the disease, who's at highest risk of death, how do we treat it? This is an advanced heart failure conference, so what does that mean for HCM patients? And then finally, what's on the horizon? So HCM is defined as left ventricular hypertrophy that's out of proportion to increased afterload. So it's maximal end diastolic wall thickness of at least 15 millimeters anywhere in the left ventricle. You can also meet the definition if you have LVH between 13 and 14 millimeters, if you have a family member who's diagnosed with HCM, or if you have a pathogenic or likely pathogenic sarcomeric variant. There are a lot of features to HCM and it's highly variable, but hypercontractility is the main one. And then systolic anterior motion of the mitral valve, elongated mitral valve leaflets, hypertrophied PAP muscles, and many others that we just won't go into. HCM is highly prevalent, so it's 1 out of 200 to 1 out of 500 people worldwide. 30 to 60% of people will have an identifiable sarcomeric variant on genetic testing that are in 8 common genes. The diagnosis, however, does not require a family history of HCM or positive genetic testing. And there's thought to be an equal distribution by sex, although women tend to be diagnosed less commonly and later in life than men for a variety of reasons. The 2 main classifications of HCM are obstructive and non-obstructive. Obstructive is about 70% of patients and non-obstructive is 30%. So LVOT obstruction is defined as at least 30 millimeters of mercury across the LV outflow tract. We generally think of symptoms occurring greater than 50, but that's not true for everyone. And that's the threshold that we use for septal reduction therapies and for cardiac myosin inhibitors. Let's see if this video will play for you. There we go. Okay. An LVOT obstruction is dynamic. It's sensitive to preload, afterload, and contractility. And if you don't get an LVOT obstruction of at least 30 millimeters mercury, you're encouraged to do provocative maneuvers on the patient to elicit higher gradients. So at the cellular level, HCM is defined by cardiac myocytes that are hypertrophied, disorganized, and separated by interstitial fibrosis. So panel A is normal myocardium, and then panel D is dense interstitial fibrosis in blue. So what's the natural history of HCM? Well, it's got a very wide phenotypic expression and wide symptom burden. We generally think that there's a higher lifelong risk of adverse events such as AFib, ventricular arrhythmias, heart failure, stroke, and mortality in patients who, 1, either have a pathogenic or likely pathogenic sarcomeric variant, or 2, patients that are diagnosed earlier in life. The clinical spectrum, like I mentioned, is extremely wide. So it ranges from patients who are just diagnosed, incidentally or on family screening with a positive genotype, but they have no clinical evidence of disease, so they're considered phenotype negative. And then there are those that are phenotype positive, and this can range from obstructive disease, non-obstructive with a preserved EF, advanced heart failure, arrhythmias, and sudden cardiac death. There are a lot of mechanisms for how patients have symptoms with HCM, but these are kind of the 6 main ones. So dynamic LVOT obstruction, mitral regurgitation either from SAM or primary mitral valve disease, metabolic, energetic, and autonomic dysfunction, diastolic dysfunction, arrhythmias, and myocardial ischemia, both traditional epicardial disease and microvascular disease as well. Looks kind of funny, but the main middle point is supposed to say decreased peak VO2 in HCM is associated with increased mortality, increased morbidity, and decreased quality of life. And this is peak oxygen uptake is really an important metric and a gold standard for cardiorespiratory fitness in HCM. And you'll see that in a lot of the trials that we'll talk about, that that's one of the primary endpoints. So who's at the highest risk of death? So this was a really interesting study from a Danish cohort, about 3,000 patients with HCM who were diagnosed between 2007 and 2018. And they found that across the age spectrum, as you get older, your risk of 5-year death increased with age compared to the general population. And then the guidelines tell us that it's incredibly important to risk stratify patients for arrhythmogenic related death. So it's a class 1 indication to get an ICD if you've had a prior sudden cardiac death event, VF, or sustained VT. If you don't meet that criteria, then there are 5 other high-risk features you can use to decide on ICD placement. The first is a family history of sudden death. The second is massive LVH, which is defined as at least 30 millimeters of mercury, so 30 millimeters, unexplained syncope, apical aneurysm, and an EF less than 50%. If you don't meet any of those criteria, you can use NSVT or extensive scar on an MRI as ancillary features to decide on ICD. So how do we treat this disease? Well, from a historical perspective, we've known about HCM since the 1860s in France. So we've known about it for a long time. Since the 1960s, we've traditionally just used beta blockers to reduce gradients and symptoms. We did the first myectomy in 1964, and then calcium channel blockers came about in the 70s and 80s, and then septal ablation in the 90s. And then disopyramide was used in the 2000s. And then finally, cardiac myosin inhibitors were invented in 2011 range, and mavacamten was FDA approved in 2022. So why did we develop cardiac, or I didn't develop it, but why did people develop cardiac myosin inhibitors? Well, the idea was that conventional therapies, beta blockers, calcium blockers, disopyramide, they really weren't effective globally for everyone with HCM. They can be poorly tolerated. Their use is based on underpowered, short follow-up, and non-randomized studies that kind of have mixed results. And they don't really alter the underlying pathophysiology of the disease itself. And so cardiac myosin inhibitors were then created. And to understand why we use them and how they work, we have to first remind ourselves how the sarcomere contracts. So myosin lives in 3 states. It's a super relaxed state, a disordered relaxed state, and an actin activated state. So when myosin's in the super relaxed state, the myosin heads don't interact with actin, they're not involved in cross-bridge cycling, and there's no muscle contractility happening. When you have a causative sarcomeric variant, you end up destabilizing the super relaxed off state. So you have more myosin actin interactions or more ores in the water, and you get hypercontractility. So mavacamten reduces the myosin head availability, stabilizes that super relaxed state. You get fewer myosin actin ores or cross bridges, and then contractility is normalized. So these are some of the key trials. We won't talk about all of them. We'll just pick a few. So the first one is Explore HCM. So this was a mavacamten trial that included just obstructive HCM patients, so a gradient of at least 50 with an EF more than 55%. And the main endpoint of this trial was to see if mavacamten would improve peak VO2 and improve quality of life scores. And it did meet that primary endpoint. So a 1.5 point increase in peak VO2 or a 1 point increase in NYHA class or a 3 point increase in peak VO2 with no worsening of NYHA class was the main endpoint. And 37% of the patients in the mavacamten group did meet the primary endpoint. Only 17% in the placebo group met that, and that was statistically different. And mavacamten did impressively reduce gradients as well, both at rest and with exercise. The red is placebo and the blue is mavacamten, and you can see that even after just 4 weeks of the drug, gradients really significantly reduced, and they continued to reduce, and they stayed low over the 30 weeks of the trial. Mavacamten also improved cardiac biomarkers, so both troponin and NT-proBNP reduced significantly over the 30 weeks. And then it really had a minimal impact on ejection fraction. So there were a few patients in the trial who needed to stop the drug temporarily for their EFs dropping below 50%, but they normalized after the drug was taken away and they're able to resume the treatment. And then when we look at quality of life, the blue bar represents NYHA class 1. And at the beginning of the trial, none of the patients were NYHA class 1. And by the end of the 30 weeks, almost 50% of the mavacamten group were NYHA class 1. So pretty impressive. And then when we compare Explore-HCM to a bunch of other heart failure trials, MADIT-CRT, DAPA-HF, really big trials, we say that it really surpasses the others in terms of mean difference in KCCQ. I don't really know much about football, but my husband told me this would be a good image to show you guys. So. Okay, next. So another question you'll get from patients is, do I have to take the drug forever? And I don't know if we know the answer, but the trial does show us that when you stop the drug, their KCCQ scores do go down to back where they started. Maybe there's a signal for even worse, but it does seem you need to continue the therapy to receive the benefit. And then when you look at the long-term extension of mavacamten, so over 180 weeks, you see that the gradients stay low. Both LVOT and Valsalva gradients are significantly reduced over time. And I think this is probably one of the most interesting things. This was an Explorer sub-study of 35 patients. When you look at their MRIs pre and post, there does seem to be a signal for a change in the structure, the underlying structure of the myocardium. There's reduced LV mass index, reduced LV wall thickness, reduced left atrial size. No changes in fibrosis as far as we know, but you definitely see a difference in the morphology of the ventricle. So next we'll talk about VALOR-HCM very briefly. So this is another mavacamten trial. This is in sicker patients. So these were all patients who were NYHA 3 or 4 to begin with, or those who'd had syncope, and they'd all been referred for septal reduction therapy in the last 12 months, and they had to be actively considering it to be part of the trial. And the primary endpoint for this trial was, would patients still be eligible or still want to get septal reduction therapy? And in the mavacamten group, only 14% still remained eligible for septal reduction therapy at the end of the trial, whereas 70% of the placebo group were still eligible. And then when we look at long-term extension data, about a quarter of the patients were able to streamline their background HCM therapy and just remained on beta blockers, so pretty impressive. All right, finally, Sequoia is another trial for cardiac myosin inhibitor. This is for aficamten. And it also showed really substantial and similar improvements in all of the metrics we talked about. So it improved peak VO2, it improved KCCQ scores, it improved NYHA class, and reduced biomarkers. So in terms of safety of cardiac myosin inhibitors, there's no head-to-head trial, so we don't really know the answer. They seem to be equally safe. They have slightly different mechanisms of action. Aficamten does have a wider therapeutic window and a shorter half-life, and it's got a better CYP profile, so there's potential for less drug-drug interactions. But looking at some of the adverse events, some of the percentages might seem a little bit different, but it's hard to know if these are significant without a head-to-head trial. And then in terms of efficacy, they both really substantially improve exercise capacity and symptom burden, so they seem equally efficacious. I think this is a pretty interesting sub-study which asks the question if your genetic status matters for how effective mavacamten will be. And so looking at patients who are genotype negative, mavacamten was equally effective in reducing gradients, peak VO2, and NYHA class. So there are lots of gaps in our knowledge about cardiac myosin inhibitors. A lot on the slide I'll let you read, but I think the main ones are, should we start them before we start beta blockers and calcium channel blockers? I think that's a question we all have, and there is a study ongoing to answer that question. A lot of the patients in these studies were largely Caucasian populations, so we need to understand these drugs in different groups. And then what about patients who have a lot of pulmonary hypertension? Can the RV handle it, or a lot of fibrosis? I don't think we really know the answers to those questions. So what do the guidelines tell us? Well, they tell us first class 1 indication is to start a beta blocker of verapamil or diltiazem for obstructive HCM. Then if you still have persistent symptoms, then you can try a myosin inhibitor, disopyramide, or go to septal reduction therapy, kind of all equivalent class 1 indication. So septal reduction therapies are generally considered for those who are drug refractory. Septal myectomies can alleviate gradients at any level within the ventricle. They're thought to have a pretty low mortality rate and pretty high clinical success if they're done at a high volume center. Alcohol septal ablation is another option for those that don't want surgery or can't have surgery. It does require appropriate coronary anatomy, and it's thought to be less effective if you have higher gradients or higher wall thickness. There is a slightly greater risk of a pacemaker, and the 10-year survival is a little bit lower. So this is data from the SHARE registry, which incorporated 10,000 patients from many high-volume HCM centers. And they found that about 13% of patients underwent myectomies and about 5% underwent ablations. And 7 years of follow-up later, they found that 21% of patients developed de novo AFib after their septal reduction therapy, and 13% developed composite heart failure outcomes. So there is definitely a dramatic improvement in symptoms initially after septal reduction therapy, but there's a cohort of patients that will have an ongoing cardiomyopathic process, which will lead to new AFib or heart failure. And interestingly, female patients had a higher risk of that composite heart failure outcome. So what about non-obstructive HCM? So unfortunately, just last month, the Odyssey HCM trial ended because mavacamten didn't meet its primary endpoint for changing peak VO2 or KCCQ scores in non-obstructive HCM patients. And so the guidelines tell us that class 1, we can try beta blockers or calcium channel blockers if patients are symptomatic. If they're persistently symptomatic, we can try some oral diuretics. If they're asymptomatic, we don't really know if we should treat them. Guidelines kind of give a 2B indication for a beta blocker or calcium channel blocker. And then there's one small study called the VANISH trial that looked at really young patients with HCM. The average age was 23. They all had kind of mild phenotypes and they had sarcomere variants. And there was a signal for valsartan maybe improving some cardiac remodeling metrics. So potentially an option if your patient is young. So what about HCM and advanced heart failure? So the definition of advanced heart failure in HCM is an EF less than 50%. This accounts for about 5 to 7% of HCM patients. And once they reach an EF less than 35%, that's a particularly high risk population. And the treatment is our traditional 4 pillars of GDMT. You can also consider CRT or ICD using some of the other metrics we talked about before. The guidelines tell us it's a class 1 indication to use a CPET to quantify their functional limitation and to select them for transplant. And then if they're refractory to maximum medical therapy, then it's a class 1 indication to evaluate for transplant according to current practices. This was a UNOS analysis from 2013 to 2022 that looked at all of the heart transplants in the US and found that 3% of them were done for a diagnosis of HCM. And interestingly, the HCM patients did have lower cardiac indices and slightly higher PVRs than all of the other patients undergoing transplant. And those were both statistically significant. And HCM patients who do undergo transplant, they have really excellent 1-year survival, no different than any other patient undergoing transplant. The guidelines also interestingly give a 2A indication for consideration of an LVAD as a bridge to transplant for HCM. Obviously, there's lots of concerns with LVAD, mostly the inflow cannula traversing a hypertrophied myocardium and a hypertrophied PAP muscles, which can lead to cannula obstruction and suction events, arrhythmias, thromboses, RV dysfunction, all of the possible bad outcomes. And so as you can imagine, it's not done very often. And so this was an INTERMAC study from 2008 to 2014 that found there were only 94 LVADs that were implanted for HCM as the underlying diagnosis. And most of them had this kind of quote unquote burnt out phenotype, which is an EF that's less than 40% and an average LVEDD that was 6 centimeters. And they tended to be younger and less sick than other patients implanted with LVADs. But they did have a similar 1-year survival. However, when you stratify the HCM patients based on LV size, you find that those that started with a pre-LVAD LV end diastolic diameter of less than 5 centimeters had a substantially worse mortality compared to those who had higher LV end diastolic diameters, which makes sense for all the reasons we just talked about. So finally, what's on the horizon? So there are some new minimally invasive procedures that are available. There's radiofrequency ablation for burning some of the hypertrophied myocardium. There's transcatheter myotomies and myectomies, and they have shown some good early results for obstructive HCM. Then there are other drugs that are available. So this one's currently being studied in the Cirrus HCM trial. It's EDG 7500, which is a cardiac sarcomere modulator. It works in low calcium conditions, so more in diastole, so theoretically has less of an effect on ejection fraction. And in some early trials, a single dose reduced gradients in 2 hours and seemed to be fully reversible. And there are even some metrics for improving KCCQ and diastology in non-obstructive HCM patients as well. And then finally, so gene therapy always seems to be the final frontier. And so we talked about 30 to 60% of HCM patients will have a genetic variant, and the most common is MYBPC3, which is the thick filament of the sarcomere. And so many of those variants truncate the protein. And so gene replacement can be used in these patients who have a gene that truncates a protein and can be replaced. So this is the MyPeak-1 trial that's currently enrolling across a few sites in the US. And they use a TN201 gene therapy, which is a transgene of MYBPC3. It's a first-in-human open-label trial that is just dosing and safety at this point and has a 5-year follow-up. And the idea is that they incorporate the working MYBPC3 gene into an adenovirus viral capsid, and they administer it as a one-time IV infusion to the patients, delivering the working gene to the sarcomeres. And so there are lots of challenges and opportunities with gene therapy. You know, for those of you that are basic scientists, you can read all of these things. But I think for those of us that are clinicians, the main question here really is, you know, who should receive these therapies? You know, 30 to 60% of patients will have a genetic diagnosis. So when should we treat them if gene therapy pans out to be safe and efficacious? Should it be for those that have positive genetic testing but don't have the disease yet? Or should it be for patients that have actually developed the disease? I think that's the main clinical question we don't have the answer to. So the take-home points here are that HCM is highly prevalent. It's 1 in 200 to 1 in 500 worldwide. Cardiac myosin inhibitors are effective and potentially disease-modifying for obstructive HCM. They reduce the need for invasive procedures. We still don't know what to do about non-obstructive HCM. They're a very symptomatic population, and we don't have a lot of therapies. There is an ongoing SGLT2 trial. There are no trials for MRAs. And then for obstructive HCM, we also have these new transcatheter approaches that seem promising. Gene therapies are actively being studied, but finally, at the end of the day, heart transplant is really kind of the final gold standard pathway for those with HCM and advanced heart failure. So this is our large multidisciplinary HCM team here at UT Southwestern. We are a center of excellence, and it's not possible to take care of these patients without everyone on this slide. So thank you. And then next I'll call up Lori Roth and Aaron Davidson to be part of our panel discussion.
Okay, well, I have a question. Unless you want, oh, you want to introduce folks first.
Is the PA experience, advanced heart failure, and also works with me in managing our patients with cardiac amyloidosis. Aaron Davidson, I don't know that well, but is a pharmacist and is currently working with Natalie, and really is kind of knee deep in all the ins and outs of administering some of these novel agents for HCM, such as Medicare. So this also gives us an opportunity where we'll have discussions amongst ourselves, but certainly any of you that are at home or those of you in the audience, if you have a question, please feel free to ask.
Well, I'm going to get started. Okay, so a patient comes to the clinic, they've been referred, they have diabetes, and there is some component of neuropathy. They've had uncontrolled hypertension for a good while, but their heart is thick, and there's this question about, is this hypertrophic cardiomyopathy non-obstructive, or is this amyloid? And what's first, second, third thing that you do to make the right diagnosis?
There we go. Okay. I guess that brings up the question of potentially like a genotype first strategy in diagnosing these patients. I mean, probably some imaging, like a cardiac MRI would give you some insight for HC. I mean, if Dr. Tapaskar and Groden agree, as far as, you know, what type of disease process the myocardium we're dealing with. And then potentially, you know, cardiac MRI combined with genetic testing would be a good start to see if we get any classic TTR you know, genetic abnormalities versus something that might be more classic for HCM. think would be a good starting place.
Yeah, and I think, with a lot of these diseases, there are also clues. There are some red flags that you can see in the patient's history. In fact, I tell a lot of our residents and fellows that amyloidosis is really not all that hard to diagnose, neither is HCM. I think what is really, pardon me, the rate limiting step is you have to think about it as a diagnosis. So there's some really simple clues in a patient's history that might heighten your index of suspicion that they have amyloid heart disease, for example. And I'll let Natalie talk more about HCM. But do they have some red flags, such as bilateral carpal tunnel syndrome? We know that this is very, very common in patients with cardiac amyloidosis. Do they have thickening of their myocardium that might be disproportionate to their degree of hypertension, or they might have neuropathy that is disproportionate to their degree of or severity of diabetes. Somebody with hypertrophic cardiomyopathy that's diagnosed older than the age of 60 years old. Or if somebody, and this tends to be a lot more specific for individuals with ATTR amyloidosis, did they have a tendon rupture, such as a long biceps tendon rupture? So all of these can really serve as clues and risk enhancers to then guide us, that might inform some of the further testing that we order that might serve as clues that this person could have amyloidosis.
Yeah, I agree with everything that these two have said. I think we didn't really talk about it that much, but there are other phenocopies for HCM, certain things you should rule out, like Fabry's disease. So I think starting with an MRI is very important, like Lori mentioned, and I tend to send everyone for genetic testing just up front. One of the key diagnostic features of HCM is that LV hypertrophy outer proportion to afterload, but that's not to say HCM patients can't have aortic stenosis. I mean, they're both diseases of an aging population, so they're both common, or have hypertension like we're mentioning. So it is important to quantify the hypertrophy and assess for other diagnoses as well. So genetic testing, I think, is very appropriate. An MRI, I always get echoes and ask for, eliciting gradients. And then depending on the patient's age, I might also just send them for a Holter monitor up front to assess for any arrhythmias that can help you tease out the diagnosis too.
So Aaron, I have a question for you. So really, can you tell us what your role is in the day-to-day management or week-to-week management in administering some of these therapies for hypertrophic cardiomyopathy?
So right now with the CMI, the drug interactions, that's been a big thing. And it's really important because some of these drugs are available over the counter. So educating the patients to let us know, are you starting something new? Do we need to adjust your dose? There's been some updating to labeling. So that's going to drive some probably changes in what we do. Do we decide to change the offending agent? Do we adjust the dose of the CMI and dealing with that and talking to the patients, like what to expect from the medication timeframes? We get a lot of questions. Well, I just changed the dose. Why don't I feel better today? Talking about like the half-life, how long the drug takes effect in dealing with the patients. I've also been really involved in like the monitoring. They have to get echoes on a regular window, discussing what that means. Thankfully, again, we had a label update so we can extend that monitoring, but still have to talk to those patients about the label update. Like, why is that okay now? We've been doing this for 3 years. Why all of a sudden can I extend that? And what should I be looking for in between visits? When should I call? And some of those are very important things. And then also, these are specialty drugs, and a lot of times patients haven't dealt with the specialty pharmacy. They think they can get it at their local pharmacy, and talking about that process with them.
Oh, I want to jump in here for a second. So we have 82 people online, and please, we encourage you to ask questions, but there are 2 questions that came up. Okay. So the first is, we're going to start with wild type. And wild type ATTR, if they have severe neuropathy and are on a stabilizer, how do you treat the neuropathy?
We send them to a neurologist.
Spoken like a true cardiologist.
No, I think the question is, do we change our therapy? So I think, first of all, it is, we do know that, I mean, we didn't go into if we wanted to talk about all the pathophysiology and all the diversity in amyloidosis, we could probably spend several days doing that. But amyloidosis is a prototypical disease, and like HCM, where, I think Lori alluded to this. It's really a disease with where the genotype can certainly influence the phenotype. In other words, knowing somebody's mutation can translate to what you may or may not expect their disease to present as. And in amyloidosis, it can give you a clue as to whether or not you would expect a lot of cardiomyopathy or a lot of neuropathy. And then we've got some genotypes, much like the example that I gave you, that has both. So wild type ATTR, which is non-hereditary, we think right now is more so a disease related to aging, or perhaps it's an aging disease that might be related to proteostasis. So they don't experience much neuropathy at all, but there are individuals that do. And so the question is do we modify our therapy? And right now there are no data to support that we modify the therapy with, if they're currently on tafamidis. And as it turns out, the silencers had a historical indication to treat ATTR polyneuropathy. Eplontersen still has that. And it's largely an artifact of the label. None of these agents necessarily work on the organs. As I've demonstrated, they really work on the protein outside of the fibril depleters. So it's not that we don't think these agents don't work. In other words, tafamidis may or may not work for neuropathy. It just wasn't studied in that population. Now in Europe, they did approve a lower dose of tafamidis to treat ATTR polyneuropathy, but we treat individuals with a higher dose, which is 80 milligrams as opposed to 20. So in our practice, we don't really switch people. We keep them on their drug.
Okay, so you took the bait. Okay, part two of this question, I think you did. In patients with hereditary or variant TTR who has neuropathy as well as cardiomyopathy, do you ever use both a silencer and a stabilizer?
That's a great question. We don't really know the answer to that, if that's the best strategy. I can't say that we've done that in our practice, and we don't really know.
Well, I mean, outside of clinical trials.
Sorry, yes, outside of that, of course.
And then we do have one special case where we do use both agents on purpose. I don't know, Lori, do you want to give the one-liner on that patient?
Oh, sure. This is a young patient and he has really significant leptomeningeal involvement with a very neuropathic TTR variant. So we started him on silencer medication, and then also knowing that tafamidis crosses the blood-brain barrier also got him, actually Dr. Groden worked really hard to get him free tafamidis from the company. So we got him on both. So he's a rare exception that we have him on combination therapy, whereas we don't do this as our regular practice because we're not really sure how to navigate that space.
No, but yeah, and it stands to reason, right? I mean, you're going to hear all throughout the day probably about a number of combination therapies that are very prevalent in medication. So I think it's very natural to think that a combination ATTR therapy might be better than the single agents alone. And it's really, really not clear. We don't have any comparative effectiveness. And really all these clinical trials, they exist in vacuums. The risk of death is different in every single study in which these agents were tested. So, but what we will probably be doing is combining these agents with something that depletes ATTR fibril deposits.
Okay, now we're going to turn to hypertrophic cardiomyopathy. If anyone else has a question, please jump ahead. Okay, all right. So, Dr. Tapaskar, two questions here. First one is, how does age, for example, 35 versus 70 years old, impact on the use of primary prevention defibrillator for hypertrophic cardiomyopathy for those with well-controlled symptoms and gradients?
That's a really good question. And that's often a topic in our monthly meetings. So generally, we feel like if you've reached the ripe old age of whatever it was that you said, that and they haven't had an arrhythmic event, they're probably not going to have an arrhythmic event that's going to cause sudden cardiac death. Every electrophysiology team will be a little bit different, but we generally feel like around 40, 50 years old, if you're not seeing any, evidence of, ventricular arrhythmias, fast VT, frequent events, that your risk is likely reduced over time. But it's a case-by-case discussion. Obviously, there are exceptions to that rule, but if you've made it to, seventh decade of life, at that point, we're generally not implanting primary prevention ICDs.
Staying with you and your group, tell us a little bit more about the development of pulmonary hypertension in the context of hypertrophic cardiomyopathy, and how that plays a role both in symptoms and then if ultimately needing advanced therapies and the complications that can occur.
Yeah, that's a really good question. When we looked at that UNOS analysis, patients with HCM who underwent transplant did have higher PVRs than all the other transplanted patients. When you look at the actual numbers, the PVR difference it's like 2.3 versus 2.1. So like numerically, it doesn't, is that really clinically a difference? I would say that it's something you always have to be aware of. Massive hypertrophy that's gone unchecked for years can eventually develop pulmonary hypertension, RV dysfunction, heart failure. They're just a higher risk population. I'm not sure if we know how to predict that's going to happen. Females tend to be underdiagnosed and can present with more advanced disease. So that might be a higher risk population. And then those who are diagnosed early in life, you really do have to watch them because there's a theoretical risk if you're diagnosed earlier, you'll have a slightly higher risk phenotype. But they're a high risk patient population. They're not huge, but they do exist.
So I've got a question for Aaron and then Lori, and I think it's really kind of the same theme of the question. So a number of these therapies, you really can't just go to your neighborhood pharmacy and go pick up and call in. And so I wondered if maybe each of you could highlight some of the logistics of acquiring some of these medications. So, some of the cardiomyocyte inhibitors, some of the amyloid therapies. So Aaron, why don't you go ahead?
So one, utilize whoever you have from the pharma companies to help you navigate some of these things. They've been super helpful. Usually there's limited distribution, so you have to find out like, okay, so which specialty pharmacies can dispense it, and understanding for a patient's insurance, which is where I come in sometimes too, is which pharmacy can they utilize, and going through that, and also for talking to the patients about this, because they're like, well, what do you mean I can't get it at my local pharmacy? And explaining like they have to overnight it, you have to be there. Those kind of things are things, and they have to discuss like, okay, we need to stay on top of this. Specialty pharmacies, the way they work, though, they help the patient stay on top of it. They call them 7 days before, see how many pills they have left, and help them stay on top of it. The hardest thing with the cardiac myosin inhibitors is that the echo data has to be submitted before they can refill for a lot of, or like if they're titrating, if they're new starts. So that can be a holdup that they're trying to get a dispense before we can do that. Talking to the patients and preparing them for this is something that we do at the very beginning. Expectations for these medications really help the patient succeed in the long run, because then they also know, who do I talk to? I'm confused about something. Do I have new insurance? We've dealt with that, a bunch of times where we have to change specialty pharmacies. Telling them, please answer your phone with these random phone numbers so we can get the medication in a timely manner. Most of my work is with the cardiac myosin inhibitor, so I'll let Lori talk about their agents and what kind of struggles they have with those too.
Yeah, I mean, it's similar. We tell all of our patients it's a process when we start these drugs. We say you can't just the same thing. You have to get it through a specialty pharmacy. You can't just go to your Walgreens or CVS and get it from there. I guess the biggest thing is setting expectations and letting them know it's going to be a process for approval and for them to be able to get it affordably. So that's a big part of it. And then we do use, fortunately, I think the pharma companies are great because a lot of them have their own specialty pharmacy set up with the drug that they can use. We also use our own specialty pharmacy here at Southwestern, which is great. And they kind of figure out, who the patient needs to get drug through. So that's for our oral medications that we primarily use our specialty pharmacy, and those are dispensed that way. For vutrisiran and the injectable drugs, that's, usually a different story. And vutrisiran in particular has to go through an infusion company or an infusion center to have it administered. So that's where it gets a little bit different. But yeah, I think it's setting expectations. It's all of those things that you already mentioned.
Lori, do you think you could tell us a little bit specifically about, now vutrisiran has an on-label indication for cardiomyopathy, but what was it like prescribing this medication before? And is there, maybe a little bit about vitamin A as well in that discussion?
Oh, sure. So we've classically used vutrisiran, and we've used now eplontersen some for our polyneuropathy patients. So previously with indication of hereditary ATTR with a confirmed polyneuropathy. We always had to make sure that the patient, typically they saw a neurologist before they got the drug, or that all those things were submitted. They had neurological testing, saw a neurologist, and kind of checked all the boxes before we submitted for those drugs. So, so that process, we kind of nailed down a little. It was a little bit tricky. As far as obtaining them, so eplontersen is a medication patients can actually self-administer at home. So that's sometimes an advantage for patients if they have, that's for, the only indication right now is hereditary and for polyneuropathy. But patients can get that drug at home, which sometimes is an advantage. It's a once monthly drug, so they can get it shipped to their home. So if they live far from an infusion center, someplace they can go, we tend to use that drug if that's their preference versus vutrisiran. They can go to any infusion center.
And what about vitamin A?
Oh, I'm sorry, vitamin A. Yes. So, so all patients on any of these silencer drugs, which are, both of those, they need to be on daily vitamin A supplementation. So sometimes that factors into our conversations too with patients when they say, I don't want to take an oral drug. And if we're trying to get them on a therapy, so you have to remind them that they still need a daily vitamin A supplementation in addition to getting the injection or infusion.
I have a question for Erin. Can you tell us a little bit about the real world experience of ejection fractions dropping on mavacamten and kind of what you do from a pharmacokinetic standpoint?
So based on the labeling, we do always hold for 4 weeks before rechecking. Realistically, we've had probably close to 65 patients. I think we've had two drop, one that we had to stop therapy, one was related to something else, and we have since reinitiated at a lower dose. So that's something we discuss with the patients because that's the biggest concern with the cardiac myosin inhibitors. They talk about the heart failure associated, and we're like, that's why we're doing these echoes so frequently. But in the real world, we're not seeing it happen that often that it brings up a concern. But that is a big thing, that we're not going to initiate a cardiac myosin inhibitor if their EF is less than 55, because we know we're going to see a slight drop anyways. And that is something that we've needed to discuss if we've had a outside cardiologist, and we've inherited some patients because their EF dropped a little bit, and that's an expectation when you start the drug. And that's another thing, to set that expectation with the patient. Like, it's okay if your EF goes from 70 to 65%. It is an expectation when we start this medication. That doesn't mean that you're progressing to heart failure.
Can you also comment on aficamten versus mavacamten?
Aficamten is going to definitely help with the drug-drug interactions. That's been a big part of my role because until the most recent label update, we've had to consider changing an offending agent. We've probably changed like 20 PPIs at this point because they were contraindicated. And so we actually have a patient that we're waiting because we can't change the offending agent. And so that's probably going to be the biggest thing. The struggle is always going to be, and as a pharmacist, I'm always thinking about it as which is the preferred agent on their insurance. And that's going to be a big part of this process when we potentially have 2 cardiac myosin inhibitors.
Okay.
Okay, so that's all the time we have. I want to thank all my fellow panelists. So obviously Dr. Tapaskar for a wonderful talk. But Erin and Lori, it's been so terrific to hear your perspectives on a number of these diseases, and in particular, some of the complexities of administering these therapies. So then we're going to transition to our next segment.
I'm going to introduce myself. I'm Ashley Harden, one of the members of the Advanced Heart Failure Transplant Group. I also am interested in round on our pulmonary hypertension service, and then I run our cardiac sarcoid clinic here. So I'm going to get started with my talk. So I'm really excited to talk about cardiac sarcoid. It is where the art of medicine truly still exists. We don't have large randomized clinical trials, or actually any randomized clinical trial data that's been published. I'll tell you, we've all missed the diagnosis of cardiac sarcoidosis if we're caring for patients who have an arrhythmia or some degree of heart failure. So part of the reason that I'm giving this lecture is not only out of personal interest, but also to educate you on what we should look for and in whom we should look for it in. So up here on the bottom left-hand side, you see this kind of gross histology here of a heart affected by someone clearly who passed away or got a transplant. We'll go with that one. who has these areas of abnormal kind of tan-ish tissue where it's been grossly affected by cardiac sarcoidosis. And then just to see who's paying attention, I'm also, like Natalie, not big into football, but I have learned who this person is. He was known as the Minister of Defense, clearly played for Green Bay at some point. And unfortunately, he died. He had sudden cardiac death shortly after his 43rd birthday. Does anybody know who that is, who hasn't seen his picture before? Mr. Henry. Reggie White. Okay. Who knew that? Just out of curiosity. Okay. A lot of people actually knew that. Okay. So we'll talk about him and he's a Hall of Famer. And what's important about him is that he actually died of sarcoidosis, and he was thought to have probably an arrhythmia and contribution of obstructive sleep apnea. So he had cardiac and pulmonary sarcoid on autopsy. So we'll get started. I have no disclosures. I want to start with a case presentation. This is a young woman that I follow in my clinic. She's 19 years old. She had no known medical history before I met her, and she was sitting at home watching TV and felt suddenly dizzy. So went to a freestanding kind of emergency room where she was found to be in ventricular tachycardia, as shown here, caught on this 12-lead EKG and required transfer then to us in an electrical cardioversion at that time. So referred here to UT Southwestern, and she underwent an echocardiogram that was grossly abnormal. So you can see down here on the left-hand side in the yellow oval shape here, she has a really thick interventricular septum in our 4-chamber view, and then our subcostal view, you can really appreciate that. Involves a lot of the right ventricle, the right ventricular apex. And the question was, we've heard Natalie's HCM talk, is this hypertrophic cardiomyopathy? Was this some sort of intracardiac mass? What is this? So ultimately, I'll jump forward a little bit. She ended up getting a cardiac PET CT that showed several areas of abnormal FDG uptake, as you can see here in the hilar lymph nodes, where it's yellow and white, and then in multiple areas of the myocardium, including the septum. So we sent her for a diagnostic evaluation, the first of which was an endomyocardial biopsy, because we needed help figuring out what this was. And that was non-diagnostic, and we'll talk about whether that was expected or not expected in the next several slides. And then because that was non-diagnostic, she underwent a bronchoscopy to target the hilar lymphadenopathy with biopsies. And this is actually her tissue. You see this big non-caseating granuloma here on the left-hand side, and then a really nice example of a multinucleated giant cell there. So ultimately, she was given the diagnosis of sarcoidosis with both cardiac and pulmonary involvement. So this case, at least for me, raised a lot of questions, and we're going to go through these questions as my outline over the course of the rest of the talk. So what is sarcoid? A lot of you may be thinking, like I did initially, remind me what sarcoid is. Why do I care about that? Why do I care that someone has cardiac involvement? Is it worse than not having cardiac involvement? How do these patients present clinically? Is VT a common presentation like this patient? How do we officially diagnose it? When someone's given the diagnosis, they often ask, how worried should I be about this? Is it benign? Is it serious? And then how do we treat the patient? And then if you're thinking, I may have a patient that has cardiac sarcoidosis and I don't know what to do about it, how do you refer a patient here for evaluation at UT Southwestern in our clinic? So we'll talk a little bit about what is sarcoidosis. Sarcoid's an enigmatic disease. It keeps it really interesting for this reason. The term sarcoid was coined by a dermatologist actually back in the late 1800s, and it's thought to be a multi-system, and multi-system becomes important later on in the talk, granulomatous disease of really unknown etiology, felt to represent an immunologic response to some sort of antigen in genetically susceptible people. And I showed this a little bit more in detail here. How do we know that there are genetic factors at play? Well, we've witnessed ancestry differences. There are linkage finding studies and genome-wide association studies that suggest a genetic risk. And then there's high sibling relative risk, especially in monozygotic twins. So if you have a twin monozygote and you have sarcoidosis, your twin is 80-fold more likely, has an 80-fold higher risk of developing sarcoidosis in their lifetime than someone who is not a monozygotic twin. And then many environmental factors have been implicated, mycobacterial or certain fungal infections, inorganic particles, insecticides, and even a variety of types of mold. So sarcoid can affect many organ systems. You can see here in the middle figure, this green man. Oh, sorry about that. You can see it can affect really any organ system, but most commonly is highlighted in the red circle in the middle. It affects the lungs. And generally that's just lymph node, not even lung tissue. There's generally lymph node involvement. But you may be seeing a patient for a cardiac issue and have another clue that may heighten your suspicion that this could be cardiac sarcoidosis, or even internists may see this as the first presentation of systemic sarcoid. And things like anterior uveitis here in the top left, lupus pernio-dermatologic manifestations, neurologic, including Bell's palsy. And then this is, of course, someone who has advanced pulmonary involvement and pulmonary fibrocystic disease. The epidemiology of sarcoidosis. So unlike hypertrophic cardiomyopathy, sarcoid in general, and this is systemic sarcoidosis anywhere, is rare. The incidence is less than 65 per 100,000 individuals, but generally tends to be diagnosed and manifests in middle age, 40 to 55. This disease is more common in Northern Europeans, often in the Scandinavian countries, and then also African Americans, and least common in Eastern Asians. So this is data from the US National Healthcare Database, looked at patients who were identified as having sarcoidosis from 2010 to 2013. And you can see here on the x-axis race or ethnicity. This disease is most common in African Americans as opposed to Asians, Caucasians, and Hispanics. And here in red are women versus men. So women are affected more so than men, especially our African American women. The histopathologic hallmark of sarcoidosis are non-caseating granulomas, but importantly with the asterisk, it's important to know that a non-caseating granuloma is not pathognomonic for sarcoidosis. It's a diagnosis essentially of exclusion. So you really have to rule out other things that are in the differential for a non-caseating granuloma. So they can be certain types of bacterial infections, and examples are here on the right-hand side: fungal infections, systemic vasculitides, IgG4 related disease, exposure-induced, drug-induced, including immunotherapies, and even hematologic malignancies. So why do we care about cardiac involvement? So this is a study that was done in Denmark. It was over a 20-year time span from the late 1990s to the mid-2010s. And it looked at patients who were newly diagnosed with sarcoidosis, and age, sex, and comorbidity matched them in a 1-to-4 fashion with a background population. So here we have almost 12,000 patients that were diagnosed with sarcoid and almost 50,000 that did not have sarcoid. And they were followed for 20 years for an average of 20-year time span for an average of 9 years. And you can see that the absolute risk of heart failure in this population was 2-fold higher in patients with sarcoid than those who did not have sarcoid. And similarly, their absolute risk of ventricular arrhythmias, sudden cardiac death, or needing a defibrillator was 2-fold higher in the sarcoid population than those who did not have sarcoidosis. And importantly, cardiac sarcoid is actually more common than we used to think. And the incidence has increased significantly over the past several decades. And we can see that here in this figure on the right-hand side. This is from the Mid-Fin registry in Finland, where they have a national database of national health care database. And you can see that over time from the 1980s, and we see up through the early 2010s, there was a 20-fold increase over a 25-year time span. You'll notice here that the uptake of the use of cardiac MRI and PET CT was introduced when we see an uptick in the number of cases that were diagnosed. So this is probably not that it's happening more, but confounded by increased awareness that this exists, and the diagnosis is improved with the use of advanced imaging. So how do patients with cardiac sarcoidosis present clinically? You'll remember our 19-year-old woman presented with VT. Is that a really common manifestation of cardiac involvement or not? And this data is reproducible from many different patient population studies that are available. Here's one again. This is data from the Mid-Fin registry in Finland. Over about a 20-year time span, involved over 300 patients, which is a lot for cardiac sarcoid. And you'll see actually the most common clinical presentation of cardiac sarcoidosis was higher grade AV block, followed by heart failure. Sudden cardiac death can be the first manifestation of cardiac involvement, and then followed by ventricular tachycardia. So importantly, this pie diagram here, it encompasses all patients who have sarcoidosis, whether cardiac or not. So you take a patient who has sarcoidosis, and the literature often quotes that there are 5% of patients who carry a diagnosis of sarcoid with obvious clinical manifestation of disease, meaning 5% that present with arrhythmias, heart failure, or have had sudden cardiac death. But cardiac sarcoidosis is often subclinical. So if you look at If you look at patients who have a diagnosis of sarcoid and you actually do imaging studies or you look at autopsy data, there's probably at least 25% of patients with sarcoidosis who have some degree of cardiac involvement that's subclinical at least. So when should you suspect cardiac sarcoidosis? I like to think about two different patient populations here. Do we know that the patient you're seeing, do they have a history of known extracardiac sarcoidosis, or do they have no known history of sarcoidosis? If they have no history of known sarcoidosis and they are presenting with unexplained VT or they've suffered sudden cardiac death, if they have advanced AV block and they're relatively young, less than 60 years old, they have an abnormal echo and you don't know why, unexplained heart failure, you should think of sarcoid at least in your differential, thinking about it. If they've known extracardiac sarcoid, the bar is a little bit lower if they've had significant palpitations. Usually it's palpitations daily for at least 2 weeks. They're telling you I've had a history of syncope or significant pre-syncope. They have clinical heart failure, an abnormal echocardiogram or an abnormal EKG. We should look for cardiac involvement of sarcoidosis. So importantly, cardiac manifestations of sarcoid may actually be the first to appear in someone who's ultimately diagnosed with systemic sarcoidosis, and they may not have clinically obvious extracardiac involvement. We'll talk a little bit more about that in a couple of slides. So how do we diagnose this? Now we suspect it in a patient, how do I get to the diagnosis? We're going to talk about two key topics under the realm of diagnosing sarcoid. The first are the current diagnostic criteria, and second are limitations of these criteria. So endomyocardial biopsy is the gold standard. If you get a biopsy and you see non-caseating granulomas and you've excluded everything else, great, but the yield is really low, 20 to 30%. So really clinically, we rely on clinical criteria. There are three main sets to know about, but we're going to focus here on the 2014 Heart Rhythm Society Expert Consensus Guidelines. These are international guidelines and they require histology from somewhere in the body to make the diagnosis, unlike other clinical criteria, including the Japanese Ministry of Health and Welfare. So the diagnosis of sarcoid is easier if you get an endomyocardial biopsy here. You have myocardial tissue with non-caseating granulomas, and importantly, no other cause is identified for the non-caseating granulomas. And you see here, you have granulomas and a multinucleated giant cell. That's great. But the yield is about 25% due to the patchy nature of the disease. Help from our EP colleagues can increase our yield a little bit. So you can see there, they can do voltage mapping here. This is mapping of the right ventricle and the septum. In the red and the green are areas of abnormal voltage. And they can put their little electrode catheter in an area of abnormal voltage, and we try and come in through the IJ here with our bioptome, take a picture, and we hope we get something like this. So the yield may be increased up to about 50% with voltage guidance, but still subpar for putting a patient through a semi-invasive procedure. So we rely really heavily on these clinical criteria. So the Heart Rhythm Society says your patient may have probable cardiac involvement if there's evidence of extracardiac tissue. That's a key point. With non-caseating granulomas, no other reason why they have them, and one or more of the following: an unexplained low EF, unexplained VT or high-grade AV block, abnormal PET CT or cardiac MRI. I'll talk more about that in the next few slides. An abnormal or a positive gallium scan. We don't do that here at UT Southwestern usually. Or a patient has shown response to empiric immunosuppression where their ejection fraction has improved when it was low, or their heart block has improved after they received some sort of immunosuppression. So let's talk a little bit about the limitations of these criteria. There are lower sensitivity of some components versus the others. So again, the gold standard is not easy to obtain. There are some limitations with clinical criteria. So echo is very different than cardiac MRI in terms of sensitivity of sarcoidosis. So experts really emphasize the use of advanced cardiac imaging. So the first that I always try and pursue in all of my patients is a cardiac MRI. We're looking for areas of late enhancement of gadolinium or LGE. And this indicates areas of fibrosis and or inflammation. We can't quite accurately distinguish between the two most of the time. We're looking for a pattern of scar that's non-ischemic. It's often in a subepicardial or mid-myocardial distribution. This is certainly not specific for sarcoid alone. Limitations are this is an expensive test, takes about an hour to have done, and then there are artifacts in patients who have pacemakers or defibrillators. If it's abnormal, I then proceed to a PET CT, and the utility really in cardiac MRI, one major benefit is that if patients have a normal cardiac MRI, they're unlikely to have cardiac sarcoidosis. A cardiac PET CT, I consider as complementary to a cardiac MRI. We're looking for areas of FDG uptake, which are these colorful areas in the ventricle. left ventricle here, but there's a broad differential for why we have FDG uptake. You could see this with ischemia, other types of myocarditis that we'll hear about, and even a poor nutritional prep. So it can benefit is that it can detect extra cardiac disease that may be easier to target for biopsy. It does require special dietary prep, and we end up having, unfortunately, a higher rate of false positives than we would hope for. And there's exposure to radiation here with this test, unlike a cardiac MRI. So let's talk a little bit about the lack of a diagnostic pathway for isolated cardiac sarcoid. So this really presents to us as clinicians a clinical conundrum. So there's no clear pathway, if you'll notice, for diagnosis of isolated cardiac sarcoid without tissue. But the literature is telling us that up to 65% of cases of patients with cardiac sarcoid, it seems to be isolated only to the heart. So it's a major diagnostic and therapeutic challenge, and it really raises the question, is cardiac sarcoid truly isolated? You told me earlier it was a multi-system inflammatory disease, and may we be missing an alternative diagnosis? So I really like this slide because it illustrates an interesting point. Isolated cardiac sarcoid is probably uncommon, not 65% of the patients with cardiac sarcoid as you screen more intensely. So that data that says, 65% of patients with cardiac sarcoid have isolated involvement, deemed isolated involvement after they just did a physical exam on the patient, some basic labs, and a chest x-ray. But if you look at autopsy data, and this isn't even microhistology, it's gross histologic involvement of sarcoid. On autopsy, 22% didn't have anything grossly abnormal in lymph nodes, et cetera. And if you do a whole body PET CT, it's probably really unlikely that you have isolated cardiac involvement. And if you repeat that PET CT 6 months later, it's probably even lower than 3%. So this is important because we should consider phenotypically similar cardiac syndromes. We'll hear from Drs. Hendren and Drasner in a little bit about myocarditis and genetic cardiomyopathies, but I want to highlight here other forms of inflammation in the heart can look like isolated cardiac sarcoid. Some restrictive cardiomyopathies, HCM and amyloid, and then genetic cardiomyopathies. If you look at a study from UW, who they studied patients who were referred to them for isolated cardiac involvement, did genetic testing, and about a third of them had a pathogenic mutation where inflammation was thought to be involved in the pathogenesis of that disease. So always question the diagnosis of isolated sarcoid. Okay, few last things. What are the implications of diagnosis, benign or serious? And this is some contemporary data from French, Japanese, and Finnish populations, large numbers of patients for cardiac sarcoid at least, and it's not as dismal as we thought. The 5-year survival's in the 90% range, and 10 years anywhere from 80 to 90%. And prognosis, of course, is associated with the following risk factors, of course, ejection fraction, cardiac biomarkers, malignant arrhythmias, and importantly, the presence of LGE on MRI or FDG on PET scan. And I show you this here, that the odds ratio for VT or death, if you have the presence of LGE on a cardiac MRI, is very high here. And similarly, if you have multiple areas of abnormality, FDG uptake, then the hazard ratio for VT or death is high on PET CT. So what treatment recommendations are appropriate? And then we'll end with how you refer a patient here. We want to treat active inflammation. Importantly, the goal is to treat active inflammation, prevent its clinical sequelae, but these recommendations are based on expert consensus. There's been no proof of survival benefit. We most commonly use steroids, and then second line are antimetabolites. And if we have ongoing persistent inflammation, we often escalate to TNF alpha therapy. We want to identify and address arrhythmias. These are very common complications as we saw cardiac involvement. If patients have high-grade heart block, we should place a pacemaker, and then there's some data that these patients should probably get a defibrillator. If they've had malignant ventricular arrhythmias, of course, we'll place a defibrillator for secondary prevention. There's unclear role of immunosuppression for VT, unlike AV block, which tends to respond to immunosuppression. And we also use antiarrhythmic medications and ablation techniques in these patients. Last couple slides here, we want to risk stratify for sudden cardiac death. Again, basic indications or classic indications for ICD placement if they've had sustained VT, sudden cardiac death, or a low EF. It's a class 1 indication, but note that there are a couple unique to cardiac sarcoidosis. If your EF is actually greater than 35% and the patient needs a pacemaker, we talked about that for AV block, they have unexplained syncope or a certain amount of LGE on a cardiac MRI that's not super well defined, there's a class 2A indication. Or if these patients also have an EF that's not severely depressed and inducible ventricular arrhythmias during an EP study, it's a class 2A indication. So note that there are several indications for ICD placement with an EF that's not less than 35%. And finally, we're going to manage heart failure pretty similarly to other patients who have heart failure, aside from treating active inflammation. If they have evidence of that on a PET scan, we're going to employ medical therapies for heart failure. So we're going to try and target inflammation if we can. There's a role for guideline-directed medical therapy here, device-based therapies as we discussed, and honestly, then we can pursue advanced therapies for heart failure if needed. And I didn't show my slide on advanced therapies for heart failure, but these patients, even after heart transplant, have a similar risk of rejection and very low risk of recurrence in the transplanted heart, especially if they're maintained on steroids. So lastly, how might we refer a patient for evaluation? Here we have a cardiac sarcoidosis clinic here at Southwestern with advanced heart failure, EP, cardiac imaging specialist. We collaborate very frequently with subspecialists, our pulmonary colleagues, rheumatology, dermatology. We have multidisciplinary conferences quarterly. And if you're here at Southwestern, you can refer, or anywhere, refer to advanced heart failure and then note the concern for cardiac sarcoid, and we'll get the patient in for a comprehensive intake visit. We have a very detailed protocol with specific diagnostic testing and individualized treatment plans. There's a website. You want to scan the QR code or Google us. And then we'll circle back finally, last two slides here, a case presentation. So this was our 19-year-old. She met Heart Rhythm Society criteria because she had a positive extracardiac biopsy from a lymph node, and she had an abnormal cardiac MRI and PET scan. So this was her initial PET CT. She was treated with pred and methotrexate, had no further VT, and you can see a really nice response here. So in summary, cardiac involvement is a major source of morbidity and mortality in sarcoidosis, and we should consider it in patients who have unexplained VT, heart block, or heart failure. Screen for cardiac involvement in patients with known extracardiac sarcoid if they're telling you they're having palpitations, syncope, if they have abnormal cardiac imaging studies. Diagnosis relies heavily on clinical criteria because there's a low sensitivity, unfortunately, with endomyocardial biopsy. This entity of clinically isolated cardiac sarcoid can be really challenging to diagnose, and we probably should do genetic testing. We'll hear a little bit about this later on our patients who are deemed to have isolated cardiac sarcoidosis. Management includes treating inflammation, arrhythmias, and heart failure. And then we have a clinic here available to you to send your patients if you'd like help. Thank you very much. Okay, I'm going to introduce our next speaker, one of my amazing colleagues, Dr. Hendren here. He's the medical director of heart failure at Parkland, one of our sister county hospitals, and has really been instrumental in bringing more advanced therapies to that patient population and the ability to do things like ECMO over at Parkland. And then he is an expert on myocarditis, and I'll talk to you a little bit more about that.
Wonderful. Well, thanks, Ashley. Good morning, everyone. As Ashley said, I work as one of the colleagues in our transplant section here. Perhaps my most relevant disclosure, staying on the football theme this morning, is that I'm actually an NFL minority owner and a passionate fan of the Green Bay Packers. So I recognize Reggie White very, very well and detest the Bears with all three. So myocarditis is an interesting disease in that it is often very common, presents on the one hand and familiar to all of us in the room. Yet on the other hand, it oftentimes does not lead to catastrophic outcomes except in a minority of patients. And that small percentage of patients, while individually the risk is low, when you scale that to 8 million people in North Texas or over 30 million people in Texas, can scale to adverse outcomes that we have to all be aware of and screen for. Despite its common prevalence, this is actually a summary slide of the high quality randomized clinical trials in the myocarditis space. There's no high quality evidence. We have guidance based upon expert recommendations. We have regional differences and institutional differences. I do want to highlight the ACC expert consensus pathway on myocarditis management, in part led by Dr. Drasmer, one of my colleagues here. And that's the basis for some of the discussion. But again, just to highlight that there's a lot that we don't know in this condition, despite the common prevalence of it. So I'm going to work through a brief outline here today, hitting some high touch points and some things I think are high yield or potentially open to debate, to really screen what happens with most of our patients, and then what are red flags and things we have to think about and watch for scenarios that are a little bit unusual. So just so we're on the same page, there's the myocarditis, myopericarditis, and perimyocarditis. All of those are essentially variations of the different thing. Right? Essentially inflammation of the heart, and to whatever extent there's pericardial inflammation drives whether it's a pure myocarditis, no pericardial inflammation, myopericarditis, inflammation of both the heart and the pericardium, or perimyocarditis. In practical reality, that doesn't matter, but it's just so you all are aware that these oftentimes get lumped together in patients presenting with chest pain and myocarditis. All of these are kind of similar terms, and they're a bit really academic. They don't really mean all that much. But I would highlight, as Ashley said, the diagnosis of myocarditis or inflammation of the heart is just that. It's an umbrella term that encompasses all these different things. Just because you have inflammation and you diagnose myocarditis doesn't actually tell you what it's from. So this is a more comprehensive kind of list of some of the things that I think about when I'm seeing a patient with myocarditis. And again, if you look at the most common etiologies, things like infection-associated or viral-associated myocarditis, that encompasses more than 90 out of 100 patients. And I'll spend most of my time talking about that today. But there are these other things that we think about. And sarcoidosis is not shown here, but it is within the differential that we think about for our patients. And so there's a number of ways in which we think about these patients, particularly when they have repeat events from that perspective. So I think this encompasses really the most common presentation that we see for myocarditis in the community, right? These are typically young men presenting with no prior past medical history or limited medical history, with typically recent onset or acute onset chest pain. They have some shortness of breath. They had maybe a cold a few weeks prior. Nothing really remarkable in their social or medical history from that perspective. They look pretty good when you go and see them, maybe a little uncomfortable, particularly with kind of breathing or deep breathing. They don't have heart failure. You look at their echo, their EF is normal, and then you get called because, of course, their troponin is markedly abnormal, well above the 99th percentile. We use 5th generation high sensitivity troponin here, so that would be well above the 99th percentile. And that's what typically gets these patients admitted when they go to the ER, is they're young with chest pain and a high troponin, and that's where cardiology often gets involved. For my patients, we do look for coronary artery disease, and typically we'll screen with the coronary CTs for these patients. And like this example here, they're oftentimes negative. And so then you're really left the question of what is going on with these patients. So typically the textbook presentation of myocarditis comes through 3 different flavors or groups. So the most classic presentation, as we talked about in the last slide, was presenting with chest pain. But patients can also present with heart failure or new shock. And then atrial or ventricular arrhythmia is classically VT or VF. And again, because there's not been really a comprehensive study of these patients, when you look through different registries looking at different clinical events, they capture myocarditis in a perfect way. So on the far right-hand side, you can see this registry of young men who died suddenly, and about 1/4 of those patients end up dying from, on autopsy, had myocarditis. This has been replicated in US cohorts as well, too, particularly among young men in the military who die suddenly and unexpectedly, that there is a percentage of young men who die and have myocarditis on autopsy. And that subsequently leads to the activity restriction, which we'll talk about later. But if you look at things like inflammatory heart disease in the middle, and then MNOCA, an increasingly popular term for MI without clear cause, you look at the biopsy confirmation of those patients, there is a significant proportion of those patients that do have myocarditis. And then the Lombardi registry is probably the best cohort so far that has been well phenotyped out of Italy, about 400, 450 patients. And we'll spend a lot of time digesting that a little bit more. But they really represent a contemporary cohort of infection-associated, viral-associated myocarditis that we'll spend most of our time on here this morning. And as you can see on that left-hand column under the Lombardi registry, most of those patients are presenting with chest pain, right? That's how they get to the ER. There is a proportion, about 1/5, that end up with heart failure, and then many of them have prodromal symptoms. So again, when you think about your patients presenting to the ER, probably 9 out of 10 are going to have a very reassuring, benign course. It's that 1 out of 10 that we have to watch for and be aware of. Breaking down the symptoms of those patients, again, a little bit more who present with low risk viral-associated myocarditis. Most of them have chest pain, right? That's what got them into the registry. Many of them will give you an antecedent fever history, either subjective or objective. About 10% will have an autoimmune condition. There is an association, and there's some genetic reasons we think that might be relevant. I would highlight that while EKG manifestations are almost universally board tested for cardiovascular exams, 1 out of 5 may have a normal EKG. So that alone is not sufficient to rule out myocarditis. And then by definition alone, you have to have an abnormal troponin to have a definition of myocarditis. And so all patients have that. And again, most patients have normal ejection fractions coming in. So again, low risk in general. How do we pick out the higher risk patients? So for me, as I'm looking through a new patient in the ER, what are some basic things we look through? Well, of course, the usual demographics. Again, a history of autoimmune disease is seen in about 1 in 10 people with myocarditis. It's not uncommon. Asthma is also typically a clue for our patients there. And then as we look through the lab work on the CBC, I'd pay a lot of attention to eosinophils. If we see new onset myocarditis with eosinophilia, that can be indicative of an eosinophilic myocarditis. We see a handful of those cases a year referred in. Eosinophils are a great clue that there may be something else going on there. And then certainly the usual things like drug screening, HIV, syphilis, things like that we do for all of our patients. I generally do not order ESRs or CRPs. They're elevated in 80% of patients. They're not elevated in 20% of patients. And when you think about what are outcomes, whether there are differences in outcomes for those patients, there's no difference in outcomes. So it's fine if people get it, but it does not drive management and does not really drive things here. And then other potential lab work depending upon clinical history and where the patient is from. If you're worried about autoimmune conditions, ANCA, anti-myocyte antibodies, double-strength DNA, as Dr. Drazner is going to allude on a little bit more, genetic testing has become increasingly a test that we are doing for our patients, particularly with recurrent episodes of myocarditis where we think there may be more of a genetic risk and driver for those patients. Again, just to highlight again the EKG changes here, 15 to 20% of patients have completely normal EKGs. So again, that alone is not sufficient to exclude myocarditis. And patients with more severe disease or kind of what we'll call fulminant disease, people who present with shock, VTVF, or clinical heart failure are more likely to have PVCs, particularly multifocal PVCs, heart block, wide QRSs. And those, of course, probably are markers of more aggressive phenotypes of the disease. And those patients tend to be sicker, but there's no absolutes in that population. So what about viral antibodies? So things like Cox antibody titers, all these antibody titers that we've done historically. Again, there's no strong guideline recommendation one way or the other. I will tell you, I will share my personal anecdote, is that personally, I rarely check them. We really now increasingly believe that, as I'll touch on in a little bit, this is really an autoimmune kind of response. And so most PCRs are negative. Most antiviral PCRs may take weeks. It's expensive. It really changes management. And in a small study you can see here shown, if you look at people who are either antibody positive or negative, there's no difference in outcomes. So that clearly does not drive the outcomes. And as we're all thinking about healthcare costs, it is a way to save potentially thousands of dollars for our patients if it's not changing management. Again, what about genetic testing? So again, Dr. Drazner is going to delve into this a little bit more in the next talk here, but we know that about 10 to 20% of patients with myocarditis have a pathogenic mutation that's identified. And patients, as you can see here, this is an example of people with desmosomal gene variants, but there are other variants that have been proven as well too. Patients who present with myocarditis and have pathogenic genes have a worse outcome over time. As you can see in the blue line on the top there, those who are who have a genetic mutation positive for desmosomal gene variants, as opposed to those who are negative, the bottom line and then the second line there have much better outcomes compared to others. And so it's a risk factor for patients going forward, both in terms of risk of needing heart failure advanced therapies, as well as recurrent episodes. And we can counsel our patients about that. And for those that are usually young men or women, this is also relevant to their family planning as well too. So it can be very helpful for them as they think about things that are important in their life. Diagnostic criteria, so these have been relatively standard over the past 10 years. So again, if you look at the top there, there's kind of two different pathways or trees that this can go. So importantly, all patients have to have signs or symptoms compatible with the clinical syndrome. So if you just trip and fall into an MRI scanner and you have some LGE or some abnormal enhancement, that alone is not sufficient to diagnose the disease. You have to have clinical symptoms. Historically, that clinical symptoms was only corroborated with an endomyocardial biopsy with criteria established here in Dallas in the 1980s. But as that test has its own inherent risks and side effects, the non-invasive pathway using MRI has really evolved as kind of the standard for us and other centers around the country. So as you look at the right side of that image there, so again, you have to have signs, symptoms, an abnormal MRI, which I'll expand on in just a moment, with some active inflammation and some active scarring, plus a cardiac biomarker that's elevated, typically for us troponin, greater than 99th percentile. All three of those things together get you to the diagnosis of myocarditis. And again, just the presence of myocarditis does not give you the etiology of myocarditis. So what are those specific imaging features that we're seeing in MRI? There's two different components that our radiologists are using. So our T1-based imaging looks at things like extracellular volume, LGE or scarring in the heart. So is there extra stuff around the cells in the myocardium that is abnormal and concerning? That, though, is not sufficient by itself. So we need the second component, which is T2-based. So that is really focused at looking at edema or swelling inside the heart, active inflammation. So many of our patients, when they have their first MRI, will have both components. As they heal, as that inflammation resolves, we want to see that T2 component go away, that active inflammation go away. Sometimes our patients will continue to have scarring. They may have abnormal T1 values. That may be very well expected, but the active inflammation is what we ultimately are concerned about long-term for our patients. And so that's the component we monitor over time with serial MRIs. And if you look at the diagnostic accuracy between biopsies and cardiac MRI basis, the sensitivity and specificity is relatively, the operating characteristics are relatively good. Again, there's nothing perfect. The gold standard is very limited, and there are many patients who we undoubtedly don't appreciate have the disease, unfortunately. A word on biopsies very quickly. So as we think about biopsies, the histopathologic criteria were actually created here in Dallas, again in the 1980s. And really what they're looking for fundamentally is looking for that inflammatory infiltrate with active injury. So it's not just the presence of cells, it's the presence of cells plus inflammation causing damage for those. We know that in most centers, there's around a 0.5 to 1% risk of serious adverse complications. So it is not a test we typically like to jump to right away because of the competing risk of the procedure. And similar to cardiac sarcoid, there is a diagnostic limitation. So we know that around 50% of samples, even with 5+ samples, are not catching inflammation that's seen on MRI. So there's limitations to this test. And so for that reason, it's really not first-line therapy for us. We can do additional immunohistochemical staining that marginally adds some insights in the disease, but is really kind of evolving. And then historically, centers have done PCR testing, looking for viruses in the heart muscle itself, where they take a sample of that biopsy, send it out to try and grow viruses out of there. And that really has fallen out of favor, both at our center and many other centers around the country. The yield tends to be low. It tends to be done very expensively, and it has to be done very, very specifically in an operation that really is not well done. So for those reasons, for sampling error, for variable pathology criteria and complication rates, these are real major limitations to biopsy, although we will certainly do it in certain scenarios. So when do we actually think about biopsying our patients? So again, these are the guidelines here. They're all level expert opinion based, and I can read them to you, but I think what's more important is practically, when you think about your patients, when are we thinking about biopsying them? So when do we biopsy? When we think we are suspecting myocarditis and we either cannot have an unavailable MRI or the patient cannot tolerate MRI. If we don't know why they have myocarditis and they're presenting with heart failure or VTVF, we're oftentimes biopsying those patients to look for giant cell because that has very different implications for the natural history of their disease, very different treatments, and we treat that very differently. Again, patients presenting with shock and VTVF, again, looking for giant cell or sarcoidosis. And then anytime we're thinking about risky therapies, right? So if we're worried we're gonna have to transplant that person, we're worried about having to use profound immunosuppression to treat them, that may be a reason to think about that. We do have also reasons when patients are on checkpoint inhibitors, if there's uncertainty about their diagnosis, that we sometimes will entertain that as well too. And then if we're worried about hypersensitivity, eosinophilic myocarditis, again, that presentation with myocarditis plus peripheral eosinophilia, that can be useful to confirm that, although again, we don't have to necessarily do that, but that can be confirmatory for those patients. Again, this is the broad list of things to consider. I'm going to focus on the infection-associated or viral-associated myocarditis. So one of the opportunities from the pandemic was historically people thought that viral myocarditis was, in fact, the virus actually going into the heart of the patient, replicating and causing direct damage. But you can see here that this is data from very early in the pandemic with SARS-CoV-2 cases, COVID-19 on the left, that blue line rising up, followed by cases of myocarditis or MISC on the right side. You can see that 6 to 8 week lag happening there. Most of these patients tested negative for SARS-CoV-2, and so it really cemented that this is an immune-mediated process rather than a direct viral replication process. And despite the thousands of cases of COVID-19 myocarditis, many of which were biopsied around the country, including many at our centers, I'm aware of less than 5 in the world that actually had electron microscopy proven virus in the cells, and many of those were in macrophages that may have migrated from other places. So it did really discredit the idea that myocarditis or that the virus is replicating in the myocardial cells is causing this problem. So with the infection-associated myocarditis, we estimate that this is causing well more than 90% of the problems. It's really an immune-mediated process that's reacting to the virus. If you start on the lower left-hand side of the screen there, you can see that someone's exposed to a virus that leads to an inflammatory cascade and that causes immune activation. In some of those patients, the virus proteins that are expressed are mimicking or similar to proteins expressed in the heart, and that can cause this cross-reactive confusion where the body starts to attack or injure the heart, confusing it for the virus rather than the virus causing the damage directly to the heart. In most patients, that propagation goes away, but in probably 5 to 10% of patients hospitalized, that cross-reactivity, that immune activation, can actually persist and lead to long-term antibodies, chronic myocarditis, and may ultimately progress to heart failure, which is one of the reasons we watch these patients so closely after their hospitalization. This immune-mediated response explains why we see a viral prodrome in many of our patients 1 to 2 weeks before presenting. It explains why many of our patients are PCR viral negative upon presentation, and why we see age and sex prevalences and seasonal variation. So this is a graph looking at incidence of myocarditis, and you can see there's seasonal variability with more cases in the fall and winter relative to the spring and summer. Okay? The prevalence of infection-associated myocarditis is much more common in young men and women because their immune system is more robust at age 20 than 50 than 70. So that is a risk factor for the disease and actually a protective factor when we see that. Again, clues that things may be unusual or atypical, older presentation is a big clue for us there. So again, clues that this is not typical low-risk myocarditis. These are the clues that I think about, I look for among patients. If you're presenting older than 45 years old, that's a little bit atypical. I had one man that presented with more than 50 ICD shocks. That's a little bit unusual, and he had sarcoidosis that lasts more than 8 weeks. Again, there's a progression of injury and inflammation that's unusual. Happening multiple times suggests there may be a genetic precursor, and so we look for those. And then VT-VF with normal EF, again, raises the question of cardiac sarcoid or things like giant cell that may be progressing. Peripheral eosinophilia, as I mentioned, is a risk factor. And then early onset or family history of heart disease, again, suggests a genetic component. And so we screen those patients much more consistently. So as we look at our patients here, how do we start thinking about separating high versus low risk as we triage them? So again, looking back to that Lombardi registry of around 440 patients, they did what a lot of us intuitively do. They look for risk factors. So they divided their patients with those presenting with cardiogenic shock, reduced ejection fractions, or VT-VF. Again, those are high-risk features. And then compared them to patients that had low-risk features. As you can see, many of these patients look similar in terms of EKG abnormalities, abnormal inflammatory markers, abnormal troponins, and then of course differentiated by EF because we're separating by EF. But if you look at how those patients do, on the left-hand side here is all comers, right? So all comers, there's around a 4% chance of cardiac death or requiring heart transplant. But again, if you separate that out by those who have complicated presentations versus lower risk complications, those who don't have shock, those who don't have VT-VF, those who don't have systolic heart failure, they do very, very well. And their risk over the next several years is very low. And this is borne out in other studies. And you compare that to those who have any of those three features, and their risk of transplant or cardiovascular death is markedly more elevated. So it's a higher risk population that I certainly catches my attention when I see referrals for those patients. You look over time and looking at their ejection fractions, again, supporting the idea that if you come in low risk, you stay low risk, their EFs stay normal. As you can see on the right-hand side there, look at the uncomplicated or low risk patients, they do well. And many of those high-risk presentations ultimately do recover and they can do well. But again, that's a population we watch closer because there's a higher pre-test probability. They have a genetic condition or something else that's going to drive their adverse outcome, like giant cell myocarditis. So how do we treat patients, or how do I think about treating patients? So again, I break that down into acute uncomplicated, acute complicated, and then chronic inflammatory myocarditis. So the uncomplicated courses, many of those patients get NSAIDs or colchicine if they have chest pain. If they don't have chest pain, we don't know if it works. We do give them some recommendations to avoid vigorous activity, which I'll touch on again in a little bit more detail in a moment. And then we do monitor them for syncope, high PVC burdens, low threshold for Holter monitors for those patients. We typically will repeat a cardiac MRI in 3 to 6 months to ensure that inflammation goes away. Many of them will have residual abnormalities, but we want the inflammation, the T2 abnormalities, to go away for those patients. And again, if they have active inflammation, if they're having recurrent episodes, that's where we really start to investigate further for those patients. What about our acutely sick patients? Again, many of those same things are still applicable. We have a lower threshold for biopsying those patients, particularly if they have persistent inflammation. And then again, the vigorous activity restriction. I do generally genetically test all of these patients on their first presentation, given that we know they're higher risk long-term. And many times when they're very, very sick, particularly if they're requiring mechanical support, it's very hard to only watch and provide supportive care. There is some general consensus that immunosuppression with IV steroids and perhaps IVIG can be helpful for those patients. Again, there's no randomized data in this space, and there's heterogeneity in how people apply that. You can see different steroid tapers that people use here. In general, we do try to avoid steroids for patients, particularly the low-risk patients, because that may not be benign. It may lead to more relapse and pericardial involvement. For people that want to do it, typically we'll use high-dose steroids for around 3 to 5 days. My general sense is we don't taper, although some do. And again, you may be treating things you don't know about yet. So you may be treating the giant cell, you may be treating the sarcoid, you may be treating something that may be responsive. We have no idea if this is actually helpful for lymphocytic myocarditis. And it certainly may be harmful with the risks of thrombosis with IVIG or steroids and infection. Chronic myocarditis, again, we look for the same things. Is the inflammation persisting? Oftentimes we'll get a PET scan to look for cardiac sarcoidosis. We may consider chronic immunosuppression on a case-by-case basis to try and turn off the inflammation in the immune system. But again, there's no high-quality data in that space. And then the probably best, highest recommendation so far has been aerobic activity restriction. So again, from the early studies, we've known that there is occasional death with normal LV function with myocarditis. And so the risk of sudden death may not necessarily associate with the amount of inflammation. So we ask patients to avoid competitive, vigorous activity until that inflammation has resolved from the heart. Please do not tell your patients, and I do not tell my patients to do no activity because that will just severely decondition them. And then when they restart that activity, they feel awful. So what I tell them is walk, do activities of normal living. Just this is not the time to train for a marathon. Don't go swimming in a pool by yourself, but normal active movements can be good. And again, we repeat that parametric mapping. So in brief summary here, again, lymphocytic myocarditis is most common in young men and women. Older people presenting for the first time, you should have a higher degree of suspicion. This may not be what it initially seems to be. We know that people with uncomplicated presentations have an excellent prognosis. We should be aware of clues that suggest this might be something atypical. The MRI, of course, can identify myocarditis. It doesn't tell you what caused it. And so again, if it's not behaving in the way you might expect it to be, we should be looking for other things. Again, if there's high-risk features, biopsy is reasonable. There's a very early emerging role for genetic testing for those with myocarditis, and then recurrent episodes merits referral because that suggests something else is going on and portends a different prognosis over the next several years than people who are not having recurrent episodes. Thank you all. I'd like to introduce Dr. Drasner, who's been a long time now colleague and partner and a thought leader in the areas of heart failure, among many, many other credentials. Dr. Drasner.
Thanks, Nick. Before I get started, I do want to, just pause and recognize this incredible breadth of expertise that's already been on display. And for the trainees in the room, just think about the options within a career of heart failure that are available to you. And also do want to say how fortunate I am to work with this amazing group of professionals. So it's really, really a pleasure. So I'm going to be talking about genetic cardiomyopathy. And what I'm going to do is I'm going to give you my top 3 take-home points. And the first is that the era of genetic testing in all patients with a non-ischemic cardiomyopathy have arrived. The second is this idea about a 2-hit hypothesis, which may be operative in many patients with a cardiomyopathy. And then third, I want to discuss this clinical scenario of hot phases of arrhythmogenic cardiomyopathy, which looks all the world like myocarditis. And it's a pretty interesting clinical scenario to discuss. So the first take-home point about the era of genetic testing has arrived. And the thesis is that this is because it impacts patient care. And there'll be 3 arguments to that thesis. The first is criteria for ICD implantation. The second is that you can detect at-risk family members. And then the third is that you can absolutely establish the true diagnosis. So let me bring a patient to us. There's a 30-year-old woman who had a striking family history of sudden death. Her father had died at age 48 shortly after he developed heart failure. The father's brother also died at a young age. He had an ICD in place and there was thought to be a malfunction. Because of that, that family underwent recent cascade screening, and 3 of the 4 children, they were the first cousins of my patient, were found to have a pathological variant in a gene called RBM20 and notified her. She then went got tested and was found to carry the variant in RBM20. And so had an echocardiogram performed showing an EF of 45%, slightly dilated ventricle. And she saw Dr. Link in our arrhythmia center who ordered a cardiac MRI and then referred her to me. When I saw her, she was asymptomatic. She looked compensated on exam, flat neck veins, no third heart sound, no leg edema. Her pro-BNPs were not that high. And she was on beta blockers and ACE inhibitor, really being treated for asymptomatic left ventricular dysfunction. The cardiac MRI that Dr. Link ordered returned, and it showed that she had an EF of 41%. She had a dilated ventricle, normal right ventricle. And there was this linear mid-wall late gadolinium in the septum consistent with a non-ischemic cardiomyopathy. And because of this, we did refer on for an ICD implantation. And I'll pause here and note that this is even though her ejection fraction is above 35%. And so what is RBM20? When you see these patients with genetic cardiomyopathy, I do think it helps to kind of delve into the underlying genetic defect to try to understand the pathophysiology. And in this case, RBM20 is a regulator of messenger RNA metabolism because it interacts with the spliceosome. And through its interaction with the spliceosome, it then affects a multitude, more than 40 other genes, some of which are familiar to you, including things like titin or the ryanodine receptor. So the way that works is shown here. You can see on the top left, RBM20 is being transcribed, and then it gets sent to the cytoplasm where it's translated. And then you can see the RBM20 protein. Let me see if this pointer works here. No. The RBM20 then gets imported back into the nucleus and then interacts with the spliceosome. And then it gets, through the interaction of the spliceosome, it then affects other proteins. Okay, so here we have the RBM20 that is translocated, but when it's mutated, what happens is the protein can no longer get back into the cytoplasm, and so it can interact with the spliceosome, and so then it has downstream consequences in all the other genes. And because of that, it essentially leads to a cardiomyopathy. And so this is a transgenic model where the RBM gene was deleted, essentially, and you can see here that the female mice compared to the wild type were much dilated, and you can see that the ejection fractions both among the male and female were lower. Well, if you go to humans, you can look at a registry here of 143 patients who were followed for about 7 years. And what was found was that the baseline ejection fraction was independently associated with the risk of sudden death. And of the 10 participants who had a malignant ventricular arrhythmia, the median EF was 29%. 4 of the 10 had an EF greater than 35%. And only 1 of the 10 had an EF greater than 45%. So because of that and similar data like this, the European guidelines say that an ICD should be considered when you're at risk of sudden death and the EF is greater than 35% in the presence of additional factors. And they point out those additional factors are a number of variants in the pathological genes like lamin A or in filament C or phospholamban. And on the bottom there, you can see RBM20 is listed. You also note here the annual sudden cardiac death rate for some of these is 5 to 10%. And then for example, RBM20, it's 3 to 5%. And just to give you some context, if you look, for example, at the European guidelines, this is similar to what Dr. Tapaskar showed earlier, the estimated risk of 5-year risk of sudden death greater than 6% gets you a class 2A indication for a defibrillator. So that's over 5 years of risk of greater than 6%. In the presence of these pathological genes, you have a 3 to 5% risk each year. So it's a much higher risk than even what's being recommended for hypertrophic cardiomyopathy. Well, RBM20 is just one of many genes that are involved in the dilated cardiomyopathy phenotype. You have sarcomeric genes, things like myosin heavy chain or troponins. You have the cytoplasmic genes like filament C, desmosomal genes, which we've heard somewhat already about DSP or desmoplakin. And then you have other genes, including RBM20. So it clearly can impact your decision-making in patient care because you'll implant an ICD even if the EF is greater than 35%. What about the identification of other at-risk family members? This is a second case of a patient who was in her 20s and was diagnosed with a peripartum cardiomyopathy, developed progressive heart failure, which culminated in a heart transplant. This was done years ago. And an explant, she had what looked like myocarditis. Transplant went well, the graft was doing fine. I'll note that this was years ago before we were doing routine genetic testing. We thought everything was going well. But then recently her teenage son was playing tennis and started having chest pain and had this echocardiogram. And you can see a very thickened ventricle that had a very poor ejection fraction. He was tested for genetic abnormalities and he was found to have a pathogenic premature stop codon in a gene called LAMP2, which is X-linked or associated with X-linked Danon disease. So once we saw that, we realized that in fact that the son had Danon disease. Undoubtedly, our patient had Danon disease, even though we thought she had a peripartum cardiomyopathy, and in fact genetically tested her, and that's what she had. So what is known about Danon disease? Well, it's a rare X-linked disease that's caused by this loss of function mutation in LAMP2. LAMP2 is the lysosomal associated membrane protein type 2. And it essentially fuses with the lysosomes and the autophagosomes. So really defects in this lead to a defect in autophagy. And without LAMP2, then you can't clear the intracellular waste essentially, and you get these vacuoles that accumulate and lead to the thickened ventricle. In the men, they have 100% penetrance and they develop severe LVH and arrhythmias in adolescence. But the women present about 10 years later with more of a dilated than a hypertrophic phenotype. And that played out exactly in our case, where our patient, the mother, presented much later than her adolescent son, and she presented more with a dilated phenotype. He presented more with a hypertrophic phenotype. And that's shown graphically here. Here are the sex differences in the men and the women. You can see that the men are developing advanced heart failure by their 20s, whereas the women present 10 years later, and they don't usually manifest with severe disease until their 30s. Well, we transplanted her not knowing that she had Danon disease. What's going to happen to her? Well, fortunately, it turns out that if you look at heart transplant in a series of Danon disease, you can see here the outcomes are pretty good. 5-year survival rates have been reported at 87%. So it should go well for her, which is even better news because the son also underwent heart transplant, and that too has gone well in the early period. And so this sounds like a really, dramatic success story, but you have to kind of pause, and you can easily imagine a very different catastrophic outcome on that tennis court. I mean, we just got lucky that he had not collapsed and died. And so it was a good success story, but better to be lucky than good in this case. And so I think the value of genetic testing here is so important, not only for your patient, but also for their relatives. And also, it doesn't apply just to these patients who are presenting to us with new onset heart failure. But if you think about all these patients in our clinics who have heart failure that we've been following for years before the genetic testing became widely available, it's applicable to them as well. And I think we need to go back and search for those people and genetically test them as well. And then lastly, the third argument for this thesis about impacting patient care is this. Through this case, this is a male college student who had new onset heart failure. He had an outside cardiac MRI said to have non-compaction in the EF of less than 20. And I saw him last year. He said, yeah, he lagged a little bit with his peers when they ran in gym, but he was able to play basketball and baseball. He had a normal CK, normal strength on exam. And we sent him for genetic testing, and it turned out that he had a disrupting splice site variant in dystrophin, which is associated with DMD. So what his real diagnosis is Becker's muscular dystrophy and a cardiomyopathy, and we've referred him on to physical medicine and neuromuscular neurology. So before genetic testing, we would have said that he just had a non-compaction idiopathic cardiomyopathy, but now we really know what the true diagnosis is. He has Becker's disease. And think about the impact not only for him, knowing what the real diagnosis is and what might happen to him with peripheral musculature, but also the entire family members that wouldn't have really known what the real diagnosis was without the genetic testing. And so what do the guidelines say? Well, in 2022, we said for everyone, and I wouldn't minimize this, do a 3-generation family history. It's amazing how oftentimes if I take a family history, I'll be able to ascertain that there are other family members who have it, and it's clear that in fact they don't have an idiopathic cardiomyopathy. It's a familial cardiomyopathy. And I would also point out to you, as you're following your patients in clinic, update the family history, because it's not uncommon that I'll be following a patient and 5 years later, a patient will come and say, hey, it's really interesting. My sister just got diagnosed with cardiomyopathy. So you have to update your family history on the visits. In the 2022 guidelines, we said that for some patients, we should usually refer for genetic counseling and testing. But I think I align more with the 2023 European guidelines, where they give a class 1 recommendation, and then they list a variety of factors, things like in cases where it enables diagnosis, prognostication, therapeutic stratification, or reproductive management. I mean, it's hard to imagine which patient that wouldn't apply to. Essentially, they're recommending class 1 level recommendation for basically all patients with non-ischemic cardiomyopathy, and I do align with that. I will pause and say, yes, it's very easy to send these genetic panels, but every guideline that's ever been written about this said you should do this with the genetic counselor. And we can talk about that in the Q&A, why to do that, but I firmly believe we should be using our genetic counselors, and we're fortunate that the institution, including Scott Bennett, supported us, and we now have an embedded genetic counselor with us in our heart failure clinic that gives us that expertise. Now, you may say, well, who should I test? Can I somehow enrich the yield? And now we're starting to see in the literature risk scores emerging, multivariable risk scores to increase the yield. This is a risk score out of Madrid that had a derivation cohort and validation cohort, reasonable discriminatory capacity. And you can see here the 5 factors: skeletal myopathy, family history of non-ischemic, dilated cardiomyopathy, low voltage on the EKG, absence of hypertension, or absence of left bundle. And you can see that as the patients had more of these factors on the right-hand side, you can see that your diagnostic yield goes up. So the second point then is this 2-hit hypothesis may be operative in many patients. So what is the 2-hit hypothesis? Well, the idea is that if you have a cardiomyopathy gene or a potential insult like alcohol, pregnancy, chemotherapy, or viral infection, you won't get heart failure. But if you have both together, then you're at risk. It's two hits. You have the genetic predisposition, and then you need the second hit, this excessive alcohol or pregnancy or chemotherapy to cause it. I'm not going to go into the data, but you can see here a seminal publication showing peripartum cardiomyopathy, cancer therapy-induced cardiomyopathies, alcohol cardiomyopathy, and acute myocarditis, that in these series, somewhere between 10 and 15% of patients with a cardiomyopathy attributed to another apparent etiology harbor a genetic variant associated with cardiomyopathy. And then my third take-home point then is be aware of this clinical scenario of so-called hot phases, which looks all the world like myocarditis. This is a great case report from the New England Journal last year, and they entitled it a hot cardiomyopathy. 27-year-old woman came into the ER with palpitations and dyspnea, no flu-like symptoms, no family history of cardiovascular disease, no COVID vaccination, and look at that EKG, dramatic myocardial injury pattern that typically would either be an extensive myocardial infarction or more likely we would say this is myocarditis. And in fact, her troponins were markedly elevated at 5,900. She had no evidence of COVID, her EF was reduced, no coronary disease, and she had non-sustained VT. They sent her for a cardiac MRI, and you've already heard about T2 mapping. This was elevated here at 69 milliseconds, well above the normal limit, and then this diffuse subepicardial, almost ring-like late gadolinium pattern. And in the New England Journal, the expert discussed and said the amount and distribution of the myocardial edema and inflammation on T2 and the late gadolinium were impressive. This pattern is non-ischemic and points to conditions such as acute myocarditis. And they also went on to say cardiac sarcoidosis also could be not ruled out, although the absence of extracardiac findings or bradyarrhythmias would make that unusual. So already you can see that within this case report, this presentation, is it myocarditis? Is it sarcoidosis? Is it something else? Well, they started her on steroids, just as Dr. Hendren suggested oftentimes would be done. But the endomyocardial biopsy turned out to be negative, and then subsequent genetic testing revealed a real diagnosis. She had a desmoplakin frame-shift variant leading to premature protein truncation, and she has an arrhythmogenic cardiomyopathy. Now, arrhythmogenic cardiomyopathy we used to call that ARVC, where you got that fibrofatty infiltration of the right ventricle. But it's now recognized that you can have both left ventricular or biventricular involvement. And the other complicating feature is that some patients with dilated cardiomyopathy had life-threatening arrhythmias, even though they had minimal dilation or minimum reduction in the ejection fraction. And so because of that, these observations, this umbrella term of arrhythmogenic cardiomyopathy has arrived. And that's been defined as it could affect either the right ventricle, the left ventricle, or both. But the key is that arrhythmias are out of proportion to the systolic dysfunction. And then when you get into this diagnosis of arrhythmogenic cardiomyopathy, more than 50% of them carry this a variant in one of the desmosomal genes. And so here's a dilated cardiomyopathy, this arrhythmogenic cardiomyopathy, and clearly there is overlap. And this is where genetic testing will be so important. And I would say the same thing, you could put the same slide up for myocarditis, you could put the same slide up for sarcoidosis. There's going to be an overlap, and the only way you're going to know what the real diagnosis is to do the genetic testing. And I think the field's going to move towards a gene-first nomenclature. We're not going to call it a dilated or hypertrophic cardiomyopathy or sarcoid. We're going to call it the true genetic abnormality and then say what the phenotype is. So what are these hot phases? Well, this could present with acute myocarditis or recurrent myocarditis. And I would say you can see inflammation both on biopsy and even with FDG PET. These hearts can light up, which makes it very difficult to distinguish from sarcoid. There's no consensus on how to treat or prevent the recurrence. And the genetic associations now, desmoplakin, just like the patient in the New England Journal or DSP, is the most common desmosomal gene that's linked to these hot phases. Although if you take all causes of the arrhythmogenic cardiomyopathy, and particularly the classic ARVC pattern, plakophilin or PKP2 is far more common in that population. Well, the implications of this are similar to what Dr. Hendren was talking about, and this is what we said in the ECDP statement. We said that given the increasing recognition of genetic predisposition to myocarditis, genetic counseling and testing is advised for all consenting patients. So we moved beyond just the patients who have severe presentations, and we really said that for all patients with myocarditis, we think you should do it. And again, there's no randomized data, but the discovery of a pathogenic variant should be followed by cascade screening, thereby affording undiagnosed relatives the opportunity for clinical surveillance and, when appropriate, GDMT. And so in the summary of this is that the thesis the 3 take-home points. The era of genetic testing has arrived. For non-ischemic cardiomyopathy, it affects our criteria for ICD implantation. When you find these high-risk genotypes like lamin AC, filamin C, phospholambin, the desmoplakins, the RBM20s, you're going to put an ICD in even if the EF is more than 35%. You're going to be able to find those asymptomatic relatives so that the son doesn't collapse on the tennis court. And you can finally know what the real diagnosis is rather than just saying this is a non-ischemic cardiomyopathy or a non-compaction. You really know what the true diagnosis is. I didn't discuss because of time prognosis. And then ultimately, the other critical part of doing all this genetic testing is we're not that far away from gene-based therapies. And if you're going to want your patient to get the genetic-based therapy, you're going to have to know what the genetic defect is. So you may as well start cataloging what these genetic defects are. In the guidelines, we gave it a class 2A in the US, and even though I was an author of that, I align with the class 1 recommendation in the European guidelines. The two-hit hypothesis may be operative in a clinically meaningful minority of patients. So even if you see someone with what looks like a pure classic alcoholic cardiomyopathy or myocarditis, go ahead and do the genetic testing. And then this really interesting clinical presentation of these hot phases of the arrhythmogenic cardiomyopathy that looks all the world like myocarditis, and is important to keep in your differential. Thank you. And it looks like we are moving to a panel which Dr. Hardin will be the moderator.
I'll open it up for any questions. Oh, Dr. Groden to start, then I have some.
So Ashley, Nick, and Mark, those were 3 terrific talks. I learned something from each of you every time you get up and speak about these topics. So it's wonderful to gain all those insights from your expertise. So I think there's one theme that's been pervasive. If you heard the talks in our session with Dr. Tafaskar, myself, really is underscored by genetic testing. And I think, Mark, you touched on this in your talk, the importance of familial cascade screening. So, for example, in amyloidosis, up to 30% of the patients we treat, at least if you look at epidemiologic data in the North America and the UK, have a hereditary form of the disease. And one of the big challenges is cascade testing and how to implement that. We, as many of you all do, we believe it's best practice to leverage our experts in genetic counseling. But it seems like as soon as those discussions are had with the patient, the cascade testing seems to usually fall on deaf ears. And so, many family members may have different opinions as to whether or not they implement that. So it's I think everybody makes the case for the crucial importance of identifying these pathogenic variants. But what are your practices and how to implement that? What works? Because I can tell you, Lori and I struggle with this all the time.
Yeah, I think that's a great question and very important. I will say there's a lot of work that needs to be done on this, because if you think about it, we make a diagnosis, we tell our patient, and then the patient is the one who goes to talk to the family. Lord knows what they're telling them. And a lot of biases within their perceptions are going to be then relayed to the patients. So I think there is a lot of work that needs to be done. As you know, we're part of the dilated cardiomyopathy program with Ray Hirschberger's that is starting to look at they have the probands and they have the families. And so they're starting to look at even psychological traits of the proband and how does that affect it. So there is work that's being done on that, and it is a crucially important point. In terms of what success, I don't think I have any, I think it depends on the patient that you're seeing. We have some patients who literally, by the time they're in the car, they call their family and the family is already calling their doctors. I mean, they're super engaged. And then there's other families that are, maybe more suspect of the whole idea about genetic testing. So it may depend on the patient population that you're seeing, also may impact on the yield of the subsequent family members getting genetically tested.
Question on that note of cost and availability of genetic testing, especially if we're doing cascade testing and coverage for family members and then for patients.
Yeah, I think these are all real. And, if you go back to the morning session, the cost of the drugs also similarly are real issues for us. In this case, really, I would highlight, again, this is, I think, the benefit of our genetic counselors, because essentially, in the way, at least in my practice, the genetic counselor is the one who helps orchestrate all the cascade testing of the families. And critically important, I mean, I don't know what panel to order based on insurance, But the genetic counselor, that's their area of expertise. And so I found them to be very helpful in trying to figure out which is the best test, and then also working with the family members. Some of the companies, if you get a positive or likely pathogenic or pathogenic variant, will then include cascade screening as part of that package, but not all companies are like that. And again, it's an area where I think you need the expertise of our colleagues, the genetic counselors.
Question for Nick. I think a little bit of a hot topic, vaccines and myocarditis, and what your recommendations are, let's say, on one hand, for patients who have active myocarditis and vaccines, and then just hesitancy with vaccines, a little bit of a black box.
Yeah, no, great topic.
With
of course,
myocarditis.
that obviously exploded with the pandemic, and we know that certain vaccines are more likely, although low, to cause a risk of myocarditis. So the original COVID-19 vaccines, there's an association that is low. So 30 out of 100,000 young men will develop that. If you're going into the military and you need smallpox vaccination, there's a small chance you'll get myocarditis from that as well too. Again, the risk outweigh the benefits if you've never had disease of myocarditis before. The one hesitancy is if you had myocarditis, I think there's some uncertainty, particularly around the COVID vaccination, because that does seem to have some association with potentially flaring or triggering that disease. And if you think you had myocarditis as a result of the COVID vaccination, I think a lot of us would be hesitant to re-challenge it. And it's tough to convince a patient to do that too in all practicality. So
You would use that specifically with the COVID vaccination, and then
other
Yeah,
vaccinations, influenza should
Just-
all be
okay.
safe. And we have we vaccinated or immunized other patients as well after COVID-19 myocarditis associated, and they've done very well with other vaccines. So it does seem to be specific, more specific to that formulary and that condition. Oh, and yeah, it's a little obviously the strain of COVID-19 obviously impacts the risk and benefits of vaccination. But again, 30 for 100,000 young men got myocarditis. There was maybe 1 or 2 deaths nationally. So you're talking about a very, very small number. And then again, when you compare that to the benefit, even in terms of quality of life for patients to stay boosted to avoid complications of COVID, the benefits clearly outweigh the risks. So.
And then what would be the risk? Do you know the risk of myocarditis with just a COVID infection? So avoiding, like vaccinating to avoid the
Yeah,
risk of vaccine versus.
That has definitely changed as the strains of the viruses evolved. So initially there was clearly a preponderance of myocarditis that has gone down. We don't have a great feel for what the current variants are in terms of the risk of myocarditis. It has gone down dramatically from the first variants, but it's not zero. And so we think that the benefit that the vaccination helps reduce the risk of the current strains of COVID-19, that's less supported than the initial rounds though.
Okay, just an incredible masterclass all the way around. I have a question, and I think it also captures one of the questions here. I think sometimes we see older patients who come and they've come for some transplant eval or something, disease management, and they seem to be unusually frail, or there's something that seems a little bit out of the ordinary for that particular individual. But we don't, they've been used to their chronic diagnosis of heart failure for a while, and so genetic testing doesn't really come up. It's a quiet disease that they're having, not a hot arrhythmic disease. And so the question is when do you genetic test in someone who's older? And I think you maybe have just answered that. And I think the one thing we've learned here, we have a large neuromuscular cardiomyopathy clinic, is that there are a lot of older diagnoses that provides the explanation for the frailty and so forth. So maybe some comments.
Yeah, I think that's an important point. There are data now looking at older patients with cardiomyopathy. And because, before I saw this data, I would think, well, usually you think a genetic cardiomyopathy would present earlier in life. But it turns out when they took a series, and I think it was greater than 60, it was somewhere between 20 and 30% of those patients had a genetic variant. And so a lot of that was in Titan. So that really changed my perception that I do think even if you have patients who are older, they should still get genetically tested.
We were going to go with, oh, pardon me.
So Mark, I'm delighted that you highlighted the possibility of a gene-first approach. And, obviously the extreme version of that is population-based genetic screening. So I think one counter argument to that is that not all of these genes are penetrant. There can be implications with our financial implications. There can be implications with life insurance. There can be social stigma. There might be unnecessary, perhaps unnecessary worry or stress related to a variant. And so I was just wondering if you could elaborate on that, and possibly even Ashley and Nick, because and kind of the pros and the cons, because this is really kind of one of these next phases of personalized medicine, with the All of Us initiatives, which have genomic data on around 1 million people in the United States. I was just wondering if you could discuss this kind of controversial topic.
Yeah, it's a very hot topic, I would say. So first I'll say, when you go get genetically tested, what everyone wants, if you're the relative, let's say, and you're getting genetic testing, of course you want to be, everyone's hoping I'm going to do the test and get genotype negative. But you don't know that, otherwise you wouldn't have to do the genetic test. So you may end up getting genotype positive and not have any phenotype, have no symptoms. And then you may never develop the disease your whole life. In that scenario, then now you have the gene. If you hadn't known it, nothing would have been changed, but now you have to worry your entire life. So they're real, or the other scenario, which I didn't talk about, is that there are variants of unknown significance, as Dr. Groden knows well. So those are, you get a genetically test back, there is a variant, but we don't know if it means anything. And that needs to be followed longitudinally to see if it may in fact be associated with their phenotype or not. That's just on an individual patient. Now, if you think about, and these are panels of, let's say, 100 or 150 genes, imagine if you do the entire genome of everyone in the population, how many variants you're going to find and how are you going to make sense of all that? We just don't know yet enough about all these variants out there. Does it mean anything or not? And there is real potential for psychological harm. And then how are you going to track all that information, which is another reason I would say is so important to get genetic counselors involved, because when we send our patients and you get this variant of unknown significance, a VUS back, someone has to track that over time. And sometimes those will be downgraded and they'll be benign, or sometimes they'll be upgraded and it'll become pathogenic or likely pathogenic as more data accrues. Well, I have no way of doing that, of tracking all this and keeping a database and doing that, but the genetic counselors can on an individual patient. Now, on a population level, that brings up a whole different, and I see some young trainees in the room. That's for you all to figure out how to do this, because it is good. That's where we're going to get. But how do you manage that data, all that data that's going to be coming back to us is a really difficult question.
And I would add the other part, I see a lot of young men and women, and we'd have this discussion is, compared to things like CT scans or MRIs, we're asking a third-party company to do their genetic testing, right? And so you have companies like 23andMe who have gone bankrupt, and now their genetic data is on the market. It's very different than sending a test to Mayo. That's a medical institution. There's more implicit trust with a lot of patients there. So I think that is one of the challenges of the medical system, is how do we bring some of this genetic testing into the medical system away from third parties? And that may improve some of the trust in the testing too.
That could go for all three. Guideline-directed medical therapy in any of these disease entities in preserved EF. And we have some extrapolation in neuromuscular cardiomyopathy, sort of a preventative strategy, but those trials are not going to be done, I don't think. What is your personal practice or your sentiments about that?
That's a good one. Tough question. I think it's easy to do it when there are other indications for medical therapies. If someone's hypertensive, I might choose a beta blocker that's proven to, help with the neurohormonal hypothesis of heart failure, and it's based on GDMT. There are a lot of reasons now why people are on SGLT2 inhibitors, not just for the heart, but for other indications. So I will kind of tailor that, but to do it in everybody who has just a preserved EF, I think in sarcoid, at least, we don't even know whether we should treat with anti-inflammatories patients who we just screened because may had a palpitation or two, but have a preserved EF and a small focus of increased FDG uptake. So I will use medications that overlap with both if they have other indications for that, and no clinical heart failure.
Yeah, and I would add for myocarditis or inflammatory cardiomyopathy, again, there's no guidelines for this, but how people die when they die with an EF that's 55 with myocarditis, they die from VT of EF. So for me, I counsel and have a discussion with my patients about this may help prevent your risk from dying suddenly. It's unpredictable. Low-dose beta blocker, if tolerated, which it often is not in young men, may help reduce that risk. And so I oftentimes will start it until their MRI shows no T2, no active inflammation edema, and then take them off of it. And I don't know what I'm treating other than potentially modifying the risk of sudden death, but if 1 out of 100 young men dies, that can be devastating for the family for an otherwise safe, old, established therapy. And so we have that risk-benefit conversation quite often.
I think, when I see, I think is the patient someone who could have been enrolled in the randomized trial? So for example, if someone had true heart failure preserved ejection fraction, maybe it's a genetically cardiomyopathy or not, would they have been enrolled in the randomized clinical trial? And if they were, then I would treat them as such. But we need the data. And as we get into gene diagnoses, we need to test the specific population. So for example, in amyloid now, are emerging data looking at SGLT2 inhibitors. The trials are actually being done in that subpopulation, so we'll know the real answer. For now, for me, I think, would they have been eligible for the randomized trial that showed benefit? And if they are, then I would try to treat.
So we're going to shift gears a little bit here today and talk about trying to recover our patients and also to assess dyspnea. So as a transplant cardiologist, I can say that one of the more special parts of our job is being able to tell a patient that we have an organ for them. And I think Mr. Henry here in the back can attest to that. Has now received 3 organs with us, but it's really a remarkable feeling to be able to tell someone that they're going to have a second chance of life. Now, as a heart failure cardiologist, what I also find to be very meaningful and rewarding is to take a patient who presents with heart failure and to treat them medically and to get them to the point where they either recover with reverse remodeling or to go into remission where their heart failure symptoms are well managed and we don't need to think about heart transplant or heart pump. And that's kind of what I'm going to focus on today. So I'm going to tell you a little bit of a journey of what we've gone through here at UT Southwestern to help promote the health of our patients with heart failure and in doing so, reduce the admissions and readmissions for our patients. And we'll talk about these different things. Each of these will be covered, and then we'll kind of shift to once you've done all of these things, but you still have a patient who has shortness of breath, how can we assess that and know what to do? So back in 2018, we recognized that our readmission rate was higher than what we wanted it to be, and kind of then went into what is driving our readmissions and what are the different things that we can touch and how can we affect these admission and readmission rates. Our first thing that we developed, because we didn't have this at that time, was our transition process. So we have 2 transition nurses that take care of our patients in the hospital and in the clinic. And they will meet the patients in the hospital. Basically, they screen our admissions from the top to bottom through the hospital and find who was admitted the night before. And then they'll go meet those patients and kind of assess why did they get readmitted, what was the process for that. And they'll also teach those patients throughout their admission with an hour of dedicated teaching time. We also have teaching that is done by our dietitians in the hospital and also by our pharmacists to help the patients understand what do they need to do for themselves, why is it so important for them to take their medications. When the patients are discharged, then we have our transition nurses again touch base with our patients within 72 hours, usually 48 hours, to make sure that they got home safely, that they have all of the medications that they need, that they have awareness of when they're supposed to follow up, they have transportation, things like that. And we see them back in our clinic within 4 to 5 days of discharge, and then sometimes weekly, but at least every 2 weeks as needed while they are recovering, because we know that this transition period is their most vulnerable time. They also get weekly phone calls by the transition nurse to make sure that they're doing well. And then once they've gone through this transition process, they'll follow in our transition clinic with our transition APPs at 30 days. If they're not primarily followed in our clinic, if they've come from other places, we graduate them back to wherever they normally follow. But we take ownership of them for the 30 days after they've been in our hospital. We also systematically review all of our readmissions to try to figure out what we can be doing better for our patients. So that was step 1. Step 2 is that we developed a diuresis clinic within our heart failure clinic. We developed a standard protocol where we took their home dose of diuretic and converted it to a Lasix or furosemide equivalent. And then based on their renal function and then electrolytes, we developed this protocol so that patients can come into our diuresis clinic, be seen by our APPs and nurses, not have to have a new order each time to be able to manage them. And then we can also give boosters if we felt that that would be needed. And we have a point of care test so we can check their labs before they get any diuresis, and then we can check their labs again after they've had diuresis to see if there's any additional electrolyte repletion that needs to happen. After the success of our diuresis clinic for patients that we follow in our heart failure clinic, we then expanded that so that general cardiology clinics can also refer to us. And we've also expanded recently to the emergency department. So the emergency department now has our protocol, and they can trial our protocol for patients who they anticipate will be short stay. We define short stay for us as about 72 hours of admission. And we looked at our data and saw that 20% of patients who were admitted to our hospital with heart failure were discharged within 72 hours. So we thought that that population could be somebody that we could touch and intervene on and kind of avoid admission if they were able to see us in diuresis clinic. So the ER would try our diuretic protocol. If the patient lost enough weight, we measured weight rather than ins and outs because it's very hard to accurately get ins and outs in an emergency department. So if they lost enough weight and they felt better, that they felt safe to discharge, then they could discharge and follow up with us either next day or within 2 days, depending on what time they're leaving the hospital, in our diuresis clinic again. Our APPs would then assess them and say, are they still wet, or was that enough diuresis? Do we need to adjust their home diuretic? Can we diurese them more here? And follow them even daily if they needed to until they were euvolemic and able to stop following in our diuresis clinic. We could also use that opportunity to optimize other medications. The next thing that we did, kind of developed during the COVID period time, is remote patient monitoring. So certain patients who weren't wanting to do this, those who we thought were high risk or those who were actively uptitrating GDMT, we could get them remote patient monitoring. And this was the kit that we had for them from Health Resources or Health Recovery Solutions. They would get a Bluetooth tablet, a Bluetooth stethoscope, a scale, a blood pressure cuff, and a pulse ox. And that tablet had educational materials. It also allowed them to record any symptoms they were having, and all of their information would get wirelessly transmitted to our central RPM monitoring nurses. Those nurses are separate from our clinic. Those nurses work for RPM that for other disease processes within the hospital. Diabetes was using it, Cancer Center was using it, and they would notice if things were out of parameter. If things were out of parameter, they would then call the patient and make sure it wasn't a relative that stepped on the scale that morning, ask some questions and make sure that there really was something that was happening. And if that was the case, then they would call our clinic or notify our nurses, who could then call the patient and intervene however they felt needed. The tablet also was wonderful because it served as a remote visit platform for patients who did not have wireless or who did not have a smartphone, who were not otherwise able to do a virtual visit with us. They could do that through that tablet independently. And that for a lot of our high-risk patients who had trouble with transportation to our clinic or who didn't have the resources to do virtual visits, this could serve as our virtual visit platform. And that really has been able to help some of our very high-risk patients. And the benefit of this is if they use this, I think it was 75% of the time they were submitting their data, then this could go through insurance and was not actually of any cost to the patient. So it was actually very helpful for them. We also recognize the benefits of guideline-directed medical therapy. So I think you'll be hard to find somebody who's more passionate about guideline-directed medical therapy than I am. And I really, really push this for all of our patients. But as you can see here, if we have our patients on quadruple therapy, then they have a 74% reduction of risk for mortality and an 85% risk reduction for admission for heart failure. So one of the best things and most important things, and I would say the most important thing that we can do for our patients, is to really get them on good GDMT and at the highest doses possible to benefit our patients. So we next looked at how can we do this? How can we get our patients on the best GDMT? Well, a STRONG-HF trial came out, which kind of gave us some guidelines that we could really do this a lot faster than historically we thought that we could. So the STRONG-HF trial was a prospective study that randomized over 1,000 patients to high intensity. In that high intensity group, they tried to get patients to at least half target guideline-directed medical therapy before discharge, and then tried to get them to target within 2 weeks of discharge. Not everybody did that. So for the patients who were not able to get to those levels within that period of time, they would follow them weekly until they were able to get them to their maximized doses. And then they would follow them weekly after any dose adjustment. They compared this to the usual care, and the primary outcome was 180-day heart failure readmission or all-cause death. These were their results. It's kind of hard to follow, but if you look at these graphs, we have the RAS inhibition on the left, beta blockers in the middle, MRAs on the right. The darker the color is the more medication that they're on. So you can see that for each time point, the high intensity group, which is red, compared to the usual care group, which is blue, had more patients who were on that medication and at higher doses. And then in their outcomes, they found that the all-cause risk of death or heart failure readmission at 180 days was lower in the high-intensity group. And again, if you look at heart failure readmissions at 180 days, similarly, that was much lower. So that led us to think, how could we be doing better for our patients? Well, Dr. Drasner, Dr. Hendren, and I then looked at our own rates and published it and challenged other people to look at their rates and publish it and make it patient facing so that patients could see how they're doing, and looked at our rates for guideline-directed medical therapy. When we dove a little bit deeper into those, we found that we did a really good job overall compared to other guidelines or registries, and of course, related to clinical trials that looked at GDMT up-titration. We were doing pretty well. But we also saw that people who were followed by cardiologists did better than those who were not. And people who were followed by heart failure specialists did even better than those followed by cardiologists with getting their patients on good guideline-directed medical therapy. So we decided we kind of need to own this. Heart failure needs to own the GDMT for our institution. We're not unique in that finding. This was a study that was just published in 2025 that looked at 227,000 patients who were admitted with heart failure and saw that 80% received some support from any heart failure specialist. 30% had a multidisciplinary team, 22% were heart failure nurses, 39% by heart failure physicians. But they found that those who were seen by any kind of heart failure specialists were more likely to be on better guideline-directed medical therapy, less likely to have high diuretic requirements, and to have better heart failure care and decreased mortality. So that really kind of drove what we wanted to do. We're not also unique in that we wanted to develop a GDMT clinic. There are multiple different studies that showed the benefit of guideline-directed medical therapy clinics, although there are not that many that are occurring in the hospital. And these don't need to be done by physicians. These studies have shown the benefit of a pharmacy-led clinic, of a nurse-led clinic, multiple different ways that you can skin the cat. But otherwise, getting patients on guideline-directed medical therapy the best way that you can and by the best resources that you have available to you at your institutions. What we decided to do was develop a strong heart clinic. So starting with our inpatient population, our transition nurses, again, are already identifying those patients who are admitted with heart failure. Now we're also looking at them and saying, are they optimized on their medical therapy? Especially if they're new onset heart failure, how can we treat them? So then we modified our transition clinic and we now have a strong heart clinic. And our strong heart clinic will now expand our transition care from just 30 days to at least 90 days or however long it takes to get patients on the duration of the, to get them on the maximally tolerated or target guideline-directed medical therapy. And then at that point, we then graduate them back. We started this as an inpatient opportunity, so we would identify them inpatient, but we've also expanded it to outpatient. So primary care providers or general cardiology clinic who may not have the same resources that we have in our heart failure clinic can refer their patients specifically for GDMT up-titration. Our lovely APPs here own those patients and will up-titrate their GDMT and get them on the best medical therapy and then graduate them back to their primary care cardiologists or their general cardiologists. Another intervention, where did Katie go? I don't see her right now. Oh, there she is. Katie is our cardiology pharmacist, and one of her pilot projects that she's recently done is a pharmacy intervention for those who are admitted with ejection fractions that are less than or equal to 40%, but they're not admitted for heart failure. So they're not being touched by our transition team, but they're in the hospital for something else, cellulitis or some other medical problem that does not require the cardiology team. Her team will identify those and they'll go to the hospitalists or the other teams that are taking care of them and saying, hey, I saw that your patient has an EF less than 40. They're only on a beta blocker and lisinopril. Do you think we can try to get them on their SGLT2 inhibitor or their MRA? Do you need me to price check that for you? I'm happy to do that. So they kind of take every opportunity to touch these patients who have the low ejection fraction to get them on the best medical therapy. Lastly, we know that with this study that came out in 2022, that we can also prompt other people to think about GDMT. So this looked at electronic health medical records and kind of had a best practice advisory that would pop up if their patients were not on the best medical therapy and trying to educate them as to why they should be on those medical therapies and provide a way to order those. And they found that that did help. That did help people to get on better medical therapy. So we kind of adopted that process by using an Epic smart text. So the smart text will populate first time when the patient is admitted to the hospital and the provider is writing their history and physical exam. That smart text will pop up if the EMR identifies the patient who has ejection fractions less than 40. It'll screen their medications and it'll say, oh, you're not on this. It'll pop up with the medications that they're not on. You can document a contraindication or there's a link for you to order it. And then it again pops up I think it's 3 days later, if the patient maybe has stabilized, or their AKI that they came in with is now resolved, or they're no longer hyperkalemic, maybe now they can tolerate their MRI that they weren't on. It gives you another chance to say, hey, maybe this patient should be on it. And then it again pops up in the discharge summary. So multiple opportunities for you to reassess and think about your patients and whether or not they can be on guideline-directed medical therapy. So what did we find with all of our GDMT efforts? Well, again, I showed you the 2020 to 2022, which is a 2-year look back. And you can see when we started to take care of more of the patients and put these processes into implementation, that we did increase our already fantastic rates even more. And more patients were on quadruple therapy, more patients were on ARNIs and MRAs and SGLT2 inhibitors. So we really did find a benefit to uptitration of GDMT. And overall, that then leads to improved survival and decreased admission and readmission rates for our patients. So with all of these efforts, you can see that we did a lot better with our unplanned 30-day readmission rate. Back in 2018, our rate was 23%, and our goal was to get to 17% by the end of 2025. So we're nearing that, but we've already made such a huge progress here. You can see the timeline of all the interventions that we've done. It's important to see that this did not happen overnight. So I know that this requires manpower and systems and things like that, but this is a systematic process in which different ways that we could touch our patients and try to improve their outcomes and their health. Coincidentally, I wasn't aware of this, but our chief quality officer was looking at disparities in readmission rates between people of different races and people who spoke different languages, and found that initially those who were of Black or Hispanic race were readmitted more commonly than those that were white. And also those who spoke Spanish were readmitted more than those who spoke English. But with all of the different things that we were doing, that disappeared, and all the admission rates came down, and there was no longer any disparity in readmission rates. We also looked not just at readmission rates, but admission rates, because we know that any patient who's admitted with heart failure, that's a turning point in their disease trajectory, and we want to prevent any admission for heart failure. So this was looking at patients who had at least 2 visits to their primary care doctor or to a cardiologist, and then whether they were admitted for heart failure. And we can see here also that our admission rates came down over time with our different therapies. So in conclusion for this part, we did multidisciplinary efforts, which we went through each of these, that led to significant improvement in our 30-day readmission rate, as well as our admission rate for our patients with heart failure, which led to improved symptoms and improved survival for our patients. Now we're going to turn just a little bit to hemodynamics and invasive cardiopulmonary exercise testing, because in addition to my passion for GDMT, I also tell everybody that my happy place at work is in the cath lab. So we'll talk a little bit about the cath lab and how we can assess our patients who have unexplained dyspnea. So 2 seconds on what we can normally find when we do a right heart catheterization. Our normal pressures are here. I do rules of 6s, so everything's a multiple of 6. We can get their invasive filling pressure data. We can look at their pulmonary pressures. We can look at their cardiac index. We can determine their systemic vascular resistance, which is the amount of pressure the heart has to pump against, and their pulmonary vascular resistance, which is the amount of pressure the right heart has to pump against. And then there are also all sorts of advanced hemodynamics that we can do that I've listed here, which tell us more about the right side or the left side, if there's biventricular dysfunction, and these all provide prognostic information as well. And we can kind of use that as our basis when we think about patients to which medication should we be adjusting. So here are 2 patients, patient A and patient B. I have their vital signs and the baseline GDMT. And my question for you all is, what would you want to do differently? Does anybody want to change any of the medicines on these patients? Are these patients the same? Who wants to increase their beta blocker? Who wants to increase their ARNI? They're already on good doses of their MRA and their SGLT2, so we can leave those alone. Who wants more information? Okay, let's do more information. So here are their hemodynamics. So they both have elevated wedge pressures, a little bit more pulmonary pressure that's elevated on one than the other. They both have low cardiac index. Does that change what you might do for them? Who wants to increase beta blockers now? Anybody? Who wants to increase their ARNIs? Who wants more information still? More information still. Okay, here are their MAPs and here are their SVRs. So these originally started looking like they were the same patient, but now you can see that they're very different patients. Their systemic vascular resistance of patient B is much, much, much higher than the SVR of patient A. And patient B is actually a patient who was transferred to us in cardiogenic shock on high-dose inotropes they were transferred for possible mechanical support and consideration for advanced therapies. Turns out that with medical therapy and really decreasing that SVR, and I had him discharged on inotropes and saw him weekly, I was able to up-titrate all of his medications to full dose, and he recovered and has an EF of 50 now and is off of inotropes completely. So in this case, if you're, initially had lower, softer blood pressures where people might be hesitant to increase their medications, really knowing advanced hemodynamics and what their SVR is can help guide your therapies. As opposed to patient A, whose SVR is kind of where we want it to be, around 1,000. They might benefit from a little bit of their GDMT up titration, but they also have a low cardiac index, and this might be somebody who you might want more information on to see if they're really advanced heart failure, needing different therapies. So what are those things that we can do? One of the things that I do in the cath lab is an invasive cardiopulmonary exercise test. What does that entail? That has a patient who is hooked up to the regular monitor, so you can get their blood, their right atrial pressure, their wedge pressure, their pulmonary artery pressures. They're also breathing through a mask, which connects to a cardiopulmonary exercise cart. And through that cart, we can measure all about their gas exchange and different processes to really understand what is it that's causing them to not do well. So if you think about shortness of breath, there are 3 buckets. There's cardiac, there's pulmonary, and there's muscular. Cardiac etiologies of shortness of breath can be the impaired cardiac reserve, chronotropic incompetence, preload insufficiency, dynamic RV malactation, HFpEF, or advanced heart failure. Pulmonary, we can have an exercise-induced pulmonary hypertension or a primary pulmonary limitation, and then muscular, there can be muscular deconditioning, which also contributes if your muscles aren't able to extract oxygen very well. These next 2 slides are not meant to be in detail, but just to show you the different things that we can gather. These are all of the different things that we can get from our invasive cardiopulmonary exercise test, which then lead us to diagnose the different problems that I just mentioned for you. So really, this can give us a ton of information. Usually there's more than one thing that's going on, but we can then target our therapy to what's needed for those patients. So these are all of the different cardiac things that we talked about and the different parameters that we look for in our invasive cardiopulmonary exercise test. And then some pulmonary, and this is not an exclusive or all-inclusive list, I should say. There are many other things we can look for, but then our pulmonary limitations and our muscular limitations. All of these things, we can get information for our patients. We can then do treatments and reassess and see how they respond. But this can give us a lot of information for patients who have unexplained dyspnea or patients who really need more information about what's happening when they exercise that makes them have these limitations. So in conclusion, baseline hemodynamics are important to assess the severity of disease and guide our therapy. We should obtain them when our hemodynamics are not certain, when we don't know what's going on with our patient, or when patients aren't surviving as well as we expect them to. That should be a separate bullet point, somehow it disappeared, but also to assess severity of illness. And then if we aren't clear as to why somebody has dyspnea, we can do invasive hemodynamic assessment with the invasive cardiopulmonary exercise test to help evaluate dyspnea into the 3 buckets and etiologies of what can cause dyspnea. And that's all I have for you today. Our next speaker is Dr. Roble. He trained with us here at UT Southwestern, then left us for a while to go to Duke, and then we were fortunate enough to bring him back here, and he'll be talking to us about assessment of advanced heart failure.
Thank you for, excuse me, that introduction, Jenny, and thanks everybody for being here. You know, I titled this talk, "The Ambulatory Advanced Heart Failure Patient Looking Beyond Ejection Fraction," and because this is going to kind of serve as a link between Dr. Thibodeau's talk and I think the talks that will follow in the afternoon, looking at what we do for these patients. And I think, you know, as a personal anecdote, you know, one of the things I do in my role here is I do outreach clinic in Tyler and in Waco, and it's a very humbling experience. I think coming into faculty as from a trainee, where you think you know everything, and you know you're the best at everything, and you're gonna, you know, just do all these wonderful things. And the thing you're quickly reminded of is you were doing that both with supervision, but with every resource readily available to you. And I think anybody who's here or listening, not from UT Southwestern, I just have to reiterate or say that I think what you do is infinitely harder than what we do. And I really appreciate you all being here to try to hopefully learn something that you can bring back to your patients. So I do not have any disclosures. And you know what I hope to accomplish today is review a few of what I think are sort of the high-risk characteristics of ambulatory patients that sometimes can be overlooked and/or help identify that patient who, is doing okay, but actually is a little sicker than they appear on paper. And then sort of discuss certainly what we do here at UT Southwestern with once you have identified those patients, what we can then do to refine that individual patient's risk. So starting with a case of someone who I saw at one of our outreach clinics. This is a 64-year-old male, ischemic cardiomyopathy, and he was sent to me because ejection fraction never really recovered, had a repeat left heart cath, unchanged coronary disease, and there was concern that maybe he wasn't doing as well as he once was. Pretty long history of heart failure. EF was low years ago, recovered a little bit, has had some stenting, did get an ICD, but I think importantly, he was never hospitalized for heart failure and has never had ICD shocks. And I think a lot of that had to do with his otherwise underlying physical robustness. Again, if you look at his labs, of course, his proBNP was high, but nothing really jumps out. Kidneys are okay. When you looked at his echo, his left ventricle was dilated. But again, EF 15 to 20%. I think all of us have many, many, many patients who are in that category. RV not great, a little bit of valvular disease, but all of this on pretty good medical therapy. And when I saw him, I think it definitely took a little digging to see, where was he at symptomatically? Because again, working guy, tough guy, everything's fine, I'm good. And of course, I'm looking at his wife, who is just shaking her head, as is often the case. But truly, when I saw him, I wasn't totally sure how sick he may or may not be. And we'll come back to this case. But again, the question you're always posed with here, this person who walked into clinic, has never been in the hospital, do you really think they have advanced heart failure? And do you think this is somebody that might benefit from advanced therapies? And of course, there is some guidance in this regard, as I think we'll talk about further, but the I need help mnemonic for using that as a trigger to refer to advanced heart failure cardiologist. And the ESC has a pretty nice definition of sort of what they deem to be advanced heart failure with some functional data there. But, I think a lot of these are pretty obvious. The patient in shock, the patient in inotropes, the patient who's coming in and out. Anyone can pretty rapidly identify that that's a sicker person. But again, these don't encompass, I would say, everything that might help identify a patient who's a little sicker. And, I think while Intermax is not always a very clinically useful tool to apply to any individual patient that you see in clinic, sort of the patient that I'm talking about, would really kind of fit this profile 6 of somebody who, they can do most of the things. They can go grocery shopping. They feel fine just at home. But if you really push them, if they really had to do something, they're limited. And I think most of us oftentimes say, if they're doing okay, they're not in the hospital, they're taking their meds, they're not having any problems with that, we're okay with that, oftentimes. But, the reality is if you look at how someone in that category does, and again, this is data from Emory, that Intermax 6 person has about a 25% mortality at 3 years. And I think importantly also, when you look at the composite endpoint, most of those patients also don't get advanced therapies. So again, it doesn't mean that every one individual patient that might fit that category truly is needing that, but it identifies a population that probably needs a little more risk refinement. So, I think a couple of the two things I look at, there's many, but I think two things that I hope you can take away today to look at your own patients are how big is their ventricle and do they have a lot of MR? And so I'll start talking with just ventricular dilatation. Of course, I think fundamentally we're all here because what are our goals for our patients? We want them to live longer. We want them to feel better, hopefully both. And if you just look at LV diameter as a predictor for sudden cardiac death, and this is from an Oregon sudden cardiac death registry. I'm sorry, this isn't randomized data, Dr. Grodin, but LV dilatation, and this is defined as severe, so this is about a 7-centimeter ventricle that they define, is an independent risk factor and actually outperforms EF. And if you combine those two, that patient has a significantly increased risk of sudden cardiac death. Now, you may say, of course, this is registry data. LV diameter is a rather crude marker of sort of what a ventricle actually looks like. Well, okay. This paper was published, this was out of Spain, and this is patients in a heart failure clinic on medical therapy. Many of them have defibrillators, sort of well-managed patients. And they used MRI, which I think, again, often gives us a little, in terms of ventricular volume, refines sort of what the heart looks like, obviously a little bit more. And if you look at index to size, patients whose ventricle was big, both in diameter and volume, index to size, just that factor alone, again, at 5 years, 30% of those people are dead. So I think it's often easy to focus again on the ejection fraction, but the patient whose LV does not remodel, despite how they're doing, they remain at very increased risk for bad things happening. And I'm usually not short on opinions, but certainly one of my opinions is that if you see a patient and despite guideline-directed medical therapy, despite CRT, and their ventricle remains over 7 centimeters, that patient should be seen by an advanced heart failure cardiologist. I'm going to talk about MR and attempt to do this in a non-controversial way with the disclaimer that I think the MitraClip is a wonderful device and is a great thing for many, many patients. But I think we all as a community have to be thoughtful about who we apply that therapy to. And, obviously when the clip came out, great headlines, a revolutionary device, and I wouldn't disagree with that at all. And obviously, I think most people here are very familiar with the COAP data, and it was remarkable what this device did in terms of reducing hospitalizations and even mortality. But I don't think we can forget that if you look at the 5-year COAP data, in both groups, over half those people were dead. And I think, again, we all know this, it's treating a problem, you're putting a clip, treating a problem of the ventricle, not necessarily a primary problem of the valve. And you have to ask yourself, not just in the trial, but I think in clinical practice, how many patients who you're considering for mitral valve intervention might benefit from an LVAD, might benefit from a heart transplant. I think CLIP is the right thing for many, many, many patients. But again, I think you have to be very thoughtful about who you apply that therapy to. And this is by no means meant to suggest this is an apples to apples comparison. But if you compare people who were in COAPT to people who were in Momentum, which was our big HeartMate 3, our current LVAD device trial, and again, this is trial population, so real world's going to be different. Of course, in COAPT, it was an older population. The Momentum patients certainly were more intolerant of medical therapy and generally much sicker. But again, if you look at what happened at 2 years, and in red, I put the 5-year percentages. COAPT started with an older, but Momentum, I think we would all agree, is a much sicker population. Even at 2 and 5 years, you see marked differences in mortality. And even their KCCQ, patients in Momentum started lower and finished higher. 6-minute walk, same thing was true. And I think the figure on the left sort of really outlines, I firmly believe, of course, oftentimes you're really talking about 2 separate populations, but there probably is an overlap. And that is why I certainly believe that any patient with severe secondary mitral regurgitation who you're considering for a CLIP must be seen by an advanced heart failure cardiologist. And for the record, I've referred more patients for CLIP probably than I've referred for LVAD, but it requires a discussion. It requires a thoughtful review of all of that patient's data. So, maybe the patient you're seeing falls into one of these 2 categories, or maybe there's other things going on that worry you. And you think this patient, certainly is at higher risk. Well, what do we do then if we're worried about that patient? I think Dr. Thibodeau obviously talked a little bit about cardiopulmonary exercise stress testing, and I think that's really our go-to. But also we'll talk about right heart catheterization and how that can refine the risk for some of our patients. And when I'm talking to a patient about if I'm in Tyler and I need them to come to Dallas, I need them to drive and take time out of their day to do this test for me, I tell them this is like a lie detector test. You can tell me that you feel fine, you're not limited, and my answer is prove it. If I'm wrong, I'm wrong. Great, wonderful. You proved me wrong, but oftentimes I'm not. Maybe in this realm, not, many others, yes, but that's really what it serves for me is parsing out who's really sick and who's telling me the truth. And obviously there's other things we gain from doing a CPX in these patients. Of course, it informs prognosis. We can make sure that there's not another reason why they're short of breath. And I think in certainly a subpopulation, this actually is very helpful at providing an exercise prescription. I think everybody in that is in the world of heart failure very familiar with this data, and this has really formed the basis of why we use cardiopulmonary exercise stress testing to risk stratify who might benefit from advanced therapies, and again, people who were ineligible for transplant in the group 1, and if you look at the group 3 at the top of that, people who were too well because functionally they had a peak VO2 greater than 14, you see a marked difference in their mortality. And of course, not included here is the people that went on to transplant who had similar survival to the patients who were too well for transplant. But I also think importantly from this paper, what it nicely showed is that if you actually compare the hemodynamics of these people with their, I don't know where the pointer is, but the top right being their wedge, ejection fraction on the bottom left, and their cardiac index on the right, they're not that different. Which again, I think speaks to what a lot of us know, is that functional data is really, really important. And resting hemodynamics don't always tell the full story. Now, you might say this is from an era where patients were treated with digoxin, Lasix, ACE inhibitor. We didn't have the things we have today. You really still believe that this is all true? Well, in HF Action, they asked this question. And I think, again, speaks to the power of this test and the power of functional data that's still in a modern era. If you have a peak VO2 that's less than 12, your mortality is markedly increased as compared to people who are not as physically limited. Again, we do refine that a little bit, thinking about percent predicted, because of course a 20-year-old is not the same as a 70-year-old. And exercise duration, I have feelings on that, but can be prognostic in that regard as well. I think the other thing we know as well is that, especially as you go lower, differences between men and women maybe are not as prognostic. But again, functional data is very, very powerful in these cases. So going back to our patient, I did see him and I didn't believe him. So I did take him to the lie detector. And he exercised for 6 minutes, not good, and stopped because he was short of breath and had leg fatigue. His heart rate didn't change much. Again, we see that very commonly in our heart failure patients. And his blood pressure actually dropped at the end of exercise. Bad sign. He did try, but his peak VO2 was 8, which was 31% predicted. And he had a very high VE/VCO2 slope, which is also predicted of mortality. And at peak exercise, he wasn't using much of his lungs. So his heart was really, really limiting him. This was a very, very high-risk stress test. Now, of course, here we have CPX readily available, but that's not true everywhere. The machines cost a lot. You have to have techs who work with it. You have to have people who read it. So what if you're somewhere where you're worried about somebody and maybe you don't want to wait to get them referred, or maybe they're not sure they really want to drive or something like that? Well, what can you do? A right heart cath, if you have a cath lab, is readily available. And we get a wealth of information from this that is also prognostic. And I think it's somewhat obvious, but again, the patient you're seeing, if there's any change in their symptoms, if there's anything you're worried about, right heart cath is very safe, readily available. You can do it quickly, send that patient to the lab. And again, here on the bottom, data from Vanderbilt, and the primary goal of this study was really showing the differences between indirect FICT and thermodilution. But I think there was a lot of power, and again, showing that if you look on the far right of each of those bar graphs, both at the VA and the Vanderbilt, if just with resting hemodynamics, if you have a low cardiac index, your mortality significantly increases, despite how you're feeling, despite how you're looking. And I think, you know, this was data actually here from Parkland. And to further this point, again, these were all patients brought in for ambulatory right heart caths. These weren't patients sitting in an ICU on a balloon pump. These were patients who walked in off the street. And if you compare the groups who had a cardiac index less than 1.7, those with greater than 2.2, and then somewhere in between, of course, their hemodynamics in terms of their filling pressures are different. But again, if you compare those people who had a very low resting cardiac index at 1 year, almost 40% of those people were dead. And so again, even if you don't have cardiopulmonary exercise stress testing readily available, right heart cath is very easy to do. And that really can identify a people who, despite how they may look or feel, is at high risk for bad things happening. So our patient, again, coming back to it, after he had this cardiopulmonary exercise stress testing that did confirm he was as sick as I thought he was, this was his right heart cath numbers, elevated filling pressures, very low cardiac index. So we brought him into the hospital, started him on milrinone. He was evaluated for both transplant and LVAD, was listed for transplant, and he did okay for a little while on the milrinone, but then sort of quickly developed congestive symptoms again, was feeling tired, just not thriving. So we brought him back in for another right heart cath. His numbers looked actually a little worse than they did previously. And we placed an intra-aortic balloon pump, and he was transplanted about 2 weeks later. So again, you know, not every patient, of course, is going to fit this profile, but I think it speaks to the power of there are a lot of robust, tough people who, despite what they tell you, are a lot sicker than they appear on paper. So in conclusion, again, ambulatory advanced heart failure is very common, and it carries with it a pretty poor prognosis, despite those patients often looking great or well. Two things that I hope you can take away and look at your own patients is look at the size of their ventricle. And again, somebody who has severe MR that you're considering for mitral clip, which may be completely the appropriate therapy, make sure an advanced heart failure cardiologist is also involved in that decision-making. And then lastly, again, cardiopulmonary exercise testing provides great functional data, informs prognosis, and is really, really useful as a lie detector test, as I said. And again, even if you don't have that available, right heart catheterization, getting their filling pressures, getting their cardiac index is a very powerful prognostic tool. Say thank you, and if anybody, that's my email, that's my cell phone. If anybody ever needs anything, feel free to text or call. Thanks. Is everybody here? Yes, of course. Yeah. Is Julius here? Okay. So I know Hannah, Dale, and Robin are APPs that we all work together in clinic. And if I'm being completely honest, are the people who actually run the clinic. We'll turn it over.
I think if I remember correctly, you each had something that you wanted to hit on to start here. If you want to go ahead.
I'll go. So being primarily in clinic, seeing these patients that are on a lot of different medications and you're trying to push GDMT, Dr. Thibodeau, what would be your approach if they're kind of dragging their feet, don't want you to push meds because they feel as though their fatigue is related to their meds?
I think there's a few things that I would do. In all of my clinic notes, patients can access their clinic notes. I see it in my chart. On all of my clinic notes, I have what I told you, that use of these medications compared to no medications reduces your risk of death by 74% and reduces your risk of heart failure hospitalization by 85%. So I feel like empowering the patient, these are the reasons why, this is why I want you to be on these medicines, is very important. So I want them to understand the impact that these medicines can have. We also talk a lot about how the medicines may show, you might read about your medicines and say that they affect your blood pressure, and your blood pressure you're already worried about is a little bit too slow. And I explain the whole thing about SVR, and the way I describe it to patients is, think about this pressure outside of your heart as a pipe. And if that pipe is super narrow, it's really hard to get blood flow through it. But if we can give you these medicines to open up that pipe, you're going to get more blood flow to the rest of your body. Your blood pressure might actually get higher. And this is the reason why I want to do this. Specifically for fatigue or depression or nightmares or things like that, the beta blockers that we use for heart failure are carvedilol, metoprolol, succinate, and bisoprolol. I don't have too many people on bisoprolol, but bisoprolol does not cross the blood-brain barrier. And so for people who have a lot of the CNS effects and who say, I absolutely cannot tolerate beta blockers, I will not do it. I say, give me one more chance. Can I please try bisoprolol? And they tolerate it and their nightmares go away and their depression gets better and they don't feel the same fatigue that they do when they try carvedilol and metoprolol. So I always have that in my back pocket for people who are really resistant to beta blockers when I know that their cardiac index is okay and there shouldn't be a cardiac reason that they can't tolerate their beta blockers.
I have a question for Dr. Robel. You've really highlighted how the functional data from the cardiopulmonary exercise stress test is very invaluable. And we are fortunate here at UT Southwestern to have both that and right heart cath. I mean, what's your approach when you're seeing a patient in clinic and having both of these tools available? What's your approach in getting one versus the other or getting them simultaneously?
Great question, Dale. Yeah, so I think in general, especially when we're sort of thinking about, is this someone that, might be advanced therapies candidate, might need something like a transplant or an LVAD? I think the functional data is really my screening tool, obviously, sort of as I said. But I also think, that's, of course, you make sure there's nothing else causing their dyspnea, but I also think that's what kind of gives you a little bit more confidence that whatever you are thinking about doing is going to make them feel better. Because at the end of the day, despite what a heart looks like, and we have plenty of these patients, if they can get on a treadmill and do great, there's nothing, there's no transplant, there's no LVAD that's ever going to make them feel better. There may be some residual risk from sudden cardiac death, or they don't like their meds, and we can manage that. But I think that's why I certainly would prefer in that situation to know what somebody actually can do, not just what their resting hemodynamics look like while they're lying on a table doing nothing.
And to follow that question, so say you do the right heart cath and the stress test, and you think that, example, that he maybe wasn't as sick as you thought. Is there a timeline for when you objectively want to repeat that to kind of prove him correct?
Also a very good question. I think when I am talking to people, especially in I think in an outreach setting, and I'm asking them, to come to Dallas to do something, I also message to them that, of course, we are using this as a tool to figure out, are they sick enough? Are they not? But I think also what I emphasize is that it serves as a baseline, to your point, that, okay, if you do great and don't need to any of the things we're talking about, fantastic. I mean, the goal is for no one to need a transplant or a VAD. But at that point in time, when you told me how you felt, I know exactly what you could do. And so, I don't think there's necessarily utility in a programmed once a year or anything like that. But what I tell them is, when I see you again, whether that's 6 months, 1 year, 5 years, whatever, if there's been a change in your symptoms, you're going right back to the treadmill. And now I have a very good comparator to know what you could do and what you could do now. And it's very good evidence, I think, when talking to patients to put on paper, or at least, objectively show them, this is where you were and this is where you are now. I think the conversation's got to be a little different now.
Okay, so I've got some questions. So lots of things here. For Dale, Hannah, and Robin, what does a heart failure disease management program mean to you? What is that? Could you describe what that is, how that might be a different experience than prior experiences? And what are some of the things that we haven't talked about that includes that whole program?
So for me, the heart failure management program is not just getting GDMT optimized. It is educating the patients. And maybe this is more my nursing background, educating the patients on lifestyle changes, on dietary expectations, what they can do to be proactive in keeping themselves active and healthy, in addition to just taking this slew of medications all day, every day. I mean, it's more in family education as well, and emotional support for them.
Yeah. I would probably say, coming from general cardiology previously or interventional, what the heart failure clinic and the benefit of referring people to an advanced heart failure clinic is that you have these tools like Strong Heart, you have these tools like IV diuresis, you have the time to talk with these patients and educate them that more meds, obviously the patients think that's a bad thing, but that's actually a really good thing and a positive prognostic that you can get them on these meds. And then you have the diuresis clinic, which the psychological standpoint of going in and out of the hospital, the family members, all of the legwork, when you can see them in the clinic and provide outpatient diuresis where they're not, interrupted sleep and random people. They're in one room with one bathroom, and they know that at the end of the day, when successful, when it's beautiful, when it happens, they feel better and they didn't have to spend multiple nights in the hospital to do so.
I would say, just to add to that, I feel like coming into this program, there's been such an effort in reducing admissions and readmissions through all of our different programs here, Strong Heart, IV diuresis. So it's been good to actually see the data that Dr. Thibodeau put up and getting the rates down and being a part of that. So it's been very, very good.
May I? Dale, I have no data to support this, but I firmly believe that our patients have the lowest readmission rate of all providers here. And you do help me with some of my outreach patients, but also not. But I think one of the key things that, frankly, I have no idea how to do it. You do, I don't, and I don't even know where to find the information. But the remote patient monitoring. I'm going to, again, pump you up a little bit in that, I think you do a remarkable job at managing the medical therapy for our patients. But I think, can you provide some insight in how you use that, who you use it on, and how you use that data?
Yeah, so with the remote patient monitoring, we identify high-risk patients, like Dr. Thibodeau said earlier, or our frequent flyers that need a little bit more, I guess, intense or closer monitoring. So they have the tools that was on those slides earlier, the tablet, the blood pressure cuff, the scale, and it's very simple for the patient. They can just get a weight, a blood pressure measurement every day, and we see it automatically. So we're able to, get notifications if there's a weight gain, et cetera, and we can intensely monitor them and reach out to them much closer and sooner than if, it would be delayed and they end up in the hospital if we didn't have that program in place. So it's been very invaluable tool for sure.
I know for me personally, using the RPM system, especially, and we haven't really talked a lot about HFpEF, but in the HFpEF population, when we're trying to up titrate or down titrate their diuretics, and then in the HFrEF population, especially when they live further away, being able to more rapidly up titrate their GDMT based off of what their vitals are showing us has been a pretty valuable tool.
Dr. Groden.
So, terrific talks. It's so impressive what you all do on a daily basis, everybody up at the table. But, as Dr. Robel highlighted, and I think Dr. Thibodeau, obviously functional capacity is not necessarily cardiac specific. It can be the summation or integration of a number of factors affecting somebody's fitness or physical performance. And one key contributor to that might be body size, in particular, higher WHO classifications of obesity. And we've already seen in a number of clinical trials how weight loss, perhaps mediated by GLP-1 agonists, can be associated with functional status improvement. So I was just wondering how you all are integrating that. This is not directed at anyone, but this is really more of a very hot topic. And how do you integrate weight loss into your heart failure management for those that might benefit from it?
Well, one, and Dr. Groden did not know this, so thank you for this plug, but stay tuned for an HFSA webinar in July where I will be discussing obesity and heart failure and the different ways we can work to help with that. I think GLP-1s are really good for our patients. And if there's any way to get patients on GLP-1s, I will try to do that for them because it really is something that can help them. I also promote exercise. Every visit, I'm asking them about exercise. Even if exercise for them is different than exercise for me, I want people to keep moving because as I mentioned, the muscles are one of those 3 buckets. And so even if we improve your heart failure, we're still gonna need you to use your muscles so that your muscles can extract the oxygen so you don't have shortness of breath from that. So I talk about calories in versus calories out, try to get them on SGLT2 inhibitor, try to get them on GLP-1. We do have a weight wellness clinic that we can refer to for people who will need help with that too. But that's kind of how I approach it. Others?
So early on, one of the slides shows that MRAs for lifetime rank up there with beta blockers. And subsequent slide shows that the penetration isn't so good. Is 40 to 71% pretty much as good as we can get based on hyperkalemia, or what are the barriers to getting that number higher?
I think so. So I was also, those slides are all comers. So they very well might have contraindications. They might have renal dysfunction. We did not take that into account. So our numbers, if we were able to also document contraindications, then our numbers would look even more impressive. They might be, CKD4 and not able to tolerate MRA. So I don't have that data because this is just slice or dice or through Epic, who's on beta blockers, who's on MRAs, who's not. So I do think that SGLT2 inhibitor use can help to mitigate the hyperkalemia that we see. So increasing our use of SGLT2 inhibitors can help us tolerate the MRAs and the ARNIs a little bit better. So trying to promote that. But there are just some people who have, and especially in the heart failure clinic, who have advanced disease and might have kidney disease that just aren't able to tolerate it.
Okay, so this is a speed round. I want all 5 of you to shout either yes or no. Okay. My patient was just recently hospitalized for rapid AFib and there's HFrEF. And can I refer this patient to strong heart even if I think it's a tachycardia-induced cardiomyopathy?
Yes.
Come on, here, I can't hear.
Yes.
Yes, okay, very good. I have a patient on 4 pillars of GDMT, but the blood pressure is marginal. Can I refer the patient to Strong Heart Clinic to transition to an ARNI?
Yes.
Okay, last one. Strong Heart Clinic included post-discharge patients. Would a referral to Strong Heart be appropriate for someone with new onset HFrEF who has not yet been tried and not required a hospitalization for heart failure? Yes, okay, good. And then this is an important one. Where are we at with palliative care in the ambulatory setting?
So palliative care is obviously important for a lot of our patients. There is a palliative care shortage across the country, so hopefully there are more people who want to go into palliative care and that will kind of improve with time. I think that it is already. But we involve palliative care for all of our patients who we are considering for advanced therapies. But I think that there are also patients where they're not candidates for advanced therapies where palliative care needs to be involved. We're also fortunate here at UT Southwestern where we have some cardiologists who are really interested in end of life and have kind of pivoted their careers to be kind of cardiopally people. And so we're able to kind of spin off and use their expertise as well.
Got one more here. All right, so you're showing a lot of great recovery with intensive guideline-directed medical therapy for pillars, excuse me. What is your practice about when you offer defibrillator therapy? Is it 3 months? Is it 6 months and up? And how do you think?
So again, the faster you can get people on GDMT, the better the benefit. So really try to promote GDMT and get them to the highest doses as soon as possible. And then as guidelines would recommend, once they're on good GDMT, give them 3 months to try to recover more before you would reassess them. And there are some patients who they're more higher risk, and those are the people that you might think about for life vest if they were having arrhythmias before, things like that. But we did a long time ago at Parkland's looked at our patients who are new onset cardiomyopathy and followed them during the time that we were up titrating their GDMT and found that there were not a significant number of adverse events during that period of up titration of medical therapy. So it is safe to wait. There's now more data looking at MRI and looking at the amount of LGE that you see on MRI. And if there's a lot of LGE, that might risk stratify people to be a little bit higher risk and they might warrant ICDs a little bit earlier. But in general, I will up titrate GDMT and then give them several months to see if they recover.
And I'll just add, and maybe this is slightly controversial. I think obviously we all very well know that the risk for sudden cardiac death is very different for an ischemic versus a non-ischemic. A paper that I actually don't know why it didn't get a little bit more publicity, but one of my old mentors, Dr. Felker, published an Entresto sub-study. If you believe that Entresto is a better drug overall, it would be logical to think that there probably would be some benefit, I think, in both remodeling and reduction in sudden cardiac death. And, when they compared people at 3 months who traditionally would have gotten an ICD, and some of those people did, some of them didn't have an ICD already, but at 12 months, 50% of those people no longer meant indications. So I do think for non-ischemics, especially if they're tolerating really good doses, I often will wait longer.
So, you kind of highlighted some different phenotypic parameters, functional parameters, and hemodynamic parameters that might influence risk. How does, kind of dovetailing with the ICD question, how do abnormal arrhythmias kind of factor into your decision-making as it relates to maybe advanced heart, pursuing advanced therapies, or even how does that influence maybe even the short-term risk? Maybe you could expound upon that, maybe independent of some of the other things you said.
Yeah, I think when I talk to folks, the way I sort of broach that conversation is I often don't know, are you having this VT, this VF? Are you having these ICD shocks? Is this primarily a scar, a substrate problem, or is this a heart failure problem? I literally had one of those conversations this week, and I think that is one way. Of course, MRI is helpful, but I also think, again, where resting hemodynamics is very powerful. Because if you have somebody who has very elevated filling pressures, low cardiac index, I think you can feel a little bit more confident that that's related, more heart failure related than it is to their actual substrate. Conversely, if their right heart cath doesn't look so bad, then I think that's, of course, the type of person or what antiarrhythmics they're on. Have they had a VT ablation? And certainly want EP involved for consideration of that. Could you be more specific, Dr. Groden? I know
So
you're
how
not
about
short on
individuals
words.
that have had bi-V ICDs or cardiac resynchronization therapy? We know that up to a third might not have the clinical response we anticipate or we hope for. How does that influence their risk for advanced heart failure?
Yeah, I mean, I think, again, a lot of those folks, I think one of the questions you're asking is chronicity. Are you referring that patient for CRT, 5 years later, and you go back and look, they had a left bundle then? Of course, I don't expect that person necessarily to respond as well. But I think, to your point, that's one of those things that is always in my checklist. As a heart failure cardiologist, I guess I don't really pay much attention to the EKGs, but their QRS duration is one of the few things that I always pay attention to. Because you're right, I think sometimes, we get referred or even our own patients, and that checkbox was missed. And I know I'm not really answering your question, but I definitely want that person to always have a trial if indicated. And then certainly if there is no meaningful response, and especially no meaningful functional response, not just what their EKG looks like, then I feel like I've given it a good go, and maybe it's time to think about the next step.
I think what you're maybe getting at too is that the non-responders are at higher risk. And so those are the patients that we need to be following more closely and have a higher suspicion that they might be advanced heart failure patients, and keep a close eye on them. Yep. So as my example showed, I think we have to think a little bit past blood pressure. And so I will push GDMT if they don't tolerate it. That's my key to let's get a right heart cath and see why you can't tolerate it. And so until I do that and see that they have an SVR that's around 1,000 and their cardiac index is still low, and we've tried GDMT, what they are able to tolerate for a period of time, and this is still where we are, that's when I'll say that they're not able to recover. And obviously, maybe it's not obvious, but the newer onset people are much more likely to respond than somebody who's had chronic heart failure for years and now they're coming to us. So that's why it's important to get on good GDMT as soon as possible. The benefits are better the earlier you get them on.
So my name is Jane Farr, and I'm going to talk with you for 20 minutes. Yeah. Sorry, we're just going to wait until the virtual program's on. So just first of all, thanks to Justin Groden, Rob Moreland, and Katie Ginder for being co-directors for all of this, and all the staff we'll thank at the end. Okay, so 20 minutes. Okay, so I've been tasked to talk about survival to heart transplant or LVAD, and I'm going to try very hard not to talk about survival after those modalities. That's the task of Drs. Ruby and Michaelis. Okay, two disclosures, actually not really relevant to, well, one sort of. Okay, what do we know? That many patients with end-stage organ failure have not received adequate basic or disease-specific medical therapy. Transplant or VAD, but specifically transplant cannot solve decades of poorly controlled medical disease. Advanced heart failure therapies are costly and patient labor intensive and beyond the realistic scope of life for many individuals. And we've not really found great ways, at least, to meet all patients where they are and create a realistic care plan that translates into long-term survival. We do this, but this is really the goal that we have as heart failure cardiologists. So I'm just going to talk about a little bit about the evolution of heart transplant and just a little bit about VAD as life-sustaining and enhancing therapies for advanced heart failure. I'll mention the guidelines. 2024, we have new guidelines for value selection of candidates for transplant, and there are 2023 guidelines for LVAD that I think I'll leave to just more of Catherine's talk. I'll weave in a little bit of issues regarding ambulatory patients versus shock patients, and then something about expanding the donor pool so you get a sense of what we do when we're moving towards transplant, and hope to inspire somebody to be in this field because we think this is a terrific field, and it doesn't seem to be a field that fellows want to go into, but maybe the exact opposite is true for advanced practice providers. So I am a heart transplant cardiologist to my core. These are the things that I'm thinking about at night. But me included, first we're thinking about patients with limited life expectancy or poor quality of life. So look at these 4 individuals or 5. A 22-year-old presents with fulminant myocarditis or peripartum cardiomyopathy is in cardiogenic shock. 48-year-old with chronic uncontrolled hypertension, severely dilated and hypertrophied LV, CKD3B, pulmonary arterial hypertension will presume secondary. 59-year-old with this incessant VT from ischemic heart disease and had so much ablative and antiarrhythmic therapies. A 64-year-old with RV failure physiology and congestive hepatopathy and sclerosis and developing hepatorenal syndrome. 72-year-old with low output heart failure and markedly limited exertional tolerance. All of these patients need to be considered for advanced therapies. In none of these patients did I describe what their left ventricular ejection fraction is. It is their whole scenario. And there's so many questions that come up with all these patients. Too late, too early, wrong question, wrong therapy. Could I recover from this state? Could I recover from this state with an LVAD and guideline-directed medical therapy? And this is the world that we live in. Okay, concerning trends in heart failure, estimates are not just that they're on the rise, that they are on the rise in specific cohorts of individuals, younger people who are in rural areas, Black men and women, American Indian, Alaskan Native. These are concerning signals. Okay, we're talking about stage D heart failure, and we talk about how you describe stage D. You know it when you see it, and it's specifically characterized by multi-organ dysfunction. whether that's cardiorenal syndrome or renal vascular congestion or hepatorenal syndrome. But the theme is that it's taken over the body in a systemic way. And we would argue this is too late. So Chris Roblin, we didn't even talk about this, but I have the same concerns about co-op. MitraClip is a terrific therapy, but it is being delivered in folks who are stage D. Here's a depiction in a surgical graph with a surgical journal where they're removing, like, that old operations game used to play as a kid. They're removing the MitraClip through the LVAD cannula as they're putting the LVAD in. And the picture on the left, I have an acquaintance who's a New Yorker cartoonist, and I said, can you draw this for me? Can you draw a picture of someone getting an LVAD and then taking the MitraClip and throwing it over their shoulder into the MitraClip pile in the operating room? And the point here is that we'll get patients to the bitter and brutal end who've been through therapy after therapy, and then finally we'll get a call and say, I think this patient needs a transplant. And one of the things that we say is this person needed a transplant 3 years ago, or an LVAD. Okay, so then we talk about, well, not D, beyond stage C. And a couple of us did this with Vanderbilt and Duke, and we talked about all these different things, sort of a step back from stage D and all the different things. But if you notice, a lot of these things are descriptions, and then there's a 6-minute walk test less than 300 meters buried in there. But in all the things that Dr. Thibodeau said is, I don't really even say that we talked about a right heart cath in this paper and how important that is and how underutilized this tool is. Just to look at some of the guidelines, there doesn't seem to be a benefit that can be gleaned in stable patients. But there is some data to support doing this in progressive heart failure. I think one of the difficulties is that right heart cath data can also define the patient that's progressing. We use it a lot. I think the use of a right heart cath, whether that's in a patient that's still or exercise induced, can give us so much additional information. You've already heard a little bit about exercise or exertional intolerance and all the ways that we objectify this with VO2 max testing, and also simply with 6-minute walk testing. In our heart failure clinic, we've got a 6-minute walk test up and down the halls, and it can be very, very helpful. This is a little paper that I did with, now I'm looking back, 4 medical students and a high school student. One's now a surgeon, a psychiatrist, a cardiologist, and now a fellow at Duke. They're all still in my life. And we just decided to take a look at patients who were in our disease management clinic at Columbia University where I used to work. And they'd all gotten the same amount of tests as part of an evaluation. And they were ambulatory patients, not rehospitalized. And everybody got, and then I looked and said, well, what happened to them over a year? Now it's just a single center, highly biased. Where's Justin? Oh, he's on a bathroom break. Terrific, because he would tell me this is a biased study. We said, well, there was this curve separates. Some of these people were alive and some of them were dead. And we looked at the parameters and we saw that it was a combination of things that told us how sick they were. It was a pulmonary capillary wedge pressure greater than 20, so an invasive assessment. It was a VO2 max less than 14, another piece. It was an RV stroke work index, which is a calculation from a right heart cath showing us about RV dysfunction, and a MELD score is a combination of albumin nutrition and liver function and then kidney function. So when you put the whole story together, that is what helped us understand how sick that patient is. Okay, and many patients who we meet have never been in a disease management program, not ever. And I do think that when patients get referred, especially for transplant evaluation, they are opened up to a world of a sort of a holistic assessment. Same is true of LVAD, but they've been sort of looked at and considered in a way that they haven't holistically before. Okay, so there's guidelines on who we think needs a left ventricular assist device. We do know that the HeartMate 3, number 1, is the only device out there, and number 2, the survival is outstanding, and we see so much less stroke, and bleeding, which are the major disabling issues with this therapy, maybe a little bit more right heart failure. And there's all these ways in which we can see how valuable this pump is. And that's all I'm really going to say, and we'll leave this for Catherine. Actually, I'm going to even leave this for Catherine, but not this. And that is that even though we are seeing that the LVAD therapy is a remarkable therapy that can afford longevity and quality of life. The incidence of driveline or the rates of driveline infections are still very, very significant and can be very, very debilitating for patients. So there is, you know, there's lots of this in transplant too, in terms of what we say, trading one problem for another. But that is something that is really upsetting, especially to younger people. So when you look at the guidelines for who needs a transplant, what you start the guidelines with all the typical things that I just said and what has been discussed in this therapy. But the thing that I look at most is end organ dysfunction, end organ dysfunction, end organ dysfunction. There's lots of ways that patients don't do well after transplant or do very well, and Lauren Truby will address this. But the only thing that patients want to know is stuff about this slide, right? They want to know, am I eligible and how long I will live? We'll get to that in a bit. What are the relative contraindications? Frailty, uncontrolled diseases. Diabetes is such a killer because it really shows itself post-transplant in very significant ways. Advanced end organ function, you know, stroke history, active illness, something inflammatory, something rheumatologic, malignancy, and then someone who really doesn't have the kind of support that might be needed. But we try to stretch very, very hard to try to find patients ways to do this. There's data about this. The American Society of Transplant tends to put out some of the data that is much more obviously American specific. We have some details about how frail is frail and how we can objectify that information with a hand grip and what's called a Fried's Frailty Index, and there's a number of different assessments. The overarching problem of renal dysfunction comes up over and over again. You ask the question, why are you not so many of your patients on MRAs? Because some of them have CKD 3A, 3B, 4, and they are past that, which raises the question, what kind of end organ damage is part of their story, separate from their story, but it certainly impacts on their opportunities for advanced therapies down the line. And we do know that a GFR less than 80 might be a signal for not doing so well after transplant, and certainly less than 30. Okay. There are new definitions for pulmonary arterial hypertension, which is shocking because it's mean pulmonary pressure greater than 20. That's a shock, right? But there's prognostic implications to that. And this was a paper that Ryan Tedford did looking at folks who got transplanted and who did worse, and he controlled for a number of different variabilities and variables, and found that pulmonary hypertension was a leading cause of mortality after transplant. And there are guidelines about pulmonary hypertension, how to identify it, how to try to determine if it's a reversible and whether it's not so severe that you can't still get a VAD or transplant. This is very, very important. So when patients come to see us late, and we think they're too sick, it's often because their kidneys aren't working well. And it's often because they developed a degree of pulmonary hypertension that we cannot manage. That is specifically true in patients with restrictive physiology, amyloid, and hypertrophic cardiomyopathy. We have guidance on cancer. Don't presume that your patient who has cancer is not eligible for transplant. There is almost no scenario except for quite end-stage prostate cancer where your patient is not eligible. We have guidance on leukemia and lymphoma, a little bit trickier to manage or even to pose as a risk and compete with the benefits of transplant. And importantly, part of our evaluation, and there's such a shortage in this country of palliative care specialists for advanced diseases, and in our world, advanced heart failure. Okay, so there's issues of who's eligible for transplant and how tricky it's going to be and what the risks are, and sensitization against prior blood transfusions in pregnancy is a big one. We are a center that is looking hard and exploring wide how we can manage patients who are sensitized going to transplant. It is hard for patients to try to do this, and there are risks involved. But these are the types of challenges that we have once we decide someone does need a transplant. This is what I was really talking about. When you come in for a VAD or a transplant evaluation, and ideally it would be for heart failure disease management, we are looking at absolutely everything. We want to know what your healthcare maintenance has been. We want to know the degree of function or dysfunction in all of your organs, from neurologic to your bone health. And I think patients, that's therapeutic for them. Sometimes patients come in very, very sick, and we do sort of this whole assessment and set up all these plans, and they actually get a lot better, not just because they get guideline directed medical therapy, but they get a better appreciation of why it is so important to have a pneumonia vaccine or a colonoscopy and all the things they've been sort of suggested to get over time and have sort of, just dismissed. Social support adherence and mental health are critically important. Transplant candidates are not born, they have to become. And it really takes time to get people to trust and to buy in and to focus and to prioritize and to know that it's worth it. For their family, it's worth doing, because this is obviously incredibly difficult. And only a few of us really know what that really feels like, Mr. Henry here in the room. And substance use disorder and use, these are sort of evolving questions. The world is changing. Is it so bad if your patient has a couple of gummies and this, so these are the types of things. How does it impact on their organ function? How does it impact on their transplant adherence? What are the reasons that we need to consider some of these therapies? Okay, so we're increasingly going to dual organ therapy for most of the reasons that I just described, that patients are coming to transplant so late that they often need 2 organs. And this is just a cursory view of a couple of years ago, how many dual organ candidates we were considering. And there's a variety of different combination. And there's a couple of them have this sort of tricky congenital heart disease, dual organ. Kate Kearney will talk about that, but they're really about advanced disease. You have to understand something about the transplant system, and this is part of the education that we give to patients, and we have a whole service line that helps bring these patients in, because there's a lot of things to learn for all of us and for patients to understand. Okay, so patients by and large, before there used to be new allocation, would go into transplant, at least 50% across after a mechanical circulatory support. And then there was a change in allocation 2018, where the majority of patients now were going straight from a shock or a temporary mechanical circulatory shock situation. And the reason that's relevant is all the things that I just told you are all about the ambulatory patient, where there's plenty of time to teach and learn and educate and all these things. But the fact of the matter is the majority of patients these days are coming in shock. Many of them are coming over on Impellas. There is no time to educate, to look, to evaluate. We have to make hard decisions. We'll have to make hard decisions about patients who are in shock, not just in our own institution, but in your own institution. Is your patient going to recover, and how do you know that? And if I call it the patient center mismatch, are they in the wrong center? And I don't mean that in a bad way, not for shock management, but for the next step. Using SCI risk stratification is critically important to see how ill your patient is after shock. And some of the things that we've done here at this institution is automate that process of shock severity to get a clear understanding. Before we can see it, the computer can see it. And I think we're working with this. We do know that patients who've been through shock and are survivors of shock are neurocognitively impaired, many of them, and frail. So if we allow shock events to be the trigger for advanced therapies, these patients are even going to be harder to recover and bring to the table. I do know from a series that I was involved in Impella 5.5 and for shock across the country, what we looked at to see is, and this is really, well, about 67 people, 7% of patients survived. 46% went on to heart replacement therapy, and 21% had native heart recovery. But these were on Impella 5.5, so they could ambulate and so forth. The median time to recovery off pump was about 12 days. The median time to heart recovery was 12 days. Mortality was about 12 days, and going for VAD or transplant evaluation was about 12 days. What I'm trying to say is we don't really know who's going to recover and how you can test that. And when we look in shock trials and we see, well, why didn't they do better off ECMO or this or that? It's because at different centers, you have different things that are available. Everyone's entitled to die. Everyone's entitled to recover. Only some people are eligible for a VAD, RV failure, whatever. Only some people are eligible for transplant for different reasons. But you can't even be evaluated for things if you're not in the center that can offer 2 of these modalities, the 4th one being death. I'll finish up soon. Let me go here. Let me tell you a couple of things about donors. Transplant is becoming increasingly difficult. The opioid crisis is probably starting to turn down, which is terrific news from a public health point of view. We are looking for different donors. We have expanded our donor pool to donation after circulatory death, hepatitis C and B, active viremic positive donors, even HIV positive pos. We know that the first transplant was a donation after circulatory death, and now this is back as around 2018. There was a big clinical trial that demonstrated non-inferiority of DCD to DBD. We did our first DCD transplant for heart about 2.5 years ago, and it's now 32% of our volume. This is how one way we've increased our volumes. There's been 5 HIV positive pos transplants done in this country, many in liver and kidney. We were one of those folks. It was a big multidisciplinary effort. We have 2 folks here with pictures, but it was a team of about 20 people who did this, and the patient's doing very well. I will leave you with this slide. This is a slide that Lauren Truby and I wrote about sort of the status of transplant, in the country. And the role that the guidance that we were given to write this paper was new allocation in this country 5 years later, and it took us so long to write that we had to change the title to new allocation 6 years later. But there's a lot here to talk about what transplant is. So even if you yourself is not a transplant cardiologist, reading the guidance on who's eligible for transplant, and then of course VAD, reading something about transplant, I think you can get into our shoes and see what we need. And the last thing when it comes to training, there are 147 adult and pediatric transplant programs in the country. Some of them perform no transplants, but are still open. Some perform less than 10, some perform less than 10 to 20. There are very few centers that are offering high volume, important experience at every level, junior attending, faculty, fellows, advanced practice providers. Find a big volume center if this interests you to send your patients to and train in and work in. It's an extraordinary experience. I think that's all I have. Oh, and this is our fun. This is our holiday party. This is every APP pharmacist, insurance person, everyone. We're all having a wonderful time. And the only person who wasn't there is our chief surgeon, Matt Peltz, who was in the OR. And right now he's in the OR. And so thank you for your time.
Well, thank you, Dr. Farr, for that tour de force of management and evaluation pre-transplant. I've also been tasked with the difficult problem of the overview of surviving and thriving after transplant in 20 minutes. So I will do my best to make this a high-level overview, but obviously we can dive into the details and questions in our Q&A and panels. Nothing relevant here. So I think before we talk about how we can help our patients survive and thrive, we have to understand the epidemiology of outcomes in post-transplant survivorship. So very quickly, by show of hands, who in the room thinks that the median survival after transplant is between 0 and 5 years? Show of hands. 5 and 10? 10 and 15? You, all right. 15 and 20. Oh, we have an educated group. I love it. All right. So we'd like it to be between 15 and 20. But the reality of it is that for all comers to heart transplantation, and this is data from the International Society of Heart and Lung Transplant, we know that the median survival after transplant, 50% of our patients will live to 13 years. And importantly, that survival actually will increase to close to 15 years conditional upon 1 year survival. So we know that that 1 year, that early post-transplant period is really critical in ensuring improved longevity in our patients. But to that end, thankfully, we know that a little over 90% of our patients will make it to the first year. But the other flip side of that is we know that we will lose 10% of our patients in this early post-transplant period. And that's really where we have the most ability potentially to move the needle in terms of long-term outcomes. So with this as a framework, I'll spend a little bit of time talking about sort of early, midterm, and long-term survival, and what are the individual contributors and individual factors that can help our patients sort of make it through those milestones. So when we think about early post-transplant outcomes, it's all about net state of immunosuppression. How can we balance the risks of infection and rejection in the early post-transplant period when our immunosuppression is at its sort of highest intensity? So you'll see a number of these graphs, which again are from the International Society of Heart and Lung Transplant Registry. And what these are really showing on the bottom, sort of the x-axis you see in days to years. So the first 3 time points are 0 to 30 days, up to 1 to 3 years. That infection, not including cytomegalovirus, is really the leading cause of death. Over 30%, for example, of deaths within 30 days to 1 year are related to infection. And you can see sort of in tandem, up to 10% of deaths in the first 3 years are related to acute rejection. And clearly, these are two sides of the same coin. And so understanding how we can personalize and be more precise about balancing these two risks and understanding and quantifying each individual patient's net state of immunosuppression, which I'll talk about in a bit, is really of paramount importance. As we turn our attention to mid and long-term outcomes, then the focus really becomes how can we minimize the toxicities that are inherent to our immunosuppression. And unfortunately, we are limited in the drugs we have to use. We have not had advances in pharmacotherapies in over a decade, but these are the best drugs we have. And the best drugs we have, unfortunately, come with side effects. And we know that the risk of renal failure from calcineurin inhibition exposure, for instance, and the risk of malignancy is directly tied to these therapies. And so anything we can do to minimize the amount of immunosuppression that we're providing our patients as they move through their transplant journey may help us to limit these toxicities. And finally, at the end of the talk, I'll talk a little bit about cardiac allograft vasculopathy, which may be familiar to you, many of you in the room. And I truly believe that this really remains the Achilles heel of our ability to achieve long-term survival in many of our patients. By 10 years' time, over 50% of our patients will have some degree of allograft vasculopathy. And as you can see here, as time goes on and we progress through their transplant journey, this becomes a larger and larger contribution to post-transplant mortality. So with this background in mind, here's sort of my overall goals for the talk really is to talk about how we can minimize this early morbidity and mortality vis-a-vis both managing the net state of immunosuppression. I'll touch a bit on perioperative complications. I'll talk very briefly about some strategies we employ here at UT Southwest in a multidisciplinary fashion to minimize and mitigate some of these toxicities, and briefly touch on how we can improve the progression and development of CAV. So to start with net state of immunosuppression, this is complex. And when we think about the net state of immunosuppression, what we're really describing is the combination of, number one, the drugs and therapies we're giving to a patient. Number two, how critically ill they are. Are they in the ICU with multiple tubes and lines? Are they sort of have chronic critical illness and mucosal barrier violation from a number of different things? How sick were they coming into transplant, right? How advanced was their heart failure, as Dr. Farr has described? And then we're increasingly understanding that there are certain immunogenic phenotypes that may predispose certain individuals to have a higher or lower net state of immunosuppression in the setting of certain immunosuppressive agents. You have to take all of these into consideration when you try to decide who is at higher risk of infection and who is at higher risk of rejection, and how should we titrate their immunosuppressive therapies in accordance. What's also important when we think about infectious complications after transplant is the fact that this is dynamic. The assessment of net state of immunosuppression is a very dynamic process that changes even throughout the first year. So as you can see here in this sort of nice figure in the first month, we're really thinking about nosocomial insults, right? We're really thinking about things that happen in the ICU in the peri-transplant period. And as we move through that first year of transplant, we start to think about community-acquired infections. We start to think about things like CMV and EBV, which are directly related to the sort of degree of immunosuppression that we have imposed upon our patients with our immunosuppressive agents. And then as we move on, again, we start to think about more sort of invasive fungal infections and other things that may affect our patients when our net state of immunosuppression is too high, too long after transplant. But I think the take home of this slide is that the assessment is dynamic and requires a multidisciplinary team to manage very closely to get through this critical period of the first year. And I just want to show you one real world example. The green, pink, and blue lines represent neutrophil count, white blood cell count, and absolute lymphocyte count, respectively. And this is a real patient that we've been caring for in his first year post-transplant. On the bottom, what you can see sort of in the purple in fine print is all of the changes that were made in his immunosuppression over the course of a 3-month period. And you can see as the patient develops sort of progressive lymphopenia, progressive neutropenia, a series of changes are made. Immunosuppression is minimized in order to facilitate a rebound in his sort of overall immunocompetency, and hopefully in that regard, a decrease in his risk of infection. And these decisions require a multidisciplinary transplant team of coordinators, of APPs, of MDs to really look at each patient individually, following a protocol, but obviously tailoring that therapy to what's happening to the patient in real life. And this is how we here really think about managing net state of immunosuppression. The other thing that obviously affects our patients in the early post-trans period are hemodynamic insults. And I want to spend something that's near and dear to my heart. I'll spend a couple minutes just talking about PGD. Sorry to my colleagues. I know your guys like, not PGD again. So PGD, what is it? It is a primary graft dysfunction. And what we really think about this is sort of an acute failure of the transplanted heart. We put a new heart in, we expect it to work fine. And for reasons that we don't fully understand, that heart fails acutely, right? In its most severe form, which we define as sort of requiring VA ECMO or other mechanical support after transplants, it can affect up to 8% of our transplant recipients. And if you develop severe PGD, contemporary data would suggest that your 1-year mortality can be between 30 and 40%. This is not an insignificant problem. Dr. Farr set this up nicely to say that many of our patients are coming to transplant with both durable and temporary mechanical support. And what we know is that in the contemporary era, we have data to suggest these are both risk factors. But the good news is, at least here at UT Southwestern, we have access to novel preservation and recovery strategies that may mitigate this risk. And I'll touch base on 2 of these devices briefly. I'm really proud that we are part of the International Consortium on PGD, which is over 14 centers around the world that's contributed data on over 4,000 heart transplant patients to really help us understand better what's happening with PGD in the country. And the 2 take-home points are that PGD is increasing. And I think this really speaks to the fact that more of our patients are coming to transplant on durable VAD support and on temporary mechanical support. And as we see trends, especially in temporary support, increasing, so too do we see trends in PGD. On the left-hand side, you can see the percentage of patients per year in the consortium that were affected by severe PGD. And you can see that from 2010 to 2022, that trend is increasing over time. On the right-hand side, in the sort of horrible color orange, sorry about that, you can see the percent of patients with PGD that came to transplant off of VAD, and in purple, those that were medically managed. And I think everyone can appreciate the fact that severe PGD rates are much higher in those coming to transplant on mechanical support. And specifically, what we found in the International Consortium was that over 12% of patients with durable VADs would develop severe PGD versus closer to 7% in those medically managed. And the risk factors for severe PGD in our VAD patients were ischemic time, so the total time that it took us to recover that heart, and things like CVP to wedge ratio and other indices that may suggest some subclinical RV dysfunction. When it comes to temporary support, we also know that our patients, at least by our consortium data, have almost a 2-fold risk of developing severe PGD when they're coming off of some sort of temporary mechanical support. And the risk is largest off of ECMO, with our sort of the odds ratio of severe PGD being almost 4 in our patients coming off of ECMO in this consortium. So what can we do about this risk? Well, thankfully here at UT and in many other places, we have a number of novel organ recovery platforms that I think hold really great promise in terms of mitigating some of these risks. On the left-hand side, you can see a temperature-controlled storage device, and on the right-hand side, a hypothermic oxygenated perfusion device. When we talk about temperature-controlled storage, this was a very nice study done from the Guardian Registry, which looked at patients that were on LVAD support prior to transplant, so presumably a group that was particularly at high risk for severe PGD. And in sort of an observational fashion, again, not randomized data, Dr. Groden, they compared the incidence of severe PGD in those with traditional cold storage on the left and those in the temperature-controlled storage on the right, and found 14% versus a little over 5% in terms of severe PGD rates, with a pretty significant reduction in terms of the odds of developing severe PGD. And work that we did here with Dr. Peltz, who's in the OR, would suggest that this may be in part because of an attenuation of ischemia reperfusion injury. The y-axis here are post-operative CKMB values, so a leak of cardiac enzymes, and you can see these at post-op day 0, 1, and 2. And consistently throughout post-op day 0, 1, and 2, those patients in red whose organ was recovered using a temperature-controlled storage modality had a lower leak of cardiac enzymes, suggesting some cardiac protection that is conferred by this device. Next, we'll turn our attention to something called ex vivo, which is a hypothermic oxygenated perfusion platform. We were part of the ex vivo trial here in the United States. This is actually data from the European ex vivo trial, which was a randomized controlled trial of this ex vivo hypothermic oxygenated perfusion, or HOPE, versus traditional ice storage. On the left, you can see the sort of cumulative incidence in terms of outcomes for mortality and follow-up time in those first 30 days between the two groups. And on the right, importantly, all the way to the right, that last column, you can see the difference in severe PGD rates. 20% severe PGD was seen in the traditional cold storage group versus 5% in the hypothermic oxygenated perfusion group. And at the very bottom, you can see that the treatment effect or odds ratio was about 0.2 for the oxygenated group. And importantly, this is in Europe, where the donors aren't as of high quality as they are in the United States. So I think this suggests that if we were to apply this to our population, again, there may be a lot of opportunities to mitigate PGD risk, particularly in our highest risk patients. Next, I want to turn our attention to some of the strategies to minimize the toxicity of immunosuppression. And frankly, this talk could be an hour in and of itself, so I'll try to just provide some very high-level overview, and then we can get into some of the details in the panel discussion. So just as a reminder, in terms of the toxicities, we think about the things that are on all of our minds are primarily malignancy, mostly skin cancer, but obviously other malignancies, as well as renal dysfunction. And those are the two that I'll focus on here this afternoon. So what do we know about renal dysfunction? We know that our ability to minimize calcineurin inhibitor exposure, so tacrolimus and cyclosporin, may confer protection from nephrotoxicity. Now, this graph here comes from one of the first randomized controlled trials of mammalian target of rapamycin inhibition versus calcineurin inhibition in heart transplecipients with early withdrawal of calcineurin inhibition, called the SCHEDULE trial. And this is actually long-term follow-up of the SCHEDULE trial. The y-axis of this graph is glomerular filtration rate. And this goes all the way from pre-transplant to 10 to 12 years after transplant. And what you can see is that the yellow group, which was the calcineurin inhibition group, from 1 year all the way to 12 years after transplant, had a significantly lower glomerular filtration rate than those patients that were treated with an mTOR-based therapy. Now, the caveat to this is this was a CNI sparing protocol, but I think we typically use this data to justify the fact that CNI minimization should also have a similar effect in terms of renal protection when we start it early and use it sort of throughout the transplant course to try to help to protect the kidneys. And obviously in our program, we try to adopt a mammalian target of rapamycin therapy early on after the first year post-transplant for all of these reasons. The other thing that I spoke about is malignancy, and this is something that is always on our mind when we care for our patients, especially those who are later in their transplant journeys. The good news is, at least in the thoracic population, things are changing. This is actually data from one of the Scandinavian registries. We've obviously already seen some excellent data from Scandinavian registries earlier, looking at the rates of malignancy sort of in thoracic heart and lung transplant patients in 2 different time periods. So the dark line that you can see on top is actually a cohort from 1987 to 1999. And on the bottom, you can see a cohort in gray from 2000 to 2016. And thankfully, as we have transitioned to newer immunosuppressive agents, namely made the transition from cyclosporin to tacrolimus-based calcineurin inhibition, and importantly moved away from azathioprine and toward mycophenolate-based antimetabolites, we have seen a reduction in the overall rates of malignancy, driven at least in large part by skin cancer reductions, but obviously in non-skin cancer reductions as well. So I think although we still have a lot of work to do in terms of mitigating this risk, thankfully our newer agents seem to at least be doing part of the job. And then finally, I just want to spend the last couple minutes speaking about CAV, or cardiac allograft vasculopathy. You know, CAV, importantly for those that aren't familiar with this entity, is very different from CAD. CAV is an obliterative vasculitis. It is an obliterative vascular process that involves the progressive thickening of the wall of the actual epicardial arteries to the point of obliteration. And you can see here on the left, on the very left, we have sort of a normal epicardial coronary artery with a nice thin wall, a thin intima. In the middle, you can see an example of coronary artery disease, of sort of typical atherosclerotic coronary disease, where you have a focal plaque-based sort of lipid-laden lesion, right, which is limiting flow through the artery. On the right-hand side, you can see an example of sort of intimal medial thickening that is classic of cardiac allograft vasculopathy. And you can see on the sort of in the middle of that figure, it is panvascular. The entire blood vessel is involved. On the bottom, you can see sort of nice examples of histology, right, where you can see sort of the focal lipid-laden plaque in the middle versus the sort of circumferential thickening that is characteristic of CAV on the right-hand side. What's important to know about CAV, as I mentioned, is that by 10 years, about 50% of our patients will have angiographic evidence of disease. That doesn't necessarily take into account disease that we see, for example, by intravascular ultrasound, which we use as a screening modality here at UT Southwestern. But what's also important is after the development of CAV, after we diagnose it, we do see a significant impact on survival. And you can see here sort of in years, sort of time after diagnosis of CAV, the red line are those that have been diagnosed, the green line, those without prevalent CAV. And so clearly this is something that does affect our patients' longevity. Importantly, and very frustratingly, we don't understand exactly why our patients develop CAV, but we believe it to be a combination of immune-mediated factors as well as cardiometabolic factors, because we know when we look at that intima under a microscope, we see a combination of infiltrating macrophages as well as lipid deposits and other things that would be more characteristic of CAD. So if we don't have targeted therapies for CAV beyond sort of changes in immunosuppression, what else can we do in a multidisciplinary fashion to sort of help slow the progression? And I think we've been turning increasingly toward mitigation of other cardiometabolic risks to ensure that those aren't necessarily contributing to the progression. This is a really nice central figure from a review that was penned by our own Dr. Garai, who's in the audience, sort of looking at the multidisciplinary approach to cardiometabolic risk mitigation in our patients. I will say that in our heart transplant clinic, we are increasingly aggressive about use of PCSK9 inhibition, for example, which was tested in a randomized fashion. Looking at CAV though, has been shown that in those with baseline increased intimal thickness, they may have some regression of disease. We're very aggressive about optimization of glycemic control with aggressive use of SGLT2s, both for renal protection as well for improvement in overall blood sugars. And then a multidisciplinary approach as has been discussed earlier to GLP-1 agonism used both for weight loss, for cardiovascular protection. And there is some animal model data that would suggest that there may be some regression of CAV in mice models. And using this sort of multidisciplinary team together, we can change the things we can change and hope that in the next 5 to 10 years, we can understand why the things we can't seem to change are happening. So in conclusion, in terms of early post-transplant outcomes, really multidisciplinary management of NET state of immunosuppression is the name of the game. We know that access and expertise with some of these novel recovery platforms may decrease the risk of primary graft dysfunction, and we're very lucky to have access to these platforms here at UT. Importantly, we are very aggressive about early introduction of mTOR inhibition to really focus on decreasing toxicities by minimizing exposures to maximum doses of calcineurin inhibition and really eliminating the use of older immunosuppressive agents. And we really do use a multidisciplinary approach for cardiometabolic risk mitigation in CAV. And importantly, it does take a village to help our patients survive and thrive. So with that, I will thank you. And it's my pleasure now, I think, to introduce Dr. Catherine Michaelis.
Thank you so much for that introduction. I'm Dr. Catherine Michaelis, and today I'll be discussing LVAD survivorship. So today in this talk, I'll discuss for patients who have an LVAD, the event-free and overall survival. I'll review some of the predictors of early and late mortality. Then I'll review complications after LVAD and their rates, and some of the conditional survival data for patients. So I wanted to start off by looking at this data from the STS Intermax database. This was a retrospective analysis that included over 24,000 patients who were implanted with a durable continuous flow device between 2010 and 2020. So this includes all of the modern LVAD devices, but of note, the HeartMate 3 was FDA approved in 2018. And so a lot of this data does reflect the survival data for patients with the HeartMate 2 axial flow pump and the HVAD, both of which are no longer being implanted. The baseline characteristics for patients in this analysis, 78% were male, and the median age was 57. The majority of patients, 51%, were implanted with a destination therapy strategy, and the median follow-up was 15 months. In the top graph, this is the data for patients aged younger than 65. And just focusing, this shows the competing outcomes. Focusing on the black line, that's the showing death on a device. And you can see that at 5 years, the rate of death on a device for patients who were aged younger than 65 was 33.5%. Now, for patients aged 65 to 75, that's this graph here on the bottom, focusing on the black line there, the rate of death during a device was 54%, and then that rate of death during support increased further to 66% for patients who are aged over 75. So we're seeing that as patients get older, their rates of death increase. Now, when we focus on this data, just looking at those older adults, so aged over 75, and stratifying their survival by era, we can see that as we approach our contemporary era of LVAD implants, the survival improves. So the 3-year survival for patients aged over 75 implanted between 2017 and 2020 was over 55%. Now focusing on patients with a HeartMate 3 device. So again, that's the only device that we're currently implanting now. This is the long-term follow-up, so the 5-year follow-up of the Momentum 3 trial. And on the left is patients who had event-free survival. So that's survival free from disabling stroke or reoperation to replace or remove a malfunctioning device. And on the right is overall survival. So just focusing on the blue line, that's for the centrifugal flow pump, the HeartMate 3. 5-year event-free survival was 54%, and overall survival was 58%. And this is some interesting data from the Momentum 3 5-year follow-up looking at New York Heart Association functional class. So for patients who survived to 5 years, nearly 70% of patients in both groups, irrespective of whether they had a HeartMate 3 device or a HeartMate 2 device, had relatively good functional status and performed pretty well on a 6-minute walk test. Now shifting gears a little bit, I wanted to discuss some of the risk factors associated with early mortality after LVAD. So this is again data from the STS Intermax database and focusing on mortality within less than or equal to 3 months. And really the most influential factors are dialysis within 48 hours, critical cardiogenic shock, major stroke, and female sex. And why is female sex something that might be a risk factor for increased early mortality? So what was hypothesized was, one, women tend to be caregivers, and so potentially they don't have as good caregiver support themselves after surgery. Some women tend to be more frail. And then also some studies have observed a higher rate of bleeding and also stroke for women versus men after LVAD. Now, getting into some of the risk factors associated with later mortality, so after 3 months, the factors that emerge are really more psychosocial issues like psychiatric issues, limited social support, and then frailty. So this was a study focusing on the HeartMate 3 population, looking at some of the predictors for long-term mortality. In this analysis, they focused on patients who survived a hospital discharge and were enrolled in the Momentum 3 trial. At baseline, median age was 62. Approximately 80% of patients were men, majority destination therapy, and overall, this was a fairly sick population. Approximately 1/3 of patients were Intermax profile 1 or 2 going into LVAD. So the pre-implant risk factors that were identified are elevated BUN, prior CABG or surgical valve procedure. And then important post-implant risk factors are low GFR, less than 60, ventricular arrhythmias occurring during the index hospitalization, and index hospitalization hemocompatibility related adverse events. And that's really defined as a mix of stroke, bleeding, and device thrombosis. So overall, for this cohort of patients with a HeartMate 3 device, the 5-year all-cause mortality was 38%. But then if we focus on patients who are low risk and have none of these risk factors, the all-cause mortality is fairly low, 22.6%. And now just focusing on each of these risk factors. So for patients with the risk factor, with the blue line, and without the risk factors, there's about a 12 to 13% difference in mortality at 5 years. Now, when we focus on the post-implant predictors of long-term mortality after HeartMate 3 LVAD, I really wanted to focus on the hemocompatibility-related adverse events. And so you can see for patients who had experienced a hemocompatibility-related adverse event, their 5-year mortality was 70.7%. So extremely high, especially compared to the group without that risk factor. Now looking at this data a little bit differently, in terms of looking at 5-year survival. So for patients who have none of those risk factors, 5-year survival can look as good as 77.4%. So a well-selected patient who does well with low complications immediately after LVAD implant and survives to discharge can expect to do very well. However, patients who have a combination of pre and post-implant risk factors may have a much lower survival. I wanted to spend a few moments discussing the HeartMate 3 survival risk score. And this isn't something that I calculate necessarily when I'm evaluating a patient for LVAD, but I think it's important to think about these different variables, and these are definitely something I consider when I'm looking at a patient. And so this includes 6 pre-implant variables: age, again, prior valve procedure or CABG, sodium with low sodium levels reflecting worsening congestion, BUN, elevated BUN may suggest worsening renal function, left ventricular end diastolic size less than 5.5 centimeters, so a small LV cavity can make a patient higher risk. It can be more difficult for the device to sit well. And then an elevated right atrial pressure to pulmonary capillary wedge pressure ratio greater than 0.6, reflective of RV dysfunction or failure. And so this score provides survival predictions at 1 and 2 years post-implant. It can be used to segregate patients into different tertiles with higher than average survival, and lower than average survival. But I think what's most important to recognize is that some of these variables may be modifiable, and therefore we can look at what we can modify to improve surgical risk going into LVAD implant. So for example, if you have a patient who's very congested with an elevated BUN and cardiorenal syndrome as a result of being congested, diuresing that patient so that their sodium improves, their renal function improves, they may be lower risk than going into LVAD implant than they otherwise would have been. Now I'm going to shift gears a little bit and talk about the complications after LVAD implant. So what are the early complications that we see within the first 3 months of LVAD implant? So bleeding, stroke, device malfunction or thrombosis, infection, and rehospitalization. And really the most common events are bleeding, infection, and rehospitalization. And that's pretty consistent across different age groups. Now just focusing on the HeartMate 3 patients. So again, you can see that bleeding and infection are the most common adverse events after LVAD implant. But this is data from the Momentum 3 follow-up, and you can see that when we compare patients with a centrifugal flow pump, the HeartMate 3, and patients with a HeartMate 2 axial flow pump, the rates of hemocompatibility-related adverse events are significantly lower in the HeartMate 3 device group. So much less bleeding, stroke, and then pump thrombosis. And that's really one of the most significant reasons why this device has emerged as the device of choice and the only device that we're currently implanting. Now shifting gears a little bit to conditional survival. This is data that I worked on when I was a heart failure fellow here with Justin Groden. We did analysis of patients in the Intermax registry who had received a destination continuous flow device. And essentially what we looked at was for patients who had one of these risk factors and had already survived 0, 1, 2, or 3 years after device implant, what was their additional 1-year event-free survival? And we defined event-free survival as survival free of device exchange or removal or transplantation. And so patients who were either female sex, Intermax profile 1, had device within 48 hours of implant, or had prior cardiac surgery, if they had survived 0 years after device implant, had a lower additional 1-year survival. However, once those patients made it to 1, or especially for the Intermax profile 1 group, 2 or 3 years after implant, that difference in survival went away. So essentially, if they survived that high-risk year after implant, their survival additionally in additional years was the same. And now looking at adverse events. So we, again, looked at conditional survival. And so we looked at patients who had experienced an adverse event during their first year after LVAD implant, but then survived that year. And then at 1, 2, and 3 years, what was their additional event-free survival? So for patients who experienced GI bleeding or renal dysfunction, there was really no difference in additional 1-year survival at 1, 2, or 3 years after device implant. However, for patients who experienced a stroke or device complication within the first year, there was a difference in additional 1-year event-free survival at that first year. But that difference went away by the time they'd survived 2 years after device implant. Importantly, and we already talked about how device-related infections are such an important complication after LVAD implant, but for patients who had a device-related infection during the first year, even if they survived to 2, 3 years after device implant, that difference in survival remained. And so that probably just reflects that once patients develop a device-related infection, that can be very challenging to treat, and we may never fully eliminate that infection. So in summary, 5-year survival after HeartMate 3 implant is 58.4% overall, but it can be as good as 77% in low-risk individuals. The majority of patients who are alive on LVAD support at 5 years enjoy great functional status and have minimal heart failure symptoms. And then it's important to be cognizant of the pre-implant risk factors that influence early and late survival after LVAD. And the complications after LVAD include bleeding, stroke, pump thrombosis, and infections, but we've seen that hemocompatibility-related adverse events are seen much less frequently with the HeartMate 3 device. And patients who survive the first year after LVAD implant, even if they experience an adverse event within that year, have similar additional 1-year survival except in the case of device infection. Thank you. And now I'd like to introduce Katie Ginder. She's one of our amazing NPs, and she's the Inpatient Cardiology APP Manager.
Hi, everyone. How are we doing? Thank you to everyone online and in person who have made it this far. Before we jump into our panel discussion, I am going to go over our inpatient APP team, and then Melanie Thomas will follow me and talk about the APP management in the ambulatory setting for our LVAD patients. So just thinking about our inpatient advanced heart failure transplant and LVAD team, it's very complex, but we have a wide range from a multidisciplinary approach. We have our advanced heart failure transplant cardiologist. We have 2 advanced heart failure fellows, 2 APPs Monday through Friday, 1 APP on Saturday and Sunday. We have our bedside nurses who our whole team relies on a lot. We have our transplant pharmacist who rounds with us daily. We have our inpatient transplant coordinator who helps us with everything from the pre-transplant evaluation and management after they receive their transplant. We have our transplant social worker, floor care coordinators, and then our P navigators who help us with all the scheduling and appointments after discharge. So this is just a depiction, thinking back when I started here at UT Southwestern about 9 years ago, close to 10. We had 2 APPs for our advanced heart failure VAD and transplant team. And from this picture, you can see while it is an inpatient cardiology service line, we have close to 20 APPs now, which is a very amazing growth that we're all very proud of. But looking at specifically the middle box, the heart transplant team, this shows that we have 2 APPs per day. They care for transplant patients with an average census of 12 to 16. And then we have our advanced heart failure and LVAD team that also has 2 APPs per day with an average census of 12 to 16. And then we have a nocturnal service that really cross covers all our patients from the cardiology, advanced heart failure, LVAD, and transplant service line. And you can see here they cross cover an average of 36 to 48 patients, and they admit for us at night between the hours of 7 p.m. to 7 a.m. So why advanced practice providers? I think it's really important to highlight the care that advanced practice providers give. We're able to perform comprehensive assessments. We develop and manage treatment plans. We can order and interpret diagnostic tests. We prescribe medications including GDMT or optimal medical therapy, immunosuppressants and anticoagulants in all our heart failure, transplant, and LVAD patients. We can manage complex cardiovascular therapies. Most importantly, coordinate multidisciplinary care for our patients, provide patient and family education, and then provide the continuity of care that our patients need in the inpatient setting. Again, this is just a different depiction, but I think what's important to see here is the continuity of care. With having a dedicated APP inpatient team, they're really able to see the care through from beginning or admission to discharge of these patients. We have developed a specialized clinical expertise, specifically in the field of advanced heart failure, VAD, and transplant. We provide an efficient workflow and throughput. We have a multidisciplinary integration and approach working with care coordinators, transplant coordinators, LVAD coordinators, bedside nurses, physicians, fellows, dietitians, physical therapists. With our new model for our care here at UT Southwestern, we're able to provide 24/7 coverage and a clinical presence in the hospital and able to have a first call provider for all of these very complex patients. And then I think most importantly, as APPs, we provide a patient-centered approach with education and support to the patients and their family members. So here, just highlighting the role of the inpatient APPs, I incorporated here transplant APPs, advanced heart failure LVAD team. Really, again, we're all one team, and our model is that we rotate between our 2 inpatient teams, but you can see here we partake in pre-transplant evaluation and management. We manage and monitor infections, manage and treat acute cellular and antibody-mediated rejection. We manage up titration or weaning of inotropes, LVAD complications, pre-LVAD evaluations. But in the middle, you can see that we all kind of do the same thing as far as admitting and discharging, readmissions, comprehensive assessments, and then care coordination. So one thing that I think is important to share with everyone here is just thinking about how do we set our APPs up for success in heart failure in general, or for the advanced heart failure LVAD transplant specialty. For me, I think that's ensuring that we have an adequate orientation. Most of the data for orientation and onboarding suggest a 12-week minimum. I think also understanding the limitations that advanced practice providers may have in their specialty. So providing didactic education should be a key point during their orientation. For us, what we focus on is having a guided but self-paced lectures throughout their orientation. We refer everyone and provide them with the best clinical practice guidelines, and then manufacturer-led LVAD trainings to take care of our inpatients. Also, I think thinking about a stepwise approach to patient load. So for most of our APPs undergoing orientation, we start low and kind of work our way up for their patient load. We provide real-time preceptor and physician feedback. And then I think one thing, again, for APPs is just investing in their APP education and growth. So ensuring that we're providing APPs with resources for certifications and to attend conferences. So here, we had all of our APPs work towards getting the heart failure certification through HFSA if they qualified, and then also undergoing the optimal medical therapy training certification. And now I'm going to turn it over to Melanie Thomas, who is our LVAD lead, APP lead.
Thank you, Katie. Hello, everyone. So I am just going to talk a little bit about continuity of care and outpatient management of LVAD, specifically the shared care we do with providers outside of our system. So as Dr. McKellis talked about, there are some limitations of LVAD therapy, but really those have improved with the HeartMate 3. So about 80% of the patients that we manage right now are HeartMate 3 patients and are destination therapy, meaning they're not transplant candidates at the time they get their VAD. And so obviously our goal is to extend their life and improve, which I think Dr. McKellis presented very eloquently. We're able to achieve that with most of our patients. We also want to resume them on their heart failure management, which is where community providers also come in, which I'll talk about in later slides. I think something exciting about the HeartMate 3 is that it is we no longer use LVAD as the primary indication for aspirin in these patients. So as Dr. McKellis pointed out, there is still bleeding as a complication, but we have seen those rates markedly decline in these. Most of our patients are able to return to a normal lifestyle. So their quality of life at 3 to 6 months post-discharge is markedly improved. And as Dr. McKellis said, we are able to return most patients to an NYHA class 1. So we have patients who work, care for young children, exercise, go on vacation, drive cars. There really is a very short list of things that they cannot do. Which is mainly being submerged in water. Driveline infection is still a risk, and they are carrying electrical components outside of their body. But they can shower, and like I said, they can do most things that they find to be quality of life. The most common adverse events, I won't belabor that since Dr. McKellis talked about it, but again, the bleeding rate, specifically major bleeding. So rehospitalization, death, or going back to the OR is much lower in the HeartMate 3, and even now after the ARIES trial when we discontinued aspirin as a primary indication. So just a little bit about inpatient management. So as Katie spoke about, we have a lot of APPs and of course our amazing heart failure attendings, but we also use pharmacists, social workers, physical therapy who are all LVAD trained. Our goal is that most patients are inpatient for about 18 days after implant. The national average is 20, and we are actually sitting right at 23 right now in our program. A lot of that has to do with the time patients are referred to us. So obviously those patients who come in cardiogenic shock are gonna have a longer post-implant length of stay. As Katie mentioned, we want to get them back on their heart failure therapy, off of inotropes. We want them to be walking without assistive devices if at all possible by the time they leave. They get teaching from the dietitian, the LVAD coordinator, pharmacist. And then of course we normally do a heart cath and TTEs after to ensure that they are optimized on their LVAD therapy, and we initiate them on warfarin. As Dr. McKellis mentioned, readmissions a lot of times are not directly LVAD related. So we do still have some non-compliance in these patients. So we do see patients come in for infection or decompensated heart failure, but that's often much lower in this patient population than they did pre-VAD. And so this is just what LVAD patients will be wearing when you see them. Obviously, they have to be connected to a power source at all times. So I just included the HeartMate power sources on here since that's the majority of our population. They wear 2 batteries that are connected to a controller on their body at all times. A pair of batteries is gonna last them upwards of 15 hours. So most of our patients wake up in the morning, they sleep on wall power, they put themselves on 2 batteries, which they carry in a vest or a bag, and then they go about their way. I actually had somebody say, oh my gosh, I saw one of your patients in the lab the other day and I didn't realize they even had an LVAD because their bag was so small. So the goal is to really be discreet and minimize what patients have to manage. After discharge, so again, the continuity of care. So our heart failure attendings manage these patients, both inpatient, outpatient, cath lab. We do have our inpatient APP team that Katie spoke about, and then they transition to an outpatient APP team that I lead. And so we see them weekly at the beginning. And then really what we're doing is a lot of heart failure and post-surgical management. So as I said, they don't have a lot of LVAD related complications. We really want to manage their preload and afterload, and we want to keep their mean arterial pressure, which we use instead of a systolic and diastolic, between 65 and 85. So again, we're really using that heart failure management. A lot of our patients are not pulsatile. So when they come in, we will take their pressure with a Doppler, and then we also notify their local EMS of them being in the community, and we send them handouts about, you know, if they do call 911 or if they pass out, of course, someone's going to try to feel their pulse. So we ask them to wear a medical bracelet, and they each carry a QR code on their equipment bag with them, that if someone scans it, it takes them to emergency management of LVAD patients. And so just the way we kind of manage them is a little different, and we try to educate the community on that. So one of the big points I wanted to highlight with you all here is our shared care. So our goal is to get LVAD patients back in the community, back to their referring provider, obviously, as long as it's a mutually preferred relationship. So in the past, we used to have a lot of referring say, oh, nope, once you have an LVAD, I don't want you to come back. And we would love for them to continue to follow. I actually had a patient who told me he went to his PCP, and his PCP said, oh, you can't come here anymore now that you have an LVAD. And he said, no, my LVAD team told me to come here, and he gave him the IFU, the instructions for use, which is a 300-page book, and asked him to read it. And so it's really funny, but and the PCP did accept him back. But to manage these patients, you don't have to be classically trained in LVAD and have a certification and have LVAD equipment in your office. Really, we want them to continue to get normal healthcare maintenance, their vaccinations, their annual screenings, and even we want them to get heart failure management with their referring cardiologist or electrophysiologist, if that is something that you are interested in. So all of our attendings give out their cell phone numbers. We give out our cell phone numbers, and we try to really keep those relationships intact, because the goal is that these patients live longer. They're going to need to seek care in the community for longer, and we want people to feel more comfortable with managing these patients so they can really have an access to a variety of services that they really need. And then, of course, we do outreach visits a lot to our community providers because we love to take patients back, like my patient did to his PCP, because there can be a negative view of LVAD patients, of the survival, especially living in the era of the old pumps, where we remember the complication rates from the old pumps. And so we really want patients to go back into the community, share how good they look. So really that can hopefully save other people who can eventually get referred for LVAD therapy and live a nice life with that. So that is all I have. We're going to take a short break, but if you have questions for any of the speakers, just kidding. If you have any questions, you can scan the QR code and they will come up. And that is not just for our talk, that's for any of the panelists who presented.
Okay, those were all fabulous talks. I mean, I'm always impressed to work with all of you on a daily basis. I think that goes without say. So here's a question that is from online. I think this is probably going to go for everyone. Can you please comment, or what are your thoughts, or at least share your thoughts on the Bivacor TAH? All right, I see a slouch and I see a giggle. We'll start with the slouch, then we'll move to the giggle, and we'll just go down the line. I think.
Anyway, so it's a total artificial heart. It's a maglev therapy, just the way the HeartMate 3 is. It replaces the entire heart, pretty much. If I recall, it's a biatrial cuff. As Texas Heart Institute has done 5. They've been extended to 15. It's a bridge to transplant. The data was shown at ISHLT. Did you happen to go? I did. I think they're all survived. Okay, Chris, tell me. Yeah, they're. Yeah. So I would love to do that here. I think it's super cool and exciting and interesting. Who would be a patient that Catherine, you would consider for a Bivacor over a VA ECMO or KVAD ECMO or something like that?
So I think with that device, So you can support somebody in biventricular heart failure, so that's helpful. I think you still have to be worried about thrombotic complications with that device. So potentially that's an issue. I think sometimes also with comparing that versus ECMO, a little bit of the center's experience with that mode of support is also important to take into account, but I'm sure it's something that we could get more experience with and get people more comfortable with too.
And maybe Chris chime in. The older total artificial heart, which I did have experience with, one of the things that we saw is when you remove most of the atria, you lose the natriuretic peptide secretion capability of the heart. And in so doing, you lose the vasodilating signals to the kidney. So a lot of these folks go into kidney failure. Justin, want to bite? Yeah. What do you think about that? I don't know that there's a signal on that. Do you know?
I think you're stealing one of my favorite.
I know.
If you answer this question right, I'll buy you a steak dinner.
Exactly.
Questions on rounds. Yeah, that's right. And the serotype is where you're going.
That's right.
Yeah, one of the few existing uses for that drug.
Yeah.
I think, but maybe the thematic question is RV failure and in how maybe that device offers hope for it. So maybe dovetailing with that, maybe some practical considerations, maybe from Melanie, Katie, what is your approach to really chronic? I mean, we all know about acute RV failure but what about once these patients have made it, to the ambulatory setting? What do you do to manage that? And what are some of the, what are some of the issues, the logistics, and some of the complications with managing chronic RV failure?
I think initially in the post-op period, one of the things that we try to do is a slow inotrope wean. I think volume management is key. And then making sure they have the right LVAD speed and able to support the RV and the LV. In some cases, we do start sildenafil, controversial maybe, but I think the slow inotrope wean, and for some of the patients, we do discharge them on the sildenafil, and then Melanie and her team will try to wean that off as able. Those are kind of my initial thoughts. I don't know. Yeah.
So obviously the goal is for our patients not to have right heart failure, but what we will do is we will do right heart casts with what's called a ramp study to make sure, as Katie alluded to, that their speed is appropriate and that they're well supported by their LVAD. We continue to try to manage their diuretics. If we have uptrending doses, worsening end organ function, then we always refer those patients inpatient to try to mitigate any chronic right heart failure. And very few of our patients actually end up on inotropes post-VAD. That's never the goal for us. And then, of course, if transplant is a consideration, we want to make sure that we're working them towards transplant so that they can get that support.
Maybe add something. I'm going to ask Dr. Truby a question. So in one of the HeartMate 3 risk score variables was a right atrial pressure pulmonary capillary wedge ratio of greater than 0.6. And you identified that also in a number of cohorts as a subclinical risk for PGD.
Yeah, that's a great point. It was something actually we initially observed when we were at fashion was that, in a contemporary setting where we had high rates of severe PGD, there was a higher prevalence of the phenomenon within our LVAD patients. And then among those patients, we tried to understand who are the high-risk LVAD patients going into surgery that would potentially come out, on ECMO. And there were a number of different signals for sort of subclinical RV dysfunction as being potentially the causal link, though we couldn't prove causality. We were only proving correlation. But CVP to wedge ratio, which obviously we used to risk stratify patients prior to VAD, came out as a signal, as well as time on device, which we know that many of our LVAD patients over time will develop some, based on Intermax data, will develop some element of subclinical RV dysfunction the longer they're on device. And then other things like renal function, which may be related to congestion from RV dysfunction, and amiodarone use, which may or may not be directly related if we're sort of using the amiodarone for VTVF that's being driven by RV failure. So there were a number of different signals as to why there may be a link between subclinical RV dysfunction and severe PGD. You know, one may hypothesize that there's some quote unquote kind of bad humors or sort of pro-inflammatory milieu that would come from a more congested liver going into the operating room. And there is some sort of translational data that may suggest that that's sort of the causal mechanism, but we need sort of more research to really better understand it.
I just want to Melanie as the LVAD coordinator. So a lot of times when I am evaluating somebody for advanced therapies and I bring up the idea of LVAD versus transplant, the idea of LVAD is very foreign to them and they kind of immediately want to go for transplant, not recognizing that there are risks after transplant as well. What are some things that you talk about with patients to help get them used to the idea of an LVAD or feel more comfortable about it?
Why do you want to get me on a soapbox? So when I go to talk to patients about LVAD, the first thing I ask is, what do you know about an LVAD? And unfortunately, the answer I get most of the time is nothing, which is very unfortunate because normally if I'm seeing you, you're in the hospital and you're in cardiogenic shock and you've had heart failure for some time. And so it is very hard for them to digest that. And so I really think, number one, if we can get LVAD talked about more in the community, it would be less of a shock and less of a consolation prize when these patients hear about it. But I try to acknowledge, look, nobody wants an LVAD, all right? Nobody wants to carry around batteries. Nobody wants to have a drive line coming out of their abdomen. What I really try to do is share with them the data about that LVAD patients do actually live a good life. And then we actually we have a robust ambassador program, I guess. Abbott has an ambassador program where patients can speak with other patients same day, but we actually go a step farther in that we have our established LVAD patients come over to the hospital or call them or FaceTime them. And 99% of the time, when me and my team walk in, they're like, yeah, well, you don't really know how I feel because you don't have an LVAD. And that's true. When I send a patient to talk to them, the patient's not afraid to lift up their shirt, show them what their dressing looks like, and say, listen, this isn't the best case scenario, but you can live a really good life. And so I find that when I circle back with patients after that, they say, this was not what I was expecting at all after talking to the patient. And while they're still not excited about LVAD, they're much more open to the therapy.
So I want to hijack this with one last question. This one's for Dr. Farr. So I think this question's a real ham. I don't mean to be a bore to everybody in the audience, but could you please tell us about the next frontier, specifically xenotransplantation with porcine organs?
So, all right, xenotransplant. So there's been 2 adult heart transplants with xenotransplant. Neither lived for very long. You know, the historical way in which xenotransplant has been studied is in what's called a non-human primate model. So, animal to animal, or macaque monkey to chimpanzee, something like that. But there's another model called the decedent model, and the work has been done at NYU, kidney and heart, and now Mass General for kidney. And that is that there's a donor, there's a family who said, I would like my loved one to donate their body to science, and then for 48 to 72 hours, that donor, instead of donating organs, they may not be suitable otherwise, will receive a xenotransplant, either a heart or a kidney, and then that donor will be kept alive, and there will be an analysis of their blood markers, infections, biopsies of the heart or the kidney. And an enormous amount of work has been done to better understand how to tailor the gene knockouts and so forth of the pig kidney or heart. And there are actually now 2, I think, at Mass General who've had a kidney transplant, xeno kidney. One left the hospital and died a few months later, but from a myocardial infarction and not kidney failure. And now there's a second. And actually, NYU has one too. And actually, she was LVAD xeno kidney. So cool stuff. An FDA trial has just been approved for kidney xeno. Heart is on the horizon. This is primarily going to be started probably with pediatric or neonate children where there's absolutely no donor organs. You know, there are, you know, our ability to take care of our 3-year-olds is extraordinary with helmets and all kinds of safety measures that we don't have a donation pool of children hearts. And what a wonderful thing, except there are lots of children who have congenital heart disease, and we're just gearing up for Kate's lecture next.
Okay, it's been a terrific day. We are on the home stretch. So it is my pleasure to announce our last speaker, Dr. Catherine Kearney, and she holds a very unique role where she's kind of bridges the gap, at least for our group, where, you know, she's got this kind of strange, wonderful marriage between adult congenital heart disease and advanced heart failure management. So the topics that she's going to be discussing today are actually quite unique. And I'm really excited to hear her speak. Kate?
Thank you. Oh, thank you to everyone for sticking around for the very last talk. I super appreciate it. I'm just going to touch on these topics, and I can't really go into depth in like 15 to 20 minutes, but we'll see how we go. So what I'm hoping to address for you a little bit is how big is the problem of ACHD heart failure and who develops it? Is it any different from conventional heart failure? What are some complexities of undertaking advanced heart failure therapies in this patient cohort? And a little bit on risk stratification assessment in ACHD patients. So 1 in 100 babies are born with congenital heart disease. These days, 90% of those born with CHD will live to adulthood. And that means that now the ACHA estimates there's about 2 million adults in the US with congenital heart disease, which is an increase of about 600,000 over the last 10 years. 25% of those born with CHD have complex CHD. And the median survival in these complex CHD patients has improved from 2 years old to 23 years old between 1987 and 2005. So we have a rapidly emerging cohort of 20 and 30-year-old patients with adult congenital heart disease who have complex anatomy and are very much at risk for developing heart failure. There's about 174,000 adults in Texas with CHD, and this is just an ACHA map of the ACHD comprehensive care centers in this region. As you can see, there's not that many for 40 million people in Texas and 174,000 people with CHD. What about the impact of heart failure in ACHD? 30% of all ACHD patients will develop heart failure over their lifetime. The hazard of heart failure in ACHD patients begins much earlier than in the general population and actually portends a worse prognosis. The number of ACHD patients experiencing heart failure admissions and heart failure mortality has increased sharply over the past 10 years, as you can see in the graph on the top. And there is a more modest increase in the number of ACHD patients undergoing heart transplant. So in 2024, 4% of all heart transplants in the US were for ACHD patients, so 168 patients. What are some of the challenges? The trajectory of these patients can be quite non-linear, and heart failure can be quite insidious in onset, and it can be difficult to define exactly when someone has gone into heart failure. They've always been limited, they've always had complex CHD. What's the point at which they actually slip into heart failure and need to be considered for advanced heart failure therapies? There are diagnosis-specific mortalities, and given the complexity of anatomy and physiology that different patients have, this can be, quite challenging to predict. Psychological preparedness in these younger patients, some of whom will have neurodevelopmental challenges, either from syndromes, from early era cardiopulmonary bypass, stroke, anything like that. There's little evidence for GDMT in many of these patients, and we just don't have strategies for mitigating the heart failure and sort of keeping the need for advanced heart failure therapies at bay. Surgical complexity is very real in these complex anatomies. Cardiometabolic risk factors, as for the rest of the community, they affect our patients as much as everyone else. I'll speak a little more about that. Sensitization is a huge issue. I'm sure everyone who's worked in heart failure for even a short period of time has probably had their heart broken by like a young, highly sensitized congenital heart disease patient, and addressing the upstream factors for that and preventing that situation developing is really important. The systemic complications look a little different. It's more likely to involve the liver. It can involve the neurology, that sort of thing. And there's an impact of pregnancy, obviously, in looking at advanced heart failure therapies and heart failure in women of reproductive age. So who is at risk? Those with single ventricle physiology, 1.5 ventricle physiology, so that's someone who's had a biventricular repair that has a Glenn shunt from their SVC to their pulmonary artery. Kind of halfway in between single and biventricular physiology. Those with unrepaired cyanotic congenital heart disease, biventricular circulations who have a subaortic RV, so CCTGA or congenitally corrected TGA or LTGA is the other term for that. Those who've had an atrial switch operation, a mustard or a Senning, and even biventricular patients with a subaortic LV are similar to conventional heart failure patients at risk of developing heart failure. And specific subsets with increased risk would be tetralogy of Fallot, where there's a risk of non-compaction LV cardiomyopathy, those with cardiometabolic risk factors as for the rest of the community, Epstein anomaly, which is primarily a right ventricular cardiomyopathy, and those who have complex repairs with restrictive RVs, especially tunnels through a VSD to a pulmonary artery and RVPA conduit, Rastelli repairs, that sort of thing. There are some specific risk factors. These are very condition specific, so I'll just talk a little bit about Fontane's as systemic RVs. We have a higher index of suspicion for heart failure in those who have a permanent pacemaker, especially those who are predominantly V-paced. Junctional bradycardia, atrial tachyarrhythmias. We know those with the systemic RV do worse than a systemic LV in the Fontane population. Protein-losing enteropathy, lymphatic dysfunction, including plastic bronchitis, severe AV valve regurgitation. Cyanosis is a predictor of mortality pre and post-transplant, and those with an elevated TPG leads to a suboptimal function of the Fontane circuit. For a systemic RV, there's long-term V-paced is a problem in these patients, and severe TR, amongst other things. So just to speak further about that, the point of this slide is just to say that a Fontane failure is not necessarily intracardiac, even though it's still heart failure. The majority of it is actually not cardiac or systemic ventricular dysfunction, although that can occur. Extracardiac dysfunction, Fontane pathway dysfunction, which can be mechanical obstruction or just pathway dysfunction, and lymphatic dysfunction are all important modalities of Fontane circulatory failure that we need to kind of wrap our heads around a little bit when looking at circulatory failure in these patients. What about the trajectory? So insidious onset, as I said. And because of this heterogeneity of anatomy and physiology, the standard heart failure prediction tools don't really help us very much. And ACHD-specific heart failure prediction models are really challenging to develop in these small populations because what applies to a Fontane does not necessarily apply to a 1.5 ventricle, does not necessarily apply to CCTGA. There's certainly a phenotypic difference between early and late failure. I mean, early Fontane failure in the pediatric world is defined as in the first 2 years after Fontane completion, but seeing a lot of these patients, there is a physiological difference between the phenotype of a 40-year-old AP Fontane who has been very healthy for 30 years and slowly declined over the last 10, versus a 20-year-old extracardiac Fontane who has always had severe PLE and has never really thrived. To speak a little bit about Fontane-associated liver disease, just to note that the mechanism of development of fold in Fontane patients is through chronic passive congestion of zone 3 hepatocytes. This is kind of markedly different from the zone 1 hepatic damage that occurs in the viral hepatitis. This leads to sinusoidal dilatation, reductions in portal venous flow, and congestion results in fibrosis through this kind of metabolic pathways. All of this means that there's a cumulative risk of HCC of 13%, like hepatocellular carcinoma, 13% at 30 years post-Fontane. We screen regularly for these patients. This is the reason that we are constantly talking about multi-organ combined heart-liver transplant in Fontane patients. That could be a symposium in itself. No one really agrees where the line should be drawn there. In general, it's probably where there's portal hypertension, but it's an ongoing problem and just an ongoing source of discussion. No one's conclusively answered the question. And it probably looks different for different programs as well. What about protein-losing enteropathy? So this is kind of a complex multifactorial problem. Etiology includes elevated hepatic venous pressure. It's kind of straightforward to think about. Reduced intestinal perfusion, which kind of develops in this pro-inflammatory state, and this is why budesonide can actually be quite helpful for some patients with PLE. Diminished heparan sulfate proteoglycans on the enterocyte membrane, and lymphatic congestion and dysfunction. Complications that, we need to be very mindful of are immunocompromise, hypogammaglobulinemia and lymphopenia, and secondary hypoparathyroidism exacerbated by long-term steroids as well in those patients who have those. There is a number of different ways of treating PLE, and there's not a lot of consensus on how to do it. This is an approach, just to think about Fontan circuit optimization first, pathway obstruction relief, diuretics. Some patients have an exquisite response to very high dose spironolactone. The mechanism of action of that is a little bit unclear. Pulmonary vasodilator if the TPG is elevated. We then move on to layering of PLE-specific medications, budesonide steroid, midodrine, it's kind of oral options. And then as a last resort, further layering of PLE-specific medications, octreotide and subcardioheparin. Just to say the impact of cardiometabolic risk factors is similar to the general population. However, there is more arterial hypertension, diabetes, and psychological disorders in our patient cohort. This is important to think about in CHD patients, even though we often as ACHD people, it's not as front of mind as it might be. As a heart failure person, it can be a real value add. Pregnancy, obviously these are younger patients, so in reproductive age, preconception counselling is really important, both the risk of heart failure and decompensation during pregnancy for those at high risk, but also the risk of sensitisation, access to advanced heart failure therapies, and informing people about that before they make decisions to try and carry a baby, especially if the risk of having a miscarriage is low because of cyanosis and things like that. Our ACHD patients are more sensitised than the general population. This is an analysis from the ISHRT database of the percentage of CHD versus non-CHD at every level of pan-reactive antibody categorisation. They are more sensitised. This can be due to blood products that have been given during surgeries, homograph material that's been part of constructions, a part of surgical reconstructions, pregnancies and miscarriages. And we have to consider that those with PLE may have lost immunoglobulin and antibodies, and they may be more sensitised than we actually appreciate on their antibody screens. So I think shared decision-making is really important in this cohort. Sharing uncertainty of timelines with high-risk ACHD patients many years and ideally decades before they become unwell can really be very helpful with them. Exploring the entire patient journey in a supportive environment, including the expectation that this will encompass the development of heart failure, allows time for them to psychologically calibrate to this kind of reality. In context of ACHD transplant, this far distant centre to Purdue work is vital because clinical decisions, life choices and psychosocial factors at play in early adulthood have implications for both heart failure trajectory and later transplant candidacy. It's only when both patients and care providers appreciate this that decisions can be made and supports put in place to protect the longest term outcome. This safeguards the option of successful transplant should this be something that the patient eventually desires. What about the role of GDMT? In LV failure in biventricular circulation, that's fairly straightforward. We use GDMT as we would in any other patient. In subpulmonic right ventricular failure, subaortic right ventricular failure, it's meant to say, apologies. In biventricular circulation, there's limited evidence for ARNI, ACE and ARBs, and a concern for beta blockers pushing towards a greater degree of pacing, which can precipitate decline. In single ventricles, there's very limited evidence, although we would try it in someone who had systemic left ventricular failure. What about ACHD and transplant? So transplant is effective therapy for ACHD heart failure, improving survival outcomes by 3 to 4 times in recipients, as compared to those who were declined at the time of assessment. Early year outcomes were poor, but are improving with more experience and consolidation of ACHD transplant into experienced centres, as well as recommendations from ISHLT for transplant at centres with both ACHD and advanced heart failure transplant units. There remains an early mortality cost with better 1-year conditional survival for CHD patients in comparison to DCM. And my biased view is obviously that this is the way in which we improve the long-term mortality in heart transplant patients by putting more organs at the right time into patients who are younger and will live longer. So what about risk stratification? As mentioned already, conventional risk stratification tools are challenging to apply to the diversity of CHD anatomy and physiology. Trajectory is unpredictable. However, we can anticipate that entire groups of ACHD patients, if they do not undertake advanced heart failure therapies, are at significant risk of dying in mid-adulthood. A new way that people are starting to think about this, and Schumacher published a really lovely paper on this in Pediatric Fontan. So the concept is important to take. The exact lessons from that study might not be as applicable in an adult population, or to consider the quantitation of risk through the accumulation of comorbidities. So risk factors for 1 year post-heart transplant mortality in a pediatric Fontan population included those with a HLHS diagnosis, hypoplastic left heart syndrome, fenestration, anatomic Fontan obstruction, clinical cyanosis, polycythemia, portal variceal disease, psychiatric disease, and a high degree of sensitization, specifically class 2 antibodies. How are we doing? What are we doing to address this here? This is a depiction of the sort of collaborative team that UT Southwestern uses to kind of address this problem. The aim is to really utilise our institutional expertise, of which there is a lot, across different domains, into a dedicated team to improve outcomes in ACHD patients with advanced heart failure. And this is not an exhaustive list of all the people involved in that particular picture. I think the main takeaway is it is a big team. We pull in the expertise that is needed for each individual patient, those with liver disease, those with sensitization, etc. But the patient is centered at the middle of that. The outcomes of optimization of evaluations for complex patients, provide recommendations on heart failure optimization and strategy, and that's where the ACHD section has a big role in that. And early identification of challenges. We also have monthly meetings with Children's Medical Centre, which is a very prolific congenital surgical centre, pooling expertise and resources on complex congenital patients across the paediatric and adult spectrum. And I think this is really valuable for us. So a few takeaways. ACHD heart failure is a growing problem. ACHD heart failure clinicians are an emerging field, but that will not solve the problem. It's going to require working together of a broad range of people across a broad range of disciplines. There are many unique challenges requiring novel approaches that are often multidisciplinary. Coordination between these teams is key, and considering the accumulation of risk factors, which are often non-traditional compared with conventional heart failure, is critical to accurately assessing risks in this population. Thank you. If we have time.
I don't have in chest. Any questions or comments here from this audience? We still have 67 online, but I don't know if we have a chat for them. Do we? Anything here? Any questions folks have? Yeah.
So that was a terrific talk. You know, one question that always comes along, and as you know, that a lot of these individuals get atrial arrhythmias, right? AFib, atrial flutter, 5 different kinds of atrial flutter coming from different places. How does that color or influence your appraisal of their severity of illness? And is that something that might be lesion specific?
I think absolutely, unfortunately, everything is lesion specific in congenital heart disease. I mean, specifically in the single ventricle cohort, atrial tachyarrhythmias in the pediatric population are emergency. In the way that we treat VTVF, they treat atrial arrhythmia. It's not as urgent in the adult world, and there are a few patients who I've seen who've just been in chronic AF in particular. They're not thriving in that state. You really do need your atrial kick if you're relying on like a single ventricle. But it does portend a bad prognosis, and the need for repeated ablations is really challenging. I think it's important for us to think about moving away from it, as most of these problems in the single ventricle circulation relate to the old AP Fontans, where the right atrium is connected to the pulmonary artery, which is better for flow dynamics, but does lead to a lot of dilatation and like a ton of arrhythmia. It's important to think about Fontan conversion, but after the age of about 25, that ship has sailed. You know, no one's going to look at it. So in our aging populations, we are really only left with transplant, and we do have to think about a balance between what is holding off transplant for as long as we can with ablations and medication strategies, but what is not leaving it too long. There's a case in the literature of a patient who had so much ablation in the pre-transplant period that they'd created an esophageal fistula that actually caused mortality in about a month after transplant, which is, I think, brave for people to write up, but important. You can go too far in trying to balance those risks.
So we're going to wrap up. I think first and foremost, we'd like to thank all of you who've attended here in person and the, just 67 or so plus who are online. and stayed with us. We all obviously work extremely hard, all of us. This is why we're here, talking to each other, listening to each other to try to do better in our areas of expertise and burgeoning expertise. So thank you for your Saturday. It's been our pleasure. We have to thank so many people. Sarah McCoy, please come up here. You are our senior project manager of the cardiovascular service line and transplant, who literally did everything, with Kristen Dupont, our chief marketing person, who had to go coach volleyball, the second part of her day. Claire Dempsey, also one of our senior project managers, Trish Narain, and where's our, and Lisa Hausman from CME, and of course, Ashley Bradley, who is our just unbelievable outreach person throughout Texas. So as you can see from our team, we are super collaborative. We are very, very interested in all of the places that people live in Texas. We are out there, our cell phones are on, and the more and more we collaborate with you, the more enriching our lives are, and the better our patients are. So thank you so much for your time.